Consultant Pediatric Cardiologist, KIMS Cuddles, to give a brief introduction about the program.
Thanks, Arvinda. Again, I welcome you all for this CME. This was Aparna's plan, and I stuck with her actually. So, because she is very interested in teaching, although I am, but I today some years I took a back, but now with that Aparna's push also, I thought we'll again continue and do something. So this is there are three ways to do it actually. One is some lectures, but all the case-based scenario. I always think the case-based scenario things are always better rather than just the didactic lecture. So that's what we did X-ray, which is more interactive. Like we did the panel discussion for the critical NICU, PICU, how to do, and that all with the actual case what we deal here. And the third and the fourth most important is a postgraduate case scenario. Because these are the case which comes to your exam on the daily life, how to do the DD, how to take clues from the X-ray, ECG, clinical signs. So, and apart from the 2-3 interesting topics which are relevant like arrhythmia, because I always feel the rhythm disturbances is giving palpitation to cardiologists as well as for the pediatricians also. So that's why how to treat that rhythm, that is one. And second thing, the update of the Kawasaki with the COVID, there is an overlap of MISC, viral pneumonia, Kawasaki. So how to go ahead with that? And apart from that, the fetal, the Dr. Chinmay, she is very well known. So how the fetal diagnosis make an impact? It's make a both impact. It's a good way, bad way, because sometimes people with the small treatable lesion also will get aborted. But sometimes if you miss something, it will be litigation also on how to treat those like TAPVC, VSD, vascular. They are easily missed by the even by the best obstetrician or best radiologist as well as the cardiologist. So this program designed for the one topic of fetal, one of the normal thing like X-ray and your Kawasaki disease management, arrhythmia, two case scenarios, one cyanotic, acyanotic, as well as panel discussion for the critically ill NICU and PICU. This is very interactive. Wherever you want to interrupt, when you want to ask, we are there, and it should be a healthy discussion. Whatever is that you ask, we are trying to justify all your queries, and we'll thought okay, at least you will go ahead with some knowledge, and we also learn from you okay, what the question is, how to deal with that. So with that, I welcome you all, and I tell Aparna to proceed with the first thing, and Arvinda to tell what we are about to do. Although first was Dr. Chinmay, but I think she's late, so probably we'll start with a case scenario so that some PGs are there, and so we'll go ahead with that one case scenario so that we can stimulate them to learn more with the subsequent topics.
Yes, sir. Thank you, sir. Now I call upon Dr. Shruti Kashyap. She is our DRMB Neonatology first year student. She'll be presenting a case of neonate with cyanosis. I request the chairpersons to be Dr. Sudeep, sir, pediatric cardiologist, and Dr. Nagarajan, sir, pediatric cardiac anesthetist, to be the chairpersons. Shruti, presentation. Come here.
Then we can discuss from the pediatrician point of view also.
Not coming. Not coming.
You can make it quick for 10 minutes. Then what are the points in discussing? If anyone wants to ask anything, you can tell us. We can discuss really about how to go ahead with the cyanosis patient. First of all, very common question. I'll start. What is the day one cause of cyanosis? Because so many neonate come to you on the day one, you have to see whether it's a peripheral cyanosis or central cyanosis. Which is the best site to look for central cyanosis? tongue, back of the tongue. Okay. So because so many of the kids coming with the lip cyanosis, but that is all peripheral cyanosis. Once you make it the warm, or if the tongue is not involved, check the saturation. If it's more than 95, that means it's not a central cyanosis, it's a peripheral cyanosis. Okay. So day one cause of cyanosis, Shruti will ask you only.
1 minute, sir.
So day one cause of central cyanosis. Anyone? Anyone can also answer. See, there are two ways to look after: cardiac cause, non-cardiac cause. So what are the non-cardiac causes? You know better than us actually. RDS, birth asphyxia, means respiratory drive is issues, chest deformity, congenital pneumonia, congenital diaphragmatic, and all those will causing PH as well as cyanosis. Third, cardiac cause. What are the day one cause for cardiac cyanosis?
TAPVCs, TGAs.
Okay, for you, the most common congenital cyanotic heart disease at birth is TGA. Okay, most common overall cyanotic congenital heart disease is top.
Etiology of
Most common congenital heart disease except preterm if you leave. So VSD. Otherwise, it's if you include PDA or preterm also, it's a PDA. These are the general thing. Okay, so day one. TGA, then
TAPVC.
obstructed, non-obstructed.
Obstructed.
Okay, that is the first thing you have to tell. Okay, then
Hypoplastic left heart syndrome, critical aortic stenosis.
I ask you the cyanotic heart disease. It's a duct dependent.
Duct dependent lesions, pulmonary atresia.
But they will not present usually on
first day. Yes, sir. After the duct starts to close.
So then complex heart disease, heterotaxy syndrome, single ventricle, tricuspid atresia. Okay, and then TAPVC, TGA. So these are the 5 most common. You can 4 test, that is 4T. That is the thing for the day one cyanosis apart from other things. Okay, then
I think you remember where your pulmonary circulation is critically affected. There you
even the severe, what you are telling, VSD pulmonary atresia, if the duct closes very fast, even they can present on day one. So what you are telling is also duct dependent pulmonary circulation also can present on day one with the severe cyanosis. How you determine the clinical criteria for PPHN? Suppose, what is the clinical criteria for PPHN apart from X-ray? With the pulse oximeter, for the birth history is important. Asphyxia is there, delayed transition. Okay, then what is the clinical criteria to diagnose that?
Difference in saturation and pre and post ductal saturations we must see. Usually we get a more than 10%, 10 difference in pre and post ductal SpO2
values. I think
values.
is too much. Even 5% more than is significant. That means the duct is shunting right to left. Okay.
Some technical issues.
More than 5% is definitely significant. Even some booked at 10%, but if you are 5% is the criteria for step down anywhere. Actually, it's a 2 to 3% difference. But 5% is definitely step down, means that saturation less than 5% upper limb. That means the duct is definitely shunting right to left. So that is the PPHN usually criteria as per your saturation monitoring between upper and lower limb. Okay. So you are ready?
Yes.
Okay, sure.
Yes. Thank you, sir. So this is the case of term-born baby, outborn, who was born to a 27-year-old primary mother with an insignificant antenatal history with good birth weight and good ABGARs. The baby cried immediately at birth, but developed respiratory distress soon after. The attending doctor started the baby on delivery room CPAP, but because of persistent respiratory distress and low saturations, the baby was referred to a nearby higher center. The baby was connected to bubble CPAP, but there was such. They did a chest X-ray, which showed ground glass opacities. So they took the first step of giving the 1 dose of surfactant. Still, they did not find any improvement, and that is when we got a call to shift this case to our hospital. So when we got the call to shift the baby, the impression that we had was that we are dealing with a term neonate with early onset respiratory distress and refractory hypoxemia. At this point of time, we had certain key differentials in our mind. The first one was, of course, pulmonary, that we need to rule out in any newborn baby presenting with respiratory distress since birth. But then there was poor response to oxygen and surfactant, so this seemed a bit unlikely. Next, cardiac, TAPVC and TGA, early cyanosis, refractory hypoxemia. So this was quite likely. Subsequently, we were also thinking in terms of PPHN, but then usually some risk factor is present, and in this case, no clear risk factors were present. Tension pneumothorax, a medical emergency that should always be ruled out, especially in a crashing neonate, and others like sepsis and metabolic also have to be
Just
considered.
one question here. Yeah, how the respiratory distress normal in a preterm and term when you suspect differs? When usually preterm surfactant deficiency distress started?
Usually in the first 6 hours of life,
Okay.
preterm respiratory.
Usually,
Hmm.
if you see TGA and any obstructed like that, what is the difference between the distress of both?
So distress of pulmonary cause will have more severe work of breathing in terms of retractions, grunting,
No.
and
See, the difference is TGA, they are more acidotic.
yes.
So they will have more work of breathing, more
Tachypneas.
acidosis, no less retractions.
Yes.
But all those like pulmonary atresia, they have more work of breathing, sorry, rate of breathing, but the retractions will be very less. That means the acidotic breathing is more with the saturation and the poor perfusion. But in the TAPVC, it will be typical like your RDS, where more retractions, more grunting. So once the mean, what does it mean? When the more parenchyma is involved, more grunting, more distress, more retraction will be there. When only acidosis is there, poor perfusion, then your more tachypnea is there, but the retractions will be very less. So that's why in all top physiology like VSD pulmonary atresia, where duct is closing, they will develop severe cyanosis with more acidosis, more tachypnea rather than retractions. But once the TAPVC is there, HLHS is there, where the more lung congestion is there, so they'll develop more retractions and more cyanosis. And apart with, so that is known as quiet tachypnea in TGA, and the retractions typically is typical when the lung parenchyma is involved. So that is the one. So the crux of here, term baby with RDS. So you have to always think of unusual causes. Usual causes like RDS, meconium aspiration deficiency, these are rare. But the cardiac is one of the most common cause which missed during that is the TAPVC, when the retraction is there not responding to a term neonate with the reticular pattern or ground glass pattern.
Right. So at admission, we found a baby with no dysmorphism. Central cyanosis was present. Transillumination ruled out pneumothorax. The admission temperature was normal. The baby was having tachycardia, tachypnea. The blood pressures were below 5th centile in all 4 limbs. The preductal and postductal saturations were low, 86% in preductal and 83% in postductal, and capillary filling time was prolonged. On cardiovascular examination, we could appreciate normal heart sounds, but tachycardia was also there at that point of time, and we could get a soft systolic murmur of around grade 2 to 3 at the apex. Other findings.
First of all, to get the murmur at this stage is very unusual. Okay, grade 2 to grade 3. So there will be tachycardia, tachypnea, and there will be, you have to take the clue from your pulse oximeter as well as from X-ray. Okay.
On respiratory system examination, the baby had tachypnea with mild subcostal retractions, giving a Downey score of 2. The other findings were normal. The central nervous and abdomen examination was essentially normal. So we went ahead with the working diagnosis of a term AGA male baby with early onset respiratory distress, central cyanosis, poor peripheral perfusions, refractory hypoxemia, most consistent with a critical cyanotic congenital heart disease.
Somebody not responding to oxygen. So what do you think? What test usually will do?
Hyperoxia tests.
Hypoxia test. So what is that hyperoxia test?
Even after giving 100% oxygen for 10 minutes using a hood or a CPAP machine, there is no rise in the PaO2 value. Persistently remains below 100. But if it is a pulmonary cause, it usually rises above 150.
Actually, there's a gray zone. Sometime in TAPVC, the transient it will increase because this will transiently decrease the some PA pressure. So that will more flow. But the flow will be increased, but the saturation improves. So, but in general, what you are telling, hyperoxia test, no improvement, PO2 less than 100, even on 100 oxygen, 100% oxygen for 10 to 20 minutes. That means it's a failed hyperoxia test. That means it's a more suggestive of
heart disease.
Heart disease.
Yes.
So what heart disease you suspect? With that, what I told you.
So at this point of time, sir, these were the cardiac differentials that we had in mind. First of all, this was early cyanosis, severe distress, poor perfusions. So we were thinking firstly in terms of obstructed TAPVC and a remote differential of unobstructed TAPVC. But then again, this is a day one baby presenting with cyanosis in the first day of life. So TGA with a restrictive ASD or PDA was also the second one that we had in mind. These first two were the main ones that we were considering. But TGA, usually the perfusion is well maintained initially. But this was a baby who had come to us with shock.
TGA, the TGA is like that. If the AS is not, they will deteriorate very fast in the 6 to 8 hours. If it's a normal X-ray, within 24 to 48 hours, it go into the gross changes. So TGA, there is a mixing is required at the ASD as well as the PDA level.
Yes.
Whenever these are ASD or small, so they will develop very severe presentation in the beginning. But they are more acidotic, more blue as compared to obstructed TAPVC and others.
Plus, the distress was
Unobstructed, there is a good mixing. So it will not present with severe at that point. It may be tachypneic, but it will not present immediately after birth until sometimes obstruction is at the ASD level. So that also considered to be obstructed. They usually unobstructed, usually not present on day one. ASD is good. So good mixing is there. So they will present even later.
yes. Some non-cardiac causes also we kept in mind at this point of time because there was reticulogranular opacities in the X-ray. So we were thinking in terms of HMD, GB pneumonia, but then again, the background was not suggestive of the same.
GB is common here?
It's not common in India, sir, but
Okay. First have to then reticular pattern. What do you mean by reticular pattern? This is very my favorite question. What is reticular pattern means to you?
net-like.
What does it indicate?
So there,
Same reticular pattern can present in adult?
Yes.
No, it's usually not present. It is a phenomena which present usually in neonate and infants, because what happens when the lung volume is high, the lymphatic drainage will take care. So once in the neonate, lymphatic drainage is very poor. So all the increase, it presents a reticular pattern. Same if you see in adult, there will be haziness. It will not be reticular pattern. Reticular pattern in adult may be related to interstitial lung disease or to be, but it will not related to the pulmonary venous obstruction in adult, because at least by that time your lymphatic drainage will improve. So reticular pattern in a neonate is because of the poor lymphatic drainage, because of the poor lymphatic development in a neonate. And that suggests your group B you leave surface, then it suggests pulmonary venous abnormality or left-sided dysfunction.
Among non-cardiac differentials also, PPHN was something that we should consider while discussing about obstructed TAPVC, but then the difference in the PA pre and post ductal saturation was not suggestive and oxygen lability per se was not there. So how do we approach a cyanosed neonate?
You tell now.
The key points that we should look in the history are, first of all, the onset and progression of cyanosis. If it is since birth, then it might be a structural cardiac condition that we are dealing with. After hours to days, it may be because of PPHN or sepsis that is setting in. Response to oxygen, usually we get a positive response in case of pulmonary disorders or in PPHN, no improvement in case of cardiac disorders. Antenatal and perinatal factors will often give us a clue. But when we are dealing with a cyanotic infant unresponsive to oxygen from birth, definitely we have to suspect cyanotic congenital heart disease. Now, there are certain red flags in the maternal and perinatal history that should make us think twice whether we are dealing with congenital heart disease, such as a diabetic mother, a history of infection in the first trimester of pregnancy, consumption of drugs like retinoic acid, lithium, anticonvulsants, ACE inhibitors, and torch infections in the mother. On general examination, cyanosis is something that we find quite commonly in newborns. So in a sick newborn, especially coming from an outborn setting, when we look into cyanosis and we are thinking in terms of heart disease, we need to see whether it is true central cyanosis or peripheral cyanosis that is happening because of poor perfusion. So like sir said a little while ago, central cyanosis will involve the tongue and the oral mucosa, and we need to be very careful in assessing that, whether if that is present, then it is more in favor of cyanotic heart disease.
One of the very common here is thiamine deficiency. 15 days old baby, they come with the severe PH and with the PFO shunting right to left causing severe cyanosis. And when we give just thiamine to the kid and we saw the mother with all those features, they all improve. Not in the immediate 4-5 days, but we saw at the 20-25 days old, so many of that neonate. They come with the severe thiamine deficiency, severe PH, tachycardia, right heart failure. And once you give single or 2 doses, they all improve. This usually cause the pH secondary to thiamine, wet beriberi, you can tell. So this is also very common in this belt. We saw even 20 days old baby also responding to thiamine with the severe pH. And that turn out to, when we saw mother, typically flat tongue, smooth tongue, chillosis. So that is also very common in this area actually. So not immediately after birth, but 10, 20 days, 25 days, when it's about to around 1 month, they also can present with the severe pH sinuses at that point.
Right. Methemoglobinemia also we should consider in this case. And
Methemoglobin, when you suspect,
other features will not be there.
just suppose it's a
not
5-year-old
immediate-
child with the methemoglobin, what clinical feature which is not present in methemoglobin that will differentiate from the cyanotic heart disease? See, methemoglobin, the concept is, it's a more,
Right.
though clubbing will never be there in the methemoglobin. That is the clinical point. Not in a neonatal, anyhow, clubbing won't be there. But suppose 3-4-year-old with cyanosis pulmonary AVM, you will get clubbing. Infected endocarditis, you will get clubbing. Cyanotic heart TOF, you will get clubbing. But methemoglobinemia, there won't be any clubbing. So that is the differentiating point in a grown-up child to differentiate cyanotic heart disease from methemoglobinemia.
And
No distress. No distress. But suppose TOF, there also no distress. Suppose LSU, pulmonary AVM, they have clubbing and all. They don't have any distress. But the methemoglobinemia also no distress. But there won't be any clubbing because there is no hypoxia in that, because the affinity of the oxygen curve is very high. So that's why the PO2 will be normal, but the saturation will be low. That's the typical ABG pattern of methemoglobin. PO2 will be 70, 80s, 90, and saturation will be 60, 70.
also, sir, in case of newborns, we need to consider that when cyanosis is clinically apparent, this means the level of deoxyhemoglobin is at least 5 grams per deciliter. So, and if the baby is plethoric, when the oxygen hemoglobin itself is quite high, so there may be some confusion at that point of time. So we also need to correlate with what is the hemoglobin status of the baby as well. Then pulse oximetry is one of the most important investigations, the bedside tools that help us to think about the heart diseases. And in this regard, the American Academy of Pediatrics has recently updated the guidelines for newborn screening for critical congenital heart disease, where now they are saying that at 24 hours of life, in a well baby, that is a baby who's not on oxygen support, or if the baby is on oxygen support, the FiO2 requirement is not more than 21%, and especially before discharge, definitely pulse oximetry screening has to be done. So if the pulse oximetry, at two sites we have to check, that is the preductal as well as the postductal. So if in either preductal or postductal saturation, the value is less than 90%, this is a direct fail test and we have to go ahead with investigations. But if the value is more than 95% at both limbs and the difference in saturation is less than 3%, then it is pass. We do not need to repeat and we can go ahead with the discharge. But if it is not more than 95% in both sides and saturation difference is less than 3, then at this point of time, we have to retest in 1 hour. If the child fails again, then a second retest is not to be done. Only one retest is allowed as per the latest guidelines. The advantage of doing this test is that clinically important non-CCHD conditions like sepsis, pneumonia, PPHN can also be picked up in apparently well babies. So the important cyanotic heart diseases that we consider in the newborn period are the TGA, obstructed TA-PVC, TOF, tricuspid atresia, truncus arteriosus, and abstinence. So TOF is a condition where the onset of cyanosis happens after the duct closure. Respiratory distress and will be severe, and poor perfusions in case of obstructed TA-PVC, bounding pulses in case of truncus arteriosus, along with a hyperdynamic circulation. The apex beat is usually down and out in case of truncus arteriosus and Epstein's anomaly, where there is a large heart. The heart sounds usually a little difficult to appreciate in a tachycardic newborn, but in case of Epstein's anomaly, it's going to be a wide split that may be appreciated. The murmurs typical in case of TOF, which is a harsh ejection systolic murmur, and in Epstein's, we may be able to appreciate a TR.
This also one question clinical. What are the causes of murmur on day 1? So when you suspect heart disease. So on day 1, usually all regurgitant lesion as well as the semilunar wall stenosis lesion will come. Okay. So all TR, MR, all stenotic, PS, AS will come on the day one. So that's what. Tell us.
Coming to the X-rays, shall I go ahead, sir? Or
You show that the reticular what you told. That is not there.
this one, sir. So white
This is not comes in a neonate. What you
this is
did.
after 2 years of age, sir.
No, no,
It's
these-
classical.
These are not usually figure of it. It's not you can see on neonate.
Hmm.
You can see the ground. What do you mean by ground glass? I want to ask because so many people are telling they are not coming. What is ground glass?
Sir, white out lungs with that.
See, suppose
patch.
you are telling a glass with a hazy glass.
Hazy.
That is known as a ground glass. You see the white out lung haziness, no reticular haziness of the lung. That is known as ground glass. And reticular pattern in the bed. These are the two specific features. What is in RDS reticular pattern? Same if you see, you have to think of TAPVC or like the ground glass appearance. So these are the two main thing which we can present with the TAPVC. These all present later. This is not, you cannot see in the neonate.
Yes.
Okay.
Yes. So ECG findings again, newborns will physiologically have right axis deviation and mild RVH, but persistent or extreme right axis deviation and marked right ventricular hypertrophy is suggestive of TAPVC, TOF or TGA, and left axis deviation is definitely abnormal. This is with left axis deviation with left ventricular hypertrophy is extremely suggestive of tricuspid atresia.
Any cyanosis with left axis, if you are sick, there are only 2-3 diagnoses. Okay, first is tricuspid because RV is small, or PA intact IVS with superior left axis. Okay, the other two most common. Then apart from the others also rare, but for your levels, the tricuspid atresia, PA intact IVS because RV also is small, the superior left axis. These are the two most common left axis with the sign. Pulmonary atresia without VSD. So there is no VSD, only the RV will be small, but there is no egress to the. So that's why that RV will be very hypertrophic, small, hypertensive. So apex will be superior and towards the left because LV will be more dominant. Okay. So left axis division is cyanotic. Two most common lesion. First is tricuspid at any age. Second, this is the pulmonary atresia intact septum. These are the two most common thing will be there. Okay. So what is your take on this case? Suppose, so what you learn from this, because you manage this case here, what you learn from that?
Yes. So what from this case, what we have learned was the high index of suspicion is very necessary to have a good clinical outcome. This baby was operated at around 42 hours of life, stayed for 17 days, got discharged, happened
No,
doing
that is
well on
okay.
follow-up.
But what, how your mind will suppose any cyanotic baby come, when you suspect the heart disease, like the crux of this, how you, when you suspect?
So persistently low saturations not improving with oxygen, less likely to be a pulmonary cause and other
Okay.
things that we
Second,
have.
even after term baby RDS.
Yes.
Third,
Yes.
when severe acidotic presented with cyanosis.
Yes.
Okay, these are the 2-3 clues. Even when you think, you have to think of cardiac disease and then you have to take care of. X-ray reticular pattern will be there like an RDS. Okay, and TJ you will not get the similar pattern in all patients, but the TJ more cyanosis, more acidotic.
Yes.
That is the more common presentation.
Yes.
Anyone want to ask anything? Or you, sir, you want to come? Anyone want to ask? Suppose any cyanotic neonate, you have to go with the 4 level of that. First is central cyanosis, brain related. Birth asphyxia also we have PH cirrhosis. Second, come to the lung and heart level. All lung deformity, pneumonia also will have. So third, heart level. Heart level we discuss what may be the causes. Fourth is at the level of hemoglobin. Okay, like methemoglobinemia. So like that you have to do, and everyone has got different presentation. When brain, there will be history of asphyxia, poor respiratory effect will be there. When lung, you will get the more retraction, some patch in the lung, or there is a risk factor of like chorioamnitis or something will be there, or chest deformity, CDH will be there, eventation will be there, lung hypoplasia will be there. Come to heart, then you have to do the hyperoxia test and see, which is on the first day and which present after 24 to 72 hours. And in that also two lesion, obstructive which present more with distress and cyanosis, TGM for tachypnea and more acidotic. Okay, and third is duct dependent pulmonary circulation, more acidotic, more severe cyanosis, but perfusion initial days present, but more acidotic. Fourth reason is methemoglobinemia, what she told. It will be totally normal, but there will be some cyanosis will be there. One patient who diagnosed only 92 was persistent. We ruled out everything. When we checked, it turned out to be methemoglobinemia. So like that, you have to go one by one to the all system and then you have to check with the help of pulse oximeter and your clinical scenario. No, severe PPHN, usually they will respond to oxygen transiently. PPHN as a neonate you are using more often, but you have to rule out secondary. Like one PPHN we did, there was a vein of Galen large, which causing the PPHN. One having sequestered lung, which you'll see only on CT. So one PPHN is not responding to your typical like you are doing hyperventilation, is still saturation not improving. NO is still your PPHN not improving. Ventilation is still not. You have to think of other causes also. So
In case-
PPHN typical will have the history like what you told, meconium aspiration or something, delayed transition, then usually it will be heavy.
So obstructed TAPVC versus PP.
It will go. If sometimes it will go. But if it not goes, then you have to go the NO or you go to the next step, HFO and NO, and then you have to check actually.
With INO, it can even worsen, right?
What?
With INO, if we are suspecting, we are quite sure it's PPH and we start on inhaled nitric oxide, but it's actually a cardiac disease, then it can even worsen clinically.
Very rarely it
But-
will worsen.
Yes.
Okay. TAPVC, some rare it will cause happen, but there is a doubtful. INO, it may improve, it may not, it will remain the same.
Okay.
But it will not deteriorate. Already if it's a deteriorated, how much it will deteriorate? It will not get deteriorated much actually.
Right. Thank you.
Thank you. Thank you, Shruti.
Thank you, Dr. Shruti, for the presentation. And I thank all the three moderators, Dr. Sudeep Nagarajan, sir, and thank you, Dr. Srinivas Chekka, sir. Before we move on, it's our great pleasure on behalf of KIMS Cuddles team to welcome the legendary pediatric cardiologist, Dr. K. Nageshwar Rao, sir. Please give him a big round of applause. Thank you, sir, for joining us today amidst your busy commitments. I think Dr. Sudeep has taken a lot of efforts to make sure sir is there. Now, so there's a small change in schedule, and because we are still waiting for Dr. Chinmay Ratha, our fetal medicine expert, to join us, we are going to move ahead with a panel discussion on common neonatal pediatric cardiac problems. And so for those of us who haven't met, I'm Dr. Aparna, neonatologist from KIMS Cuddles, Kondapur. So I shall be moderating this session. And it's my great pleasure indeed to have our pediatric cardiology team, beginning with Dr. Anil Dharmapuram, sir. Please welcome you onto the stage to join us as a panelist. So Anil, sir, is our pediatric cardiac surgeon, and he's exclusively into congenital heart repair. Sir did his MCH training from the All India Institute Medical Sciences and further on trained at multiple institutes across the world, including Stanford. And sir leads the pediatric cardiac surgical services at KIMS Cuddles. And thanks to him, our team is also now being able to be a part of the congenital critical heart post-op care. For the panel, we are also going to have Dr. Nagarajan, sir, who is our senior pediatric cardiac anesthetist. Sir did his training from JIPMER and Postgraduate Institute of Medical Education, Chandigarh. And sir specializes in cardiac anesthesia, especially in kids, and he's an excellent intensivist. It's indeed a pleasure to be associated with their team, and it's constant learning for us every day as we manage cardiac cases. We, of course, have Dr. Sudeep Verma, who completes this loop. He's our pediatric cardiologist. Dr. Sudeep and his counterpart, Dr. Gautami ma'am, who couldn't join us today, they are the ones who help us in detecting, picking up heart diseases, and guide us in medical as well as or deciding those cases which will need surgical intervention. And last but not the least, we have our own teammate, Dr. Vishwanath Nandiala, neonatologist. Please join us, Dr. Vishwa. Dr. Vishwa is MD from Chelmeda Karimnagar and has done his DNB neonatology training from Kanchi Kamakoti Child's Trust Hospital. He's a neonatal intensivist with keen interest in a lot of recent advances, including ventilation, NIRS, and volume ventilation, nutrition, and he has been a very valuable addition to our team. Request Dr. Sudeep to also please join us on the stage. Dr. Sudeep, please, you are also in the panel. So the objectives of this panel are to discuss some common clinical presentation modes of various critical heart diseases in newborns, to discuss the core principles of pre- and post-operative management, and without much ado, let us directly begin with the first case. So the first case is a full-term baby, 38 weeks, born with a weight of 3,200 grams. This baby cried immediately after birth. Apgar scores were 7 and 8 at 1 and 5 minutes respectively. The baby did not need any resuscitation. Baby developed signs of respiratory distress immediately after birth with severe retractions and required delivery room intubation. And on examination, the baby was found to have marked cyanosis. Heart rate was normal, 146. All the peripheral pulses were well felt. The baby had severe respiratory distress with tachypnea, retractions, intercostal and subcostal recessions. Despite mechanical ventilation with 100% oxygen, the baby had persistent hypoxia with saturations of 87%, and Silverman score was 3 by 8 after intubation also. On auscultation, chest was clear. The abdomen examination did not show any marked hepatomegaly or splenomegaly. The baby is on high pressures on conventional ventilation, 24 by 6 with FiO2 of 100%, persistently hypoxic. Hence, the team decided to start high frequency oscillation as one would normally do failed conventional mechanical ventilation, and the baby was started with a MAP of 14, FiO2 of 100%. So, Dr. Vishwa, the first question to you. So this is the X-ray. So can you interpret this X-ray and can you share your thoughts on the differentials at this point of time?
So we have a term neonate who presents with respiratory distress and cyanosis, not able to oxygenate even with higher settings, 100% FiO2 and MAP. So at this point, we would like to consider differentials of, differentiate pulmonary and non-pulmonary causes. So pulmonary causes like we discussed, ARDS, pneumonia, sepsis, some pulmonary hemorrhage, edema, and of course, the most important cardiac cause at this point would be obstructed TAPVC. So these would be the differentials at this point.
Yeah, so, term newborn, white out lungs, persistent hypoxemia, not improving with maximum pressures and despite the highest FiO2. So, of course, we would begin with the commoner things like RDS. Term RDS is not an uncommon entity. And of course, sepsis, congenital pneumonia due to group B streptococcal infection, pulmonary edema, pulmonary hemorrhage, PVH due to left-sided pathologies of the heart. And of course, one of the most important differentials which we do not want to miss at this point is obstructed TAPVC. So this case, we were lucky. We had Dr. Sudeep who was able to come in immediately and was able to kind of pick up that this was obstructed supracardiac TAPVC. So Dr. Sudeep, you are of course a fully trained and qualified pediatric cardiologist. We are lucky. Some centers may not have the fortune of having the a ready access to a pediatric cardiologist echo. So what are all the simple signs in echocardiogram that a neonatologist like us can look at and can suspect that this could be TAPVC?
With the TR gradient mostly. That if you take severe pH with cyanosis not improving, that is the first. pH is usually present. Second thing, if you are able to see the PFO, ASD, which is shunting right to left, because the mixing all happen on the venous side and then it will go to the left side. Third thing, suppose if you are more into echo, then you realize the smoothness of the ridge, which you see usually on the LA side, that is a comedian ridge, and the irregularity of the pulmonary vein insertion, that will be lost. That is known as a bald LA, and you will not see the comedian ridge. So suppose if you see the comedian, that rules out usually TAPVC. So three signs: persistent pH is there. PFO always shunting right to left in whatever kind of TAPVC. Third is smoothness of the LA. And fourth thing, if you are able to see some chamber behind LA, because the veins are not coming, the smoothness, that irregularity of the vein into LA will lose. So there will be chamber behind the LA, and then it will be drained either to the liver or to the innominate or the SVC or cardiac tape, wherever it is drained. So these are the four things which will, and fourth thing, sometimes when the coronary sinus is very dilated, that's what people tell, sometimes it's a ostium ASD, large ASD, but it turned out to be the coronary sinus which is dilated. So these are the 3-4 signs. If you are doing echo regularly in the NICU, you will able to see PFO, coronary sinus dilatation, chamber behind the LA, smoothness, that irregularity of the LA will be lost, comedian ridge is not seen, as well as the pH. So these are the 4-5 usual signs of the TAPVC when you see on the echo will be present.
Right. This is a very important point for all the PGs and the neonatal intensivists here, because very often I mean, I wouldn't say probably very often, but quite a few times, babies get treated as PPHN, are given pulmonary vasodilators, inhale nitric oxide for some time before someone starts suspecting why this baby is not improving. Could this be TAPVC? And many of these therapies can actually be counterproductive in obstructed TAPVC. Again to you, Dr. Sudeep, is there any role for pulmonary venous stenting in obstructed TAPVC? Would you kind of put it as one of those accessory adjuvant therapies? Where is its place exactly?
Actually, nowadays, if the surgeon is there, it's best to do. But sometimes we did hardly 3 or 4. But when the child comes in a this condition, we're not able to shift even to the uh, cath lab to the OT, and comes the next surgeon not there immediately. So what do they do? When the vein is obstructed, so you can do the vertical vein stenting either to the right side or the left side. But this is not the standard therapy. This is only reserved when the surgical access is not there and child is too sick to send to the OT at that point. So we did hardly 3 patients, but otherwise all patients we are telling surgeon and we'll do. But otherwise pulmonary vein stenting, and sometimes when the umbilical vein is there, you can take the advantage of umbilical vein and do. The 2 patients we did from the umbilical vein in the left side and right side. So that's the advantage. Without any puncture, you can take the umbilical venous line, go to RA, go to innominate if the supra cardiac TAP is innominate obstruction, or to the SVC you can do. But rarely it needed, but if the surgeon is there, best to go with the.
So I think what Dr. Sudeep is telling is obstructed TAPVC straight away clearly is a surgical condition. There should be no doubts that this is a condition that needs immediate repair. And only if we have an exceptional scenario where unfortunately, we do not have immediate access to surgical expertise, this can be considered as an option. But otherwise, it's straightforward a surgical
And suppose
case.
a booked case with the sir, with KNR sir, we did one immediately after birth. Within 1 hour, we sent to the OT and we did actually once, but that was the prenatal diagnosis was there. Infracardiac TPC we delivered in the setting, and then we arranged blood, and we use the same placental blood also you can use for priming, and you send immediately to the. This may have a role only when it's not diagnosed or come in a very bad situation, then only to. Otherwise, in any condition, surgeries.
So straight away, it's a surgical repair is what that is preferred. Right, now let's move on to some aspects before the baby goes to the OT. And let me now ask Nagarajan sir, who is our cardiac anesthetist, and if there is anything you would like to add, Dr. Vishwa, you can pitch in. So what are the important considerations in the pre-op management, especially with regards to fluids, with regards to the ventilation strategy, and what should be our targets for lactate, the mean arterial pressure, urine output, before the baby goes to surgery?
So whatever it is, this is one condition which definitely needs to go to the operation theater, and whatever if surgical team is available needs to go. But yeah, before coming to the theater, whatever can be done, it is usually shifting the whole ICU to the OT, and usually after the theater, shifting the OT to the ICU. That sort of a setup should be available for managing a TAPVC. It's very essential to understand what's the blood flow happening, and that's how we'll be able to manage these patients. So what we are having is a patient who is cyanotic with increased pulmonary blood flow. So our treatment modalities have to be aimed at decreasing the pulmonary blood flow. And there is complete mixing of the blood. These patients could be in shock if there's interatrial septum is intact or the ASD is too small, or else the obstruction could be in the pulmonary veins. If it's more in the common chamber and in the vertical vein, they're going to be more distressed and maybe not in so much of a shock. But if the interatrial septum is intact, these people would be in shock, and that would be definitely going in for surgery. So if you look at them because of pulmonary congestion, increased pulmonary blood flow, could be getting into almost pulmonary edema, would be requiring higher ventilation. But the aim has to be that the saturation we need to keep around 80 to 85 would be the target, because it's a complete mixing lesion. So TAPVC we have seen is the condition wherein the saturation in all the chambers is the same. So since it's a complete mixing lesion, 85% would indicate that 80 to 85, your QP by QS is 1:1. You don't want the QP/QS to go up. The other thing happening is because of the PAH and the volume overload, the RV is stressed out. So that is going to require a lot of support. So definitely a lot of inotropes to support the right ventricle would be required. So what's happening on the left side is actually completely different. Here is a left ventricle which is absolutely underfilled because the interventricular septum is not allowing much blood to get into the left side. And also the interventricular septum would start bowing towards the right ventricle and thus would prevent the left ventricular filling. So some sort of inotrope, a vasoconstrictor to maintain the pressures and to prevent the interventricular septum bowing towards the right ventricle would be our objective. It would be maintaining as much as possible the whatever pressures before we try to go into the theater.
Anything else, Dr. Vishwa?
Just try to maintain a pH of 7.25 to 7.35 and accept a little higher PCO2s up to 60 to 65. And like Sir said, just target a saturation of 80 to 85 and titrate FiO2 accordingly because oxygen being a potent vasodilator and there is increased pulmonary blood flow that could
Worsen the
worsen
pulmonary
the
congestion.
condition. Yeah.
Right. So targeting low normal saturations, MAPs, and as Nagarajan sir said, I mean, we may have to judiciously titrate inotropy pre-operatively and make sure that the hemodynamics are optimized before the baby goes on to surgery. Now, we have been repeatedly talking about how TAPVC is purely a surgical condition, and we are extremely fortunate at KIMS to have the surgical expertise of Dr. Anil Dharmapuram sir and his team. So, sir, can you please enlighten us on the recent advances in TAPVC surgery and your experience over years, how TAPVC repair and the outcomes have evolved?
So TAPVC basically is a three types: supracardiac, infracardiac, and intracardiac. The most common emergency which we see neonates, especially day 1 of life, day 2 of life, when we operate TAPVC, is supracardiac, for example. It's a common variety. So when we operate on these kids, as Dr. Nagajan was saying, the kid is so sick. So to open the chest and then to go on bypass is a very crucial step. The baby can crash. So we should make sure that temperature of the baby is not drifting, and the heart-lung machine is ready to go on bypass. And then the babies are usually small weight, so we operate on as small as 2 kilograms, even less than that. So to go on bypass is not an easy thing. So we have to be careful about cannulating the aorta, so the aorta is in these babies. Aorta is always small. Always very small. So cannulating aorta is a very important surgical step without damaging. And then the other thing is the superior vena cava in these babies is very small. In the sense, some of them are dilated in supracardiac variety, but strategies in surgery differ. Some people do on total circulatory arrest. We just put a cannula in the right atrium and cool the baby to 20 degrees and do a TCA. That is called total circulatory arrest. That is that we cool the baby down to low degrees and then stop the circulation and repair the veins. I will show in my presentation later how we do that. I have pictures in my presentation. That will be later. And then otherwise, to avoid circulatory arrest, we do both superior vena cava and inferior vena cava cannulation, and then go on bypass and stop the heart and repair the veins, and then the heart will take over. So the recent advances, if you tell about the problems, these days we get babies with small weight. So in small weight babies, is small. When the chamber is small, they tend to become narrow when you do the repair. At least after repair, we often find a small incidence of babies coming back with restenosis. That was a problem which we have faced. So to handle that, across the world, so various techniques have been evolved, and then various experiences have been reported. So we have been doing what is called sutureless technique in the recent years. This sutureless technique means we don't touch the intima of the heart of the common vein. In this technique, when we do the sutureless technique, we find that, I'll show my pictures later on, we find that the restenosis is very less incidence. The babies are doing mostly well. So in our experience in TAPVC, our nightmare has been restenosis. We have had, as you know, as Aparna knows, and as everybody, our unit, we have handled some babies with restenosis. They came back with restenosis, I operated them, and then they have done well too. But it's not an easy thing to handle restenosis in this case.
Thank you, sir, for your insights. So while baby is undergoing TA-PVC repair, the anesthetist would be managing the baby on cardiopulmonary bypass. So Nagarajan, sir, could you tell us something about how unphysiological cardiopulmonary bypass and circulatory arrest is for a neonate, and what are the important considerations at this point of time? So what are all the changes the baby undergoes?
Yeah, Doctor. So this is cardiopulmonary bypass for a neonate is unphysiological as you can. So the whole thing is the surgeon wants a surgical field in which there is no blood and the heart is not moving. So to achieve this, yeah, you need to stop the heart. So if you have to stop the heart, you need to give a cardioplegia so that the heart doesn't move. And also if you have to stop the coronary circulation also. So it's going to apply a cross clamp and then give the cardioplegia. So there is no blood coming to the heart and the heart is motionless. So, and then the question is, how are you going to maintain the perfusion to the other organs? So that's why you take out the blood from the systemic veins, pump it through the heating chamber, then through the oxygenator and back to the aorta, heating or cooling, whatever we can do it. So back to the aorta so that the other organs are perfused. So that would be what would be the concise way of looking at what would a cardiopulmonary bypass would be. Yeah, it has its own effects. It's, as I told you, it's the most unphysiological thing. As Dr. Anil told, some people would do it under total circulatory arrest. So you cool them to 18 degrees and sometimes you absolutely stop the circulation, or else you could maintain a moderate or a deep hypothermia and still flow some amount of blood into the various organs. So the blood which is going to come in contact with the various other surfaces is going to cause a lot of inflammatory factors are activated because of the cardiopulmonary bypass. And this definitely does have a very significant effect on the outcome of these children.
I think the next question is also to you, sir. So now that we have understood the problems, challenges that come with TA-PVC repair, both surgically and from the point of view of subjecting the baby to a cardiopulmonary bypass, the challenges don't stop there. Post-operatively, one of the important challenges that we deal with, especially in obstructed TA-PVC in a small newborn or in the early postnatal life, is PAH crisis. So I'm going to request Nagarajan sir to talk a little bit about this. What are the things that predispose some babies to more PAH crisis? How do we identify this condition and how do we manage it?
So pulmonary arterial hypertension crisis can happen in a patient who's having a pre-existing pulmonary arterial hypertension. These are people who should be more careful. I'll be more worried of children who have had some ongoing infection, especially if it's a respiratory infection. These are the ones who would definitely have a higher chance of getting into a pulmonary arterial hypertension crisis. So by definition, it would be the mean pulmonary arterial pressure going 80% of your mean systemic pressure. So that's when the RV starts failing and then things start going wrong terribly. So the PA pressures, so if you have invasive lines, you can definitely make out. So in some surgeries, we might have our PA lines, LA lines, though it's not that common as of now. But if you have a luxury of it, what you would actually find is the PA pressure is going up, as I told you, more than 80% of the systemic pressures. But since that is going up, the LV side is not filling. So the LA pressures would be low. And since the PA pressures are high, the CVP and all would start going up. The RV would start ballooning. The RV, you might get into a bradycardia, hypoxia, usually associated with some pulmonary with a bronchospasm. Also, bronchoconstriction is usually seen with when this sort of a setting comes in. So, but in TA-PVC, yeah, this is primary pulmonary hypertension is a possibility, but it could be because of a secondary pulmonary hypertension also. So having a LA line would help in differentiating both the things, actually.
So I think this is the time where we can kind of judiciously consider using pulmonary vasodilators. So very often, Nagarajan sir would tell us, keep inhaled nitric oxide ready for this baby post-operatively, because we anticipate PH crisis in some babies more than the others. And while we manage this with pulmonary vasodilators, including sildenafil, one also needs to remember that the role of systemic vasopressors like vasopressin or norepinephrine may also be extremely useful in order to maintain a decent systemic vascular resistance. So I think we have discussed extensively about TAPVC. If there are any more quick points any of my panelists would like to add, they may. If not, we will probably move on to the next case.
On the pre-op thing, okay, it goes over a little more that there are reports of managing these patients pre-operatively when the surgical team is not available on an ECMO, but the results are usually worse when you put these patients on ECMO and then do surgery than if you don't directly go do the surgery on these patients. So we have done one case like that, but I think that's one of the rare cases. But usually surgery is the thing to manage these patients. This is probably the only condition in which surgery is the thing. Rest of other things, you can call only the cardiologist and still lab and then take this patient for the next step for surgery, but not for a TAPVC.
Maybe one question that I have before we move on to the next case. Do outcomes vary based on whether it is supracardiac, cardiac, or infracardiac TAPVC? If Anil sir or Nagarajan sir could.
Usually the chamber-wise, the infracardiac has a higher mortality, morbidity associated with it. The cardiac could be actually on the lesser side, but neonatal cardiac usually doesn't come, but whenever they come, are associated with pulmonary venous stenosis. So I think that would add to the risk of even in cardiac TAPVCs, but infracardiac would be the worst outcomes.
Same thing. If the inherent stenosis, so many of that associated with the hypoplastic vein or inherent stenosis first. Second thing, what we realize is infracardiac TAP is more a vertical oblique chamber with the small volume of the chamber. Supracardiac, usually when obstructed, they have got good volume chamber. And coronary sinus, it's a big opening space. So coronary sinus is the least obstructed in general. Infracardiac is the most commonly associated with the obstruction, with the volume of the chamber is little smaller as compared to other. So that's why infracardiac. And third thing, associated inherent stenosis of the vein or hypoplasia of the vein. That is the third thing which will associate with the morbidity and mortality later with the type of TAP.
So I thank everyone for the first case discussion. I think few important carry home points for all pediatricians. Suspect obstructed TAPVC in any newborn with severe refractory hypoxemic respiratory bilateral diffuse granularity, which is not behaving the usual way, like you have the suspected RDS given surfactant, ventilated, or given CPAP, and baby is not recovering. This is definitely one condition to rule out. On an echo or on a neonatologist performed functional echo, some clues that could make us suspect obstructed TAPVC include PAH, which is not behaving the usual way, or a persistent right to left shunt across PFO, as Dr. Sudeep was mentioning, and abnormal contour of the chambers. Thirdly, preoperatively, TAPVC needs judicious fluid management. Usually, we restrict fluids. You may consider giving a dose of Lasix. Prostaglandin is usually contraindicated and may worsen the hemodynamics. And one tries to achieve near normal hemodynamics. Surgery is obviously the treatment of choice. The earlier, the better, especially when it is obstructed TAPVC. And post-operatively, one needs to anticipate pulmonary arterial hypertensive episodes and be prepared for its management with a judicious mix of pulmonary vasodilators and systemic vasoconstrictors. Thank you, Chinmay ma'am, for joining us. So we move on now to the next case. This is a different case. A term, 40 weeks, newborn, 3,500 grams, born by LSCS for polyhydramnios and gestational diabetes. The baby had normal transition, Apgar scores of 8 and 9 at 1 and 5 minutes of life, was roomed in with the mother. Baby was noted to have some cyanosis at 10 hours of life and was immediately shifted to the NICU. On examination, the baby had a heart rate of 130 per minute, like normal pulse rate. Pulses in all limbs were well felt. Fairly ruling out coarctation. Saturations were 75% in all limbs. So this baby has presented with severe cyanosis at 10 hours of life, apparently with no signs or minimal signs of respiratory distress. Cardiovascular examination, no murmur, and abdomen, again, there is no organomegaly. This is the X-ray. Pretty classical X-ray, the quintessential Egon side appearance, and no big prizes for guessing that this is transposition of great arteries. Very simple, straightforward X-ray. But a question first to you, Dr. Sudeep. Is absence of murmur a reassuring thing in a newborn with severe cyanosis? Should we still be worried if there is no murmur?
Murmur in newborn present only when the PS is there. Semilunar wall stenosis or regurgitant, then only we'll get the murmur.
Yeah.
Okay. Or sometime.
So in other words, which are the critical heart diseases that are present without murmur?
This first, the TGA is the most common condition. Okay. This is the first condition. Sometime when the PDA got closed in the duct dependent circuit, even you won't get the murmur. Even in HLHS, like which is related to the perfusion, the obstructed, you will not get the murmur. So murmur is not the only thing. You have to see the overall saturation, clinical scenario, acidosis, perfusion, excess, then you have to make out. So murmur, presence of murmur, absence of murmur is not that it's a less or less critical. It's most critical, most lesion also can present without murmur also.
Yeah, so absence of murmur in a deeply cyanotic newborn is not a reassuring sign. We still could be dealing with some of the conditions Dr. Sudeep enumerated. A TGA can be a silent chest, just cyanosis, critical pulmonary stenosis. We have some other conditions also, including Al-Kappa, where murmur may not be present. So Dr. Vishwanath, we all keep hearing about this pulse oximetry test, and we tell all our PGs and fellows. So can you tell us something about pulse oximetry screening for neonates? When should it be done? And what are the conditions it rules out? What are the conditions it still doesn't rule out?
So now pulse oximetry screening in NICU, it is a standard of care, and it should be done to all the neonates, especially well babies, to detect the asymptomatic congenital heart disease. And it should be done around 24 hours or at least just before the discharge. So we test in right upper limb or any of the foot. I mean, difference we see, and now, like Shruti said, there has been an update that we are not doing 2 retests now, just a single retest if the pulse oximetry screening is not failed or passed both. So what happens sometimes, it fails to detect. There are few conditions which may be skipped because of the duct, like duct-dependent systemic circulations. We fail to detect. So those cannot be detected with the help of pulse oximetry.
Yeah,
But
so
it should be done. It should be offered to all
newborn.
well babies
Yeah.
on room air or at least minimal support. It should be done.
So every so-called normal newborn before discharge should have a pulse oximetry test. Just like we speak about thyroid screening, we speak about hearing screening. This is a screening for critical congenital heart disease. Very, very simple to do. It only requires pulse oximeter. So you measure saturations from the preductal, that is the right upper limb, and from one postductal limb, which is either foot. And we look at the saturation. So you have the standard cutoffs. So if you find any limb saturation less than 90%, straight away it is considered as a failed pulse oximetry screening. And on the other hand, if we see persistently saturations between 91 to 95% on multiple occasions, or if there is a difference between pre-postductal saturations more than 3%, again, these are conditions that will require rescreening, and the baby needs echocardiography to rule out critical congenital heart diseases. Conditions pulse oximetry screening may still miss may include left to right shunts like ventricular septal defect or PDA, and obstructive conditions, systemic obstructive conditions like coarctation, which pulse oximetry screening may fail to detect. But this is one screening that all of us should offer every newborn before discharge. So, Dr. Sudeep, I think we did discuss this in the case scenario. I think probably we can just summarize the points. So what are the salient features to identify that cyanosis is in a newborn is cardiac in etiology? So just 2-3 simple points for us.
To the simple way, first to rule out the cyanosis with distress, cyanosis without distress, tachypnea with cyanosis, pulse oximeter low. Third thing, if not improving with your oxygen, that you failed hyperoxia. So that is even like that you present all cases, even with the ventilation, oxygen, your cyanosis is not improving as per your expectation. And that is also one of the cause for the cyanosis. You have to rule out the cardiac cyanosis.
Right. So cyanosis without respiratory distress, and where cyanosis is out of proportion to the signs of tachypnea or work of breathing, then we again suspect that this could be possibly cardiac, or cyanosis not improving with oxygen. Again, think of cardiac. Of course, Dr. Sudeep spoke about hyperoxia test during the case presentation, so I'll probably skip it now. So this baby turned out to be transposition of great arteries. So coming to Nagarajan sir, So what is the ideal timing for arterial switch in TGA, and does it vary based on whether the baby has intact septum versus TGA with VSD?
So we are all very sure that yes, TGA with intact septum, it's going to get worse. So TGA with intact septum, we are always worried, yeah, we need to do the surgery early because otherwise the left ventricle is going to regress and then it might not be suitable for a TGA. So, but then how early has always been a debate. So even for an intact TGA, so going beyond 3 weeks, TGA with intact ventricular septum, you start worrying about LV getting regressed. Beyond 6 weeks, yeah, you should not be doing it unless you have an ECMO backup and then consent for that. Otherwise, it should be a 2-stage procedure only beyond 6 weeks. 3 to 6 weeks, it's going to be a doubtful thing whether you're really going to do a TGA or you might small train them for a short term and then try to do the TGA with the intact septum. That's what it would be. Now, TGA with VSD, you don't have to worry about the LV getting regressed because the VSD and the pulmonary arterial hypertension VSD is there. So the pressures are equal in the RV and the LV, so the LV would not regress. So is it okay to leave them longer? So, but the problem is going to be development of pulmonary arterial hypertension. So definitely you can't leave them too long. Cyanosis with PAH, they would go into Eisenmenger much faster if either just one of them, if only increased flow is present. So cyanosis is going to add to the possibility of getting irreversible shunt earlier. Now, there's been a recent study, not very recent, probably around 2019 or 2020 like that, who have compared what is the best time to do a surgery for TGA with intact septum and TGA with VSD. So they say for both the conditions, it's better to do the surgery before 2 weeks. So even for TGA VSD, it's better to do the surgery before 2 weeks. So their analysis, what they had done was try to measure the brain volume using an MRI TGA VSD. If it's done more than 2 weeks, the brain volume actually measured by MRI actually is slightly smaller. So yes, TGA VSD also should be done less than 2 weeks. TGA intact ventricular septum, our policy is to preferably operate them within the first week as of now.
Right. So a TGA intact septum, greater urgency because of higher chance of LV regression. But even in TGA with VSD, preferably less than 2 weeks is what our cardiac anesthetist Nagarajan sir is advising us. And I think the earliest we have done arterial switch in our center probably is around 48 hours, sir. Right.
Even first day also when they come.
Right.
So nowadays, that's what the second question I'll tell in front. The role of BAS is very limited until unless the same, like if it's come in emergency, surgeon is not there, only risk factor is there. But nowadays, even first day when they are coming, we are managing in the 24 to 48 hours, we are doing directly surgery. I think the last bus I did probably 1 or 2 years back. After that, I not did anything. We are telling sir only to do all surgeries within less than 48 hours also. So because what we realized, and there's a study from AIMS also that once you do the BOS, the dynamics of the right and left ventricle will change. And with that second thing, you may give some infection also. There's so many other things that result only for the emergency condition when you are unable to reach surgeon immediately and the child is critical and not able to go to the surgery within short period of time. That's the only role of the BAS at present. Otherwise, when the surgery is available on the first day, 24 to 48 hours, you can do the surgery. Well, and we are doing that also. We are following the same now actually.
So BAS, what Dr. Sudeep is referring to, balloon atrial septostomy, is one of the ways to keep one of the connections possible open between the two sides, the right and the left. As you know, TGA is parallel circulation. And I think for the baby to survive, please correct me if wrong, 2 out of the 3 communications at least must be there. And I think
the best mixing happen at the ASD. So sometimes even the good PDA also there, you may not able to get good mixing when the ASD is small. So you need either ASD, VSD or PDA. But even with the VSD cert before 2 weeks, but they are little better in comparison to others. But sometimes even with the large PDA we saw when the ASD is very small, so they present in a severe form. So ASD communication is the best for the mixing in the parallel circulation. That's why we need to a good size ASD in the TG.
right. So BAS is balloon atrial septostomy, where pediatric cardiologists create a larger atrial septal defect in order to allow some mixing. But as Dr. Sudeep said, it comes with its own problems. There is a little chance of bleeding, introduction of infection, and wherever good surgical expertise is available, most units prefer to go for earlier arterial switch. So let us now come to Anil sir, and sir, can you enlighten us about challenges in arterial switch, which I think is one of the most challenging surgeries requiring a lot of precision. So sir can talk to us about the difficulties, challenges in the surgical correction of TGA.
So TGA requiring arterial switch is definitely a challenging operation for a pediatric cardiac surgeon. So as you say, when we operate early, before the LV regresses, we are operating on day 2 of life or immediate without septostomy. So the important criteria is the weight. If the baby's weight is at least 3 kilograms, we're very happy, but it rarely happens. Mostly we end up operating to 2.5, 2.4. So in small weights, and also in fresh, within 1 week of life, the main risk factor is bleeding. So when we handle the surgical technique, I'll show in my presentation later how the important step is not when we switch the artery, the switch operation, when we do the switch operation, the important thing, the challenging thing is to switch the coronary arteries. So these babies, if you open and see, if the pattern of the coronary artery is normal, we are very happy because it's a smooth run, mostly because the transportation intact septum with normal coronaries, the translocation of arteries is fairly standard and usually goes smoothly. But the problem comes when the arteries are not normal. So that's we find quite a number of babies who will come with abnormal coronary artery. That is, the left and right coronary arteries present different way. There are 3-4 varieties. So especially when the type D, when the circumflex and the right come together, and also an anterior anterior presentation like a type E, where the right coronary artery comes from along with the LAD. So in the abdominal coronary arteries, we can damage the myocardium function if the translocation of the arteries is not done properly. That is a crucial step in the switch operation, and that will determine the heart function and the outcome of the operation. And as I said, bleeding is always an issue because aorta is the tissues are very fragile. We have to have expertise in suturing this and handling the small lumen arteries.
So one of the most challenging surgeries which requires a lot of precision, and we all recall in some cases of TGA we have done here, Anil sir says they actually redid the step of reconstructing the neo aorta sometimes 2 times until they achieve the satisfactory results. The outcomes entirely depend upon some of these crucial steps. So Nagarajan sir, I mean, what are the complications we see post TGA, post arterial switch? And can you tell us something about how low cardiac output state post or arterial switch is managed? I mean, based on different parameters.
So we should understand what's going to be the pathology for the low cardiac output before we try to manage the low cardiac output in a patient with arterial switch. So as Dr. Anil told, if there's abnormal coronary patterns, it does become a little more difficult to do the coronary buttons and then translocating them. So is there any kink or is the coronary blood flow sufficient is a very important factor. Second factor which comes in is, as far as the surgical thing is, how is the myocardial preservation which has happened, the bypass time and the cross clamp time. These are all going to affect or going to determine whether patient is going to get into a low cardiac output or not. So this is the surgical factors which we see. From the patient perspective, when we see, as I told you, if it's a TGA with intact ventricular septum presenting late to us, the main concern is the LV mass is not adequate. So we are not going to adequately we definitely get into a low cardiac output state. How are you going to manage that? And the second one would be a TGA with a large VSD. Though the LV mass is good, the main problem, the main reason for low cardiac output is pulmonary arterial hypertension. So if it's a VSD, you're more worried about with VSD, you're more worried about pulmonary arterial hypertension. You're trying to use pulmonary vasodilators as much as possible, trying to bring the PA pressures down. That would more or less settle the low cardiac output state in that situation. In patients with TG IVS, we don't have much things to do. Yeah, if things are very bad, you might have to support them on ECMO. That's if you're presenting very late with regressed LV, you still go ahead and do, then you should have an ECMO backup. If that is so there's got a lot of patients who are going to be borderline. So those don't require an ECMO. But yes, you would still, TGA with IVS, with intact ventricular septum, you would still need to use a lot of pulmonary systemic vasodilators so that the LV afterload is decreased in them. You try to manage them based on the LA pressures some of the times, rather than based on the systemic vascular pressure, rather than the systemic pressures. So you don't want the LA pressures to go up in these patients by either giving too much volume or trying to achieve very high pressures. So if you're trying to achieve very high normal pressures, also adds to the afterload to these ventricles and it might fail, resulting in increased LA pressures and pulmonary bleed. So try to maintain the LA pressures less than 10. You accept pressures as long as you have systemic perfusion, your lactate is settling down, some urine is coming down. Usually it will settle down within 24 to 48 hours. The LV would start hypertrophy. Hypertrophy would come in and it would take over and it will be settling down.
So various reasons for low cardiac output state, and as sir said, the use of a LA pressure line can be a very useful marker for helping us to rule out which of the different causes are likely cause for shock in that particular baby. Sir often tells us to look at the trend of the LA pressure line rather than looking at one particular number. So if you're seeing persistently high LA pressures, that probably means that the LV function is still not adequate, and probably it could be, we should look at other possible reasons like cardiac tamponade as well. So I think we have discussed two important open heart surgeries that we often do in newborns. So with that background, I think we'll quickly try to discuss 2-3 other simpler conditions, but probably I'll skip the clinical presentation part. I'll directly probably tell the diagnosis, and we can just reserve the time for discussion by the. So this is a 5th day term newborn, 37 weeks, 2,700 gram baby, presenting with cyanosis. Saturations are 70% in room air. Again, no cardiac murmur, no respiratory distress, no hepatomegaly. Abdomen is soft. The X-ray shows oligemia of lung fields, indicating a low QP condition, low pulmonary blood flow condition with the RV apex. So this is what we see in conditions like TOF type physiology. So this baby turned out to have pulmonary atresia with VSD. So what are the different differentials of duct-dependent pulmonary circulation, Dr. Vishwanath?
So there are duct-dependent pulmonary circulation would be the tetralogy of Fallot, and few other conditions like critical pulmonary stenosis and tricuspid atresia or pulmonary atresia with intact ventricular septum. So these 4 or 5 are the differentials of duct-dependent pulmonary circulation.
So there are some few conditions that present like tetralogy of Fallot, where you have pulmonary circulation that is dependent on the duct. So Nagarajan sir, for all of us pediatricians and neonatologists, so what are all few important precautions, considerations you would like to tell us before we use prostaglandin in these babies?
So for a duct-dependent pulmonary circulation, when you're trying to use a prostaglandin, yeah, initially you might require a higher dose of prostaglandin going up to 150 nanograms per kg per minute or something to at least open up the PDA. So, but the problem with a higher dose of prostaglandin comes in is you might get into apnea. So that is one thing which we need to watch out for. But usually it's with a lower dose. But once the PDA is open up, you can decrease the dose of prostaglandin, and that definitely helps in maintaining the PDA. And patients do not get into apnea with that sort of a doses. When you come down to 50 or 10 to 50 nanograms per kg per minute, then usually you do not get into issue of apnea in those patients. So that is the major thing. Using it for longer time, yeah, can cause lots of high inflammatory sort of a feature comes in, wherein they start leaking a little bit, tissue leak comes in with these patients. They'll be a little hyperthermic. You would find them when you start using prostaglandin for a longer time.
Yeah, so prostaglandin, very useful drug, but comes with its own challenges. So one needs to be aware, typical dose is around 0.1 microgram per kg per minute, which is 100 nanogram per kg per minute. Maximum doses reported in literature are 150, 200, up to 400 nanograms per kg per minute. But higher the dose, again, comes with higher risk of complications. Dr. Sudeep, I think we have done few cases of PDA stenting in duct-dependent pulmonary in our center. I know it's not a very easy thing to do. What are the complications that you often encounter with PDA stenting when you do in this type of lesions, you know, VSD,
There are two
PS?
things, PDA, the two types, usually VSD pulmonary atresia, usually vertical or oblique duct. So to take the different axis, carotid or axillary axis, or transvenous, you have to go. Sometimes the horizontal duct, you can go with the directly with the femoral artery axis. So the problem with the PDA static, first to access the PDA sometime will be difficult. So the correct approach, either axillary, carotid, femoral, you have to take as per the morphology. Sometimes it will be too tortuous duct and too long duct, so you may not able to do. So some patients we fail to do duct because they're too tortuous, too many turns. So we send for the surgery. Third thing, the chances of dissection also will be there during the process of crossing the PDA or PDA go into spasm. So again, the on table sometimes dissection. So whenever you are doing, the surgeon should be on backup. Suppose you fail, so he can take up for the BT shunt. Third thing, even after putting the stent, sometimes they got thrombosed. So because there is a thrombus in the PDA, which we put a stent that will come through the struts. So you have to put a good heparinization, maintain the good CO2, good ventilation, good volume, start the heparin, give, and then you have to continue the anticoagulation later. So because of these two, three things are there. Once you stabilize over the period, sometimes with the small, you put a bigger stent, it will cause pulmonary edema also because the lung will be under perfused. After putting the stent, it will cause the pulmonary edema. So these are the few risks. And sometimes it will jail the vessel. Suppose you put a PDA stent, it will block the LPA. So more flow to the one lung, less flow to the one lung. So PDA, it's a challenging process. First, the approach type of the PDA, what is the possibility of doing and what is the chances of not failed in doing that. Considering that, it's a challenging process to think after that.
So consider PDA stenting only when saturations are persistently low, requiring prostaglandin infusion for a long time, but one must be aware of its complications. So sometimes, sir, when Dr. Sudeep says the PDA is vertical, difficult to stent, we request you to come in for a neonatal BT shunt. Again, you often tell it's not a simple surgery. So can you tell us something about the challenges of a neonatal BT shunt?
So the BT shunt in a neonate is always a challenge. As all of us know, in the recent times, we hardly do the shunts. The cardiologists are able to handle them with PDA stenting. That is very useful actually because it helps as a surgeon us to tide over the crisis of the baby. And even I noticed when we do a PDA stent, when they come back for surgery repair, even if the stent causes some narrowing of the LPA, we're able to handle that safely. That is one thing which I want to tell you. Another thing is to operate on a neonate with a BT shunt is always a challenge. So thoracotomy usually we do from the right side, and then for doing a thoracotomy shunt, the confluence should be normal and there should not be any stenosis of the LP origin. That's one thing. So otherwise, if the LP artery is narrow, then we have to midline shunt. That is very challenging, and the mortality is very high. So in the past, we used to do a few of them like that, but in the recent times, our incidence of doing BT shunt is, as you know, is very much low. And the most important challenging thing is when you put a shunt in neonate, it's very difficult to assess the size of the shunt and the post-operative management. Sometimes the shunt will overflow, and if it is too small, the shunt will thrombose. It's a very challenging post-operative care, and it's not a simple thing.
Thank you, sir. So I think we have discussed 3 different cases so far. We discussed one obstructed TAPVC, we discussed a case of TGA, and the third case we discussed was a duct-dependent pulmonary circulation. So for the interest of time, I'll not go into the clinical presentation of the next 2 cases. The next case is a 40-day baby, and a young infant, in fact, who is coming with signs of cardiac failure, congestive cardiac failure, tachypnea and tachycardia. And on echo, the baby has a large perimembranous VSD. X-ray shows cardiomegaly with pulmonary plethora. The cardiologist, Dr. Sudeep, when would you consider device closure in VSD? And to Anil sir, what are the challenges of VSD repair? So I think we'll just
in neonate, there is no role actually. It's very difficult to do the device closure. Usually, VSD usually present by 4 to 6 weeks. Okay, with the large VSD. Moderate VSD, they don't roll to do anything. 4 to 6 weeks afterwards, you have to decide if it's a muscular, it's a doable with the device. But mostly the periambular, malaligned, subpulmonary, they are not amenable for device. You have to go for surgery only. First, you have to manage the medically with diuretics and all. And then if it's all not improving, the CCF is not, then you have to consider the closer. So closer with the large VSD is only with the surgery. Some specific form of the VSD like the muscular VSD, okay, or perimeter with a good aneurysm, that we can do. The lowest we did till now is 1.5 month. Before that, we not did any device closure for VSD. But for the muscular perimeter with the aneurysm, where is a good sac to hold the device, then we can do device. For the way surgical is the best process for the small kid less than 2 kg or less than 1 to 2 months actually.
So large VST, how early do you think the child should be referred for
No, see,
intervention?
the usually VSD present by 4 to 6 with a drop in PA pressures, PVRI, not PA pressure, PVRI. So usually they present with 4 to 6. The first you have to start diuretic as per the guidelines. It between 2 to 6 months, large VSD. Some people we did even at 1 month when it's not improving, presented early. In premature, the PVRI falls early. So even premature, you have to do even at 1 month also, 1.5 month also. So it depends on the term, preterm, how fall PVRI will be there, how symptomatic they're even on the diuretic, and then you have to decide. But usual indication, the stabilize is between 3 to 6 months is the recommended age for the large VSD. In cases where it's not improved with medication, you have to do as early as 1 month, 2 months also as per the clinical condition.
Nagarajan sir, you agree with that, sir, or anything you would like to add?
Yeah, I think we should. I would want to wait on VSDs. Definitely not less than 1 month. I definitely don't like to anesthetize and look after them in the post-op period. They do behave very badly. There's always surgical challenges with patients who are less than 1 month coming for the VSD. The one thing which definitely needs to be looked into is there a left ventricular outflow tract obstruction when a large VSD patient is coming for early surgery. So these are the fellows who could be because of the coarctation or some LVOTO or having an increased shunt and coming in for a VSD repair early. So they will require a combined procedures rather than just the VSD repair.
Right, sir. So Anil sir, common challenge. And in your opinion, what are all the indications clearly for surgical closure for VSD?
So VSD in neonate is, as Sudip was saying, we usually don't operate them so early. So we usually wait for the diuretics and then we aim for at least 2.5 to 3 months. So sometimes we know that we are forced to operate on a neonate less than 1 month VSD. So for example, in transposition VSD, we operate even in the first week of life. So challenging for a surgeon, the challenge to do a VSD repair in a neonate is to repair the VSD. The sutures have to be the muscle is so fragile, so we have to be very careful in suturing the VSD. It can tear, and then when we tear the muscle, we can cause conduction problem, that is block. The conduction problem is a very high risk proposition to do a thing, but we have managed them quite well surgically all through. We're able to manage do the repair even in neonates. But as I told you, sometimes the weight of the baby is very small. Then we stage it by doing a PA band. We do a PA band, wait for some time, and then that is one strategy, that is one formula which we follow sometimes. But mostly neonatal VSD closures are the challenging subset for surgeon.
And Nagarajan sir, what is your thought process on management of arrhythmias, one of the common complications post VSD repair?
So yeah, arrhythmias, if you're looking at the cardiac surgery, arrhythmias, either it's brady or a tachy. Brady is a block which can come. The bundle is very close to the margin of the VSD. So, but yeah, if a good surgical technique, the incidence is much lesser. It's less than 1% would be the incidence in good units. So that should not be the issue, I feel. But more commoner is going to be a junctional ectopic tachycardia. Again, very much a function of surgical skill, I would say, because more they start stretching in the junctional area, they get into junctional ectopic tachycardia. That would require some management, definitely in terms of cooling or AV synchronous pacing and amiodarone to control the rate. So that's how would be the major problems as far as rhythm is concerned.
So the last case that we wanted to discuss was a case of coarctation of aorta, but probably I think we will skip through it for want of time, or in case the panelists can quickly give a single important point from each of their domains on coarctation repair considerations. Dr. Sudeep, Nagarajan sir and Anil sir will quickly run through your opinion, and maybe we'll wind up.
Same like role of balloon coarctoplasty reserve, because the elasticity is very high. So if you do balloon, there are chances of getting it recorked very fast.
Recurrence
Okay.
is high.
We did some to even 20-30% recorked very fast. So that's why if the surgically possible to, in the case where it's very difficult, like one we did very preterm, come in almost a very gasping condition, we did and went and balloon we did. But again, after that patient 20 days, he become the coarced and we had to do surgery. But we tide over that crisis into the role of balloon coarctoplasty is still there in condition where there is a severe LV dysfunction, is very high risk for surgery, unable to go for surgery. At that time you can do, but it has got its own complications and own risk factor, but you can able to do well. Sometimes you not get the lower pulse, you have to go with the axillary artery and do, and then you can able to do the coarctoplasty.
So
But
balloon coarctectomy, Dr. Sudeep is telling, has its own challenges and high risk of recurrence. Sir, coarctation repair.
The surgical coarctation repair, I will show my slides when I do the presentation of neonatal coarctation. So it's a challenge to operate. So as Dr. Sudeep was saying, balloon is not the strategy in our unit. We primarily do surgery, even on day 2 of life, even as small as 1.4 kilogram we have operated. So when we operate the coarctation, one risk factor is restenosis. So when we for the surgeon, the challenge is there will be ductal tissue. So we have to excise all the ductal tissue and then repair the coarctation. When we leave a ductal tissue there, it is a source of recoarctation. That's one thing. The second thing is basically the neonatal tissue are prone to recoarctation. Suturing technique is very important, and we have modified that technique by what is called an arch advancement. I'll show in my slides what we do and how we publish. That helped us to prevent recoarctation, and touchwood in our series, recoarctation is almost zero nowadays.
Right. But I think most important question here is as pediatricians, this is one of the common conditions that we miss. So Dr. Vishwanath, please tell the PGs here, what are the precautions they should take so as to not miss any baby with coarctation? What are the simple clinical pointers? And before we refer the baby to the surgical expertise, to the surgical team, how do you immediately stabilize this baby with coarctation?
The clinical findings would be there would be pulse difference in the upper limb and the lower limbs. And when you want to stabilize, because they present more with shock. So giving a fluid bolus or giving appropriate fluid is most important. And when you suspect coarctation or duct dependent, start prostaglandins as early as possible. So fluid management and PG even, these are the two things. And if any ventilation is required, just optimize the ventilation and maintain a normal pH, normal PCO2, and lactate, of course, should be less than 2 or 3 max. And just maintain adequate systemic perfusion with a urine output of around 1 ml per kg per hour. This should be the management strategies to stabilize.
So for all of us, again and again, palpating the femoral pulses, not only at birth, but repeatedly during the postnatal rounds, making sure when the baby is coming back for postnatal visits, especially with some complaints like respiratory distress, baby not looking, color not looking good, off color, again reassessing femoral pulses, because on the first few days, and PDA can take many days to close, femoral pulses may be present even in a baby with a duct-dependent systemic circulation. So going back and looking for this sign again and again can be so valuable, because there are cases of coarctation that get missed for sometimes for days together, and we see babies coming back with very severe LV dysfunction. Nagarajan sir, anything you would like to add here? Pre-op, post-op?
So the post-op wise, I would say, if still patient is in shock post-op and the surgical repair is good as is usual, look for other places of obstruction. Coarctation could be associated with some aortic stenosis or could be associated with some mitral stenosis gradient across there or an LVOTO. So those are the things which would have to be ruled out. Post-op, again, the shock could be because of biventricular dysfunction. It could be that LV is alone biventricular or an LV dysfunction. So a lot of inodilators, they would require post-operatively. And if it's a lot of hypertension is persisting, some amount of levodopa beta blocker also would be required for these patients.
Okay, so I think we will stop here. We had a last case, which was a high output CCF secondary to vein of Galen malformation. So this was one case, a similar case that recently Dr. Sudeep helped us achieve embolization of vein of Galen malformation. So this is another DD to be looked for when you have a baby with a high output cardiac failure where we do not find any intracardiac shunts, no PDA, no VSD, baby having persistent high SVC flow, RA, RV enlarged. This is one of the DDs, in addition to some other differentials also, including a portal venous communication, portosystemic shunt as well. So to summarize, I'm sorry that we took longer than what was planned. The carry-home messages from the whole panel are the following: that many or most congenital critical heart diseases are amenable to good outcome. And Anil sir is going to further elucidate on the surgical aspects. Dr. Sudeep also has some more talks where he is going to talk about the role of device closure in some of these conditions. But early detection, prompt referral to a cardiac unit, and the important role of simple tools, non-invasive tools like pulse oximetry screening that all of us can do to pick up these babies early is so vital. Of course, we have the expertise of fetal medicine experts like Chinmay ma'am, who are able to indicate some of these lesions very earlier on, even in the prenatal phase. And that would again call for planning delivery in a tertiary care or in a cardiac center. And not every cardiac lesion is an indication for termination. I'm sure ma'am will be discussing about it in her slides as well. So early detection, prompt referral, appropriate pre-op stabilization can go a long way in intact survival in many of these cases. And slowly, as NMR across our country is coming down due to other causes like prematurity, sepsis, and asphyxia, the contribution of congenital lesions, particularly congenital heart disease, is going up, and this is already being seen in states like Kerala. So it requires commitment from all of us stakeholders, pediatricians, obstetricians, fetal medicine experts in taking this process forward and help children with heart diseases achieve a near normal outcome. And to begin with, simple things like a good clinical examination, repeated assessment of femoral pulses multiple times before discharge, a pulse oximetry screening, and echocardiographic assessment wherever indicated can help us detect these lesions early so that we can refer them early to cardiac centers. Thank you. And I think we have no time for questions. We will conclude the panel here. You are all free to interact with our panelists, Dr. Sudeep, Anil sir, Dr. Vishwa, Dr. Nagarajan sir during the tea break. But since we are running short of time, we'll conclude the panel. I thank all the panelists and request you to take your seats in the chairs. And for the next session, it's my pleasure to welcome Dr. Chinmay Rath, who is fetal medicine expert and director of Resolution Diagnostics. Someone who needs no introduction to all of us. She is director of Resolution Diagnostics, which is a part of KIMS Sunshine Begumpet now. She is a mentor of so many mentors in fetal medicine.
Thanks, Arvinda.
KIMS Sunshine Begumpet now. And she is a mentor of so many mentors in fetal medicine.
Thanks, Arvinda.
KIMS Sunshine Begumpet now. And she is a mentor of so many mentors in fetal medicine.
Thanks, Arvinda.
KIMS Sunshine Begumpet now. And she is a mentor of so many mentors in fetal medicine.
Thanks, Arvinda.
KIMS Sunshine Begumpet now. And she is a mentor of so many mentors in fetal medicine.
Thanks, Arvinda.
KIMS Sunshine Begumpet now. And she is a mentor of so many mentors in fetal medicine.
Thanks, Arvinda.
KIMS Sunshine Begumpet now. And she is a mentor of so many mentors on prenatal diagnosis of KIMS Sunshine Begumpet now. And she is a mentor of so many mentors on prenatal diagnosis of KIMS Sunshine Begumpet now. And she is a mentor of so many mentors on prenatal diagnosis of KIMS Sunshine Begumpet now. And she is a mentor of so many mentors on prenatal diagnosis of KIMS Sunshine Begumpet now. And she is a mentor over to ma'am for her session on prenatal diagnosis of KIMS and heart disease. She'll hand over to ma'am for her session on prenatal diagnosis of KIMS and heart disease. She'll hand over to ma'am for her session on prenatal diagnosis of KIMS and heart disease. She'll hand over to ma'am for her session on prenatal diagnosis of KIMS and heart disease.
So a very good afternoon to all of you present here at the outset. Thank you, Dr. Aparna, for this invitation. And a very good afternoon to all of you present here at the outset. Thank you, Dr. Aparna, because it's an invitation. So a very good afternoon to I want to hear at the outset. It was quite because it's an invitation to the panel outgoing. All of you working with real time. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel outgoing. All of you working diagnosis. It was quite because it's an invitation to the panel cardiac access is there when you look at the fetal cardiac access is there when you look at the fetal cardiac access is there when you look at that how cardiac access is there the cardiac side cardiac access is there we use the right hand the cardiac side cardiac access is there we use the right hand the cardiac side cardiac access is there we use the right hand the cardiac side cardiac access is there you can split the screen and see color and effort in doing that scan. Outflow track color and effort in doing many times if it's outflow track color branching of the main pulmonary artery is very easily seen, as you can see in the picture. Now, when you report the seen, as you can see in the picture. Now, when you report the seen, as you can see in the picture. Now, when you report when we suspect seen, as you can see in the picture. Now, when you report when we suspect seen, as you can see in the picture. Now, when you report when we suspect seen, as you can see in the picture. Now, when you report when we suspect seen, as you can see in the picture. Now, when you report when we suspect seen, as you can see in the
that sites of condition somewhere else in the but message we give everybody that assessing cardiac function in the period is limited. I would not say that if a pediatric cardiologist is that see much more types of where he wants as a function. Assessments are structural and do some spectral waveforms to see the atrial contractility and things like that. Fetal cardiac evaluation is I go to the next trimester also. Challenges of size. We do the first trimester scan with the fetus is between 11 to 14 weeks. So the size of the fetus is between 45 to 85 meters. That is 4 to 8 centimeters.
So at that stage also, if we want, we can look at the fetal cardia, and we do look at least the 4-chamber view and the outflow tract. So the ISWAC guideline in the first trimester says you can get the symmetrical 4 chambers and confirmation of regular cardiac activity. That is basic. We do tricuspid regurgitation assessment for all fetuses at that stage. So at least assessing the 4-chamber view, identifying the tricuspid valve and doing a spectral waveform across the tricuspid valve is done for all fetuses in the first trimester. Beyond that, if you want to choose, there are all these things that can be checked even in the first trimester. And when push comes to shove, or a previous child has had abnormalities, or we don't see the 4-chamber view properly in the first trimester, we go ahead and do a detailed evaluation where we put color. And we look at those 2 signs, the 2 parallel flows into the ventricles, and the V sign and the Y sign to look at the outflow tracts in the first trimester. So if you just see that this is the first trimester fetus, and if you achieve Y sign to look at the outflow tracts in the first trimester. So if you just see that this is the first trimester which are parallel, and outflow tracts which cross over each other at 90 degrees. And the obvious abnormalities in the first trimester where there is chamber asymmetry, or there is some degree of malalignment, even right-sided aortic arch, I think one of them is there. That's a right-sided aortic arch picked up in the first trimester. Now, picking up in the first trimester is good, but as long as you can supplement it with sensible counseling and explanation, because otherwise, like I said, anytime you raise a red flag on the fetal heart. Now, picking up in the first trimester is good, but as long as you can supplement it unless you sensible counseling and explanation, because otherwise, like I said, anytime you raise a red flag on the fetal heart. Now, picking up in the first trimester is good, but as long as you can supplement unless you sensible counseling and explanation, because otherwise, like I said, anytime you raise now, picking up in the first trimester is good, but as long as you can supplement unless you sensible counseling and explanation, because otherwise, like I said, anytime you raise so there is a checklist that picking up in the first trimester is good, but as long as you can supplement unless you sensible counseling and this is because otherwise, like I said, anytime you raise so there is a checklist. Picking up in the first trimester is good, but as long as you can supplement unless you sensible counseling and these kind of abnormalities should not be missed anytime. So there is a checklist. Whenever the first trimester is good, but as long as you can supplement unless you sensible counseling and these kind of abnormalities, structural defects, miss anytime. So there is a checklist. Whenever the first trimester is good, but as long as you can supplement unless depends on how is these kind of abnormalities, structural defects, miss anytime. This is where so there is a checklist. Whenever the first trimester is good, but our job in the fetal unless depends on how is these kind of abnormalities, structural defects, miss anytime. This is where so there is a checklist. Whenever the first trimester is good, but our job in the fetal unless depends on how is these kind of abnormalities, structural defects, miss anytime. This is where the problem is so there is a checklist. Whenever the first trimester is good, but our job in the fetal aware of this depends on how is these kind of abnormalities, structural defects, miss anytime. This is where the problem is so there is a checklist. Whenever the first trimester is good, but our job in the fetal aware of this depends on how is these planning delivery structural defects, miss anytime. This is where the problem is so and these whenever the first trimester is good, but our job in the fetal aware of this depends on so how is planning delivery structural defects, miss anytime. This is where the problem is so and these whenever the first trimester is good, but our job in the fetal aware of this depends on so how is planning delivery structural defects, miss anytime. This is where the problem is so and these whenever the first trimester is good, but our job in the fetal aware of This is another 32-year-old IVF concept was referred because of a VSC and with overriding aorta. But when we did the scan, we found that there was a VSC. This is another 32-year-old overriding of the aorta, and she continued concept was referred because of the baby has been overriding of the aorta. But when we did the scan, we found that there was because they go wherever they deliver, they go to overriding of the aorta, and she continued now the baby has been overriding of the aorta. So when we did the scan, we found that there was problems are wherever they deliver, they go to overriding of the aorta, and she continued now go ahead wherever the baby has been. This was an ABS diagnosis when we did the scan. ABS problems are wherever they deliver, overriding of the aorta, but finally she continued now go ahead wherever the baby has been. This was an ABS diagnosis when we did the scan. ABS problems are wherever they deliver, overriding of the aorta, but finally the recurrence will be less. Go ahead wherever this is, I think, this was an ABS diagnosis when we did the scan. ABS is the right wherever they right side is your left, the recurrence will be less. Go ahead wherever this is, I think, this was an ABS diagnosis when we did the scan. ABS is the right wherever they right side is your left, the recurrence will be less. Go ahead wherever this is, I think, this was an ABS diagnosis when we did the scan. It's not just an issue later on, but right now it doesn't seem it's not just an issue later. You can see that left side it's not you can see that. So when you see an abnormality, it's not just including major manner. You can see that. So when you see an abnormality, it's not just including major manner. So when you plan review all the abnormalities, it's not just including major. So when any single you all you know, at least the baseline. So when any single you all at least the baseline. at least the basic mention it in language we have multiple mention it in language we have multiple mention it in language we have multiple mention it in language we have
యూట్యూబ్ సపరేట్ జూమ్ సపరేట్ అన్నమాట నేను జూమ్ నీకు
Dr. Sukush Bhaskar sir on the dais.
వినయ్ ఒకసారి వినయ్ ల్యాప్టాప్ పిపిటి ఉందంట.
Next, I would like to call upon Dr. Chinmayi ma'am. Dr. Anil Dharmapuram,
host చేస్తాను.
consultant cardiac surgeon. Dr. Sudhakar sir, PO, KIMS Hospital. Dr. Nagarajan sir, senior cardiac anesthetist. Dr. Sudeep Verma sir, consultant pediatric cardiologist. Dr. Parag sir, PICU intensivist and head of PICU KIMS Kondapur. Dr. Aparna ma'am, senior consultant neonatologist and HOD NICU Kondapur. Requesting all KIMS consultants to come on the stage. Dr. Bhavani Dittu, consultant neonatologist, KIMS Gachibowli. Dr. Kalyan sir, PICU consultant Kondapur. Dr. Srividya, consultant PICU. Dr. Vishwa, neonatologist, KIMS Kondapur. Dr. Veena, consultant obstetrician.
Shubham Kurutvam Kalyanam Arogyam Dhanasampadam Shubham Kurutvam Kalyanam Arogyam Dhanasampadam Shatrubuddhi Vinashaya Dipajyotir Namostute Dipajyotir Namostute Shubham Kurutvam Kalyanam Arogyam Dhanasampadam Shubham Kurutvam Kalyanam Arogyam Dhanasampadam.
Very important question. So I kindly request everyone to stay back and please make the most of all the sessions because there are a lot of excellent sessions coming in, including session on arrhythmia, cardiac failure by KNR sir and Dr. Prashant Patil, Dr. Sudeep session on chest X-ray and many more. But before we proceed, I'm just going to request Dr. Sunkoj Bhaskar sir and Dr. RSP Sri Krishna, who have represented PATS today amidst all their busy commitments. They are coming from very far, actually. Sir comes from the other end of the city. So please share your few words of wisdom, Bhaskar sir, followed by Dr. RSP Sri Krishna. Thank you always for the support of PATS, for all the academic initiatives we undertake. IAP TCB said they could not join today because of the ongoing election code. Request you to share a few words.
And also, PATS is proud to associate with KIMS Cuddles Kondapur because of late there have been so CME programs. Almost I myself have come here 5 or 6 times and the scientific sessions. This symposium on pediatric cardiology is really useful to all the practicing pediatricians. I still remember way back in 1995, Dr. Ranjit used to come from Chennai once in fortnight to see pediatric cardiac cases at CDR hospital. That time, CDR Children was a corporate hospital. And Dr. Balakrishna from Railway Hospital, Chennai, used to come to Hyderabad once in a month to do some surgeries. Dr. Magan, CDR, Dr. Ranjit, Dr. Balakrishna used to come here. So, this pediatric cardiology, unlike other subspecialties, cardiologists. Just now I was talking to the cardiologist at Hyderabad, is none other than Dr. Nageshwar Rao. He said there are 15 pediatric cardiologists. Hyderabad needs at least 30 pediatric cardiologists. 30. Because the way pediatric cardiology is expanding, take a lot of patients in pediatrics, cardiology, and as well cardiac surgeries. Here is entering into the pediatric cardiacs. Pediatric cardiology. Mechanical support is taking a big place in congestive heart failures. cardiac transplants, so many things. All these issues and the recent happenings. For this, I sincerely congratulate and appreciate this KIMS Cuddles Kondapur for bringing up this wonderful program. Thank you all, and I wish you a great learning experience. Thank you. Jai IAP, Jai Hind.
Good evening, everyone, and on behalf of IIP Telangana State, thank you. On behalf of IIP Telangana State, a warm welcome to all of you. I was just teaching our postgraduates at the medical college today, and the topic or the subject which is most exciting, most romantic, most loved topic of all in medicine is pediatric cardiology.
So now that we are all already doctors and we have also realized how tough this branch is, but at the same time, you have stalwarts. This is probably the best of cardiology of South India under one roof, and all credit to KIMS for putting them all together, the best of pediatric cardiologists under one roof. Thank you, KIMS. KIMS has always been very supportive of all academic programs, and from IAP, it's a pleasure for us to collaborate with KIMS for more such workshops. So wish you all a wonderful learning.
And thank you, Dr. Aparna, Dr. Parag, and the entire team. Over to you. Thank you.
Thanks. So we next have the talk. But before that, because Pat's office bearers, I'm going to request sir, kindly felicitate Dr. Bhaskar sir and Dr. Shri Krishna with a small memento on behalf of KIMS. Sir, please come on to the stage. I request both Pat's office bearers also on stage. And Dr. Chinmay ma'am also is going to I'll request Anand sir to please give to ma'am, all three of them. So आप शेख सर लेके चलो श्री कृष्ण सर नहीं लेकर सर्टिफिकेट सर क्या है भास्कर सर Thank you, sir, and thank you all the dignitaries. So we now move on to the session by Dr. K. Nageshwar Rao, sir. We all know that sir needs no introduction at all. Senior pediatric cardiologist, head of the department, a pioneer in pediatric cardiology with Rainbow Heart Institute. Sir has a lot of devices and patents to his credit and numerous international national publications. And he has to his credit fellowship and DNB training programs in pediatric cardiology. Over to you, sir, for your enlightening talk on interpretation of ECG and arrhythmias.
Thank you very much, ma'am. Can I have slides, please? Remove that. Most probable reasons for that non-availability of the test. Many centers, they don't have ECG to take the children, infants. You depend on other where the suckers used to be kept on such earlier days. Okay. I saw that. The bruise, ecchymosis, and it lasts for many weeks. That tends to be the scenario. Having done the ECG, reading the ECG becomes a very difficult part and looking very confusing. That's why not many pediatricians they advise ECG. In reality, it is not so. So taking ECG, and if you go by systematic approach, it's a much more easier than any other investigation modality. So I'll be covering essentially a little bit advanced rather than a basic ECG, the conduction system, physiological rhythm abnormalities, tachy, long QTC and brady. I can stop at any time. The time allotted is approximately around 25 minutes, but I will try to reduce as less as possible. So if you know that the sinoatrial node, which is somewhat SVC-RH junction, for remembrance sake, exact location, anatomy and all not required. So from which there are three internodal tracts, the anterior, middle and posterior, and there is a left atrial tract separately. That's why whenever you have a left atrial enlargement, you see bifid P wave. The P wave is a summation of both right atrium and left atrium. From there you have the right. Okay. So from there you have AV node, the his bundle, left bundle and right bundle, left bundle again divides. So the electrical summation of all this will be represented in the surface ECG is the various waveforms and intervals in the name of P wave, PQ interval, you call it as a PR interval because Q wave sometimes may not be seen, QRS complex, ST segment, T wave, and sometimes you may see E waves. So all cells in the heart are potentially arrhythmogenic, excitable. Like you saw simple muscle twitch during your physiology, frog dissection, you have a action potential, a summation of many cells. So similarly, every cell is a cardiac excitable cell. But there is a hierarchy. In olden days, in our grandparents, great-grandparent, grandfather used to control the father and family, father used to control the children. Similarly, SA node controls the AV node controls the bundle and Purkinje fibers and cardiac cells. If there is any hyperexcitability, insult, injury, or any electrolyte disturbance, all these things can trigger the arrhythmia. The arrhythmia can be automatic, that is, the cell itself can be excitable, or re-entry, the cardiac electricity will be circuiting in one particular area, either micro re-entry or macro re-entry, or triggered activity during the action potential. You will have the early after depolarization or little bit later called late after. So all these things, this is very important diagram, whoever is managing the arrhythmias, to understand the cardiac action potential of phases 0, 1, 2, 3, 4, where resting membrane potential minus 96 to it comes to plus 52 with the inward cardiac current of sodium and potassium out, again excitation contraction coupling, again potassium efflux. Then you have these phases. Based on that, these are the medications which are going to act at action potential of various phases. So let us start with a little bit very normal scenario of an ECG. Some of the diagrams are taken from the library. Most of the diagrams are our own case scenarios. A normal QRS complex has got a preceded P wave. P wave is lesser than 3 millimeter, duration 3. millivolts height, PR interval QRS, you can see that this is called a sinus rhythm. So all ECGs are taken at 10-second interval, 10 seconds period. The lowest one is the rhythm sweep. You start seeing at the age of the patient, the standardization, the speed, and then come down to the lead 2, which is the rhythm strip, and then start reading it. So rhythm is going to be very important when you are diagnosing arrhythmia. This is a normal sinus. Is preceded by P wave. Very simple. The P wave is normal, QRS is normal. It's only the interval which is lengthens and shortens. That is because of the vagus nerve, which is going to be somewhat more excitable during expiration. During inspiration, more volume causes the high heart rate. During expiration, because of the high vagal tone, there will be, you can see that the cycle length is increased bradycardia. That causes a lot of confusion. And also you see in several children with the respiratory tract infection and also dengue fever, whatever the viral infection gets admitted in the hospital, you will have that. The sinus arrhythmia is an irregular heart rate occurs with respiration. During inspiration rate goes up by and then. So this is the commonest thing which we see, and the treatment, no treatment is required. It's just a normal hyperactive child or whatever it is. This is sinus bradycardia. You can see the heart rate is very, very significantly low here. The common conditions with physiological condition with sinus bradycardia is the athlete. You know that Rafael Nadal heart rate used to be 38 to 42 because highest this one. Even Virat Kohli heart rate was around 45. So the athletes and sports person, they do they develop a athlete heart and their vagal tone is high. Their cardiac output at resting is maintained with the lower heart rates itself. You know what is the whale's heart rate? Anybody? Whale's heart rate? Whale, the largest mammal. Very good. So heart rate with exercise, prematurity, sometimes dysregulation of the autonomic nervous system, medications, diphtheria, sudden infant death syndrome, all this can cause. An interesting case, several times I diagnosed this condition not by referral, by looking at the ECGs. So 7 years old child with dullness and short stature. The interesting thing is relatively bradycardia here. You can see the heart rate is 54, the voltages are low. We did thyroid test, you can see the TSH is high level. So hypothyroidism sometimes will produce with bradycardia. Several cases we actually diagnosed based on the ECG alone. Sinus tachycardia is the commonest referral, sometimes in infants during nasal block, sometimes nasal block, otitis, mild fever, cough, irritability, colic, all this can cause sinus tachycardia. And you should know the normal rates at various ages. How to differentiate? Sometimes you will get confusion. Where is the P wave? Here you can see the P wave is on the descending limb of the T wave of the preceded beat. But the important thing is the PR interval will be maintained in all cases, PR interval, and P to R also will be, RR intervals will be maintained here. So sinus tachycardia, fever, anxiety, anemia, systemic disorders, rarely pathological inappropriate sinus tachycardia. For no reason you will have tachycardia over the period of time. they develop a cardiomyopathy, where sometimes we may have to do that sinus node ablation, or very rarely beta blockers also may usually will reduce the inappropriate sinus tachycardia. So in general, 5% of pediatric emergencies are due to pediatric arrhythmias in children. The tachyarrhythmias or bradyarrhythmias. The tachyarrhythmias are again divided into narrow QRS tachycardia, wide QRS tachycardia. Bradycardia is due to sinus bradycardia or variable degrees of heart blocks. So whatever it is, the mechanisms here, as I told you, either it is a re-entry tachycardia, automaticity here, accessory pathway, a triggered activity, or heart blocks at various stages. All these are micro mechanisms or pathological mechanisms to produce all these things. Here you can see that the P wave here is abnormal. This is another type of P wave than it is. So this is an ectopic atrial rhythm, or if you have different P waves, you can call it as a multifocal atrial tachycardias. So premature atrial contractions are quite benign, and it is probably due to fever. Even sometimes you go to barista coffee center, have a strong coffee, you'll get the palpitations and the ventricular premature complexes if you take the ECG. So in tachycardia in children, the heart rate more than 220 in infants, more than 180 in children more than 2 years of age are prone for the heart failure. So to read that, you have to see the conduction, whether P to R interval, what is the QRS duration, broad, narrow, regular, irregular. So P wave may be before the QRS or within the QRS or after the QRS. Most of these tachycardias, it may be very difficult to find out. If you find a P wave, then you always check the duration between the R wave to P is called as RP interval. We are not measuring the PR interval, we are measuring the RP interval. Suppose if there is a circuit which is going on, the accessory path which goes retrogradely fires the atrium, so that it's a good idea to check the P wave first and then see the relationship of the R wave to P wave and duration between the R to P. If the R to P duration is lesser than 70 milliseconds, it's called as short RP tachycardias. If it is more, it is called as the long RP tachycardias. Short RP tachycardias generally are narrow QRS and rapid in heart rate, that is more than 220. They present very quickly with shock, or mother will notice that baby is having a refusal of fits. Whereas the long RP tachycardias, generally it's unnoticed and they present with a tachycardia cardiomyopathy. So physician will be confused whether it is viral myocarditis or tachycardia causing cardiomyopathy. So however, the mechanisms, as I told you here, you can see the pre-excitation. There is an accessory pathway. Instead of going from SA node to the AV node, it takes the bypass track, and you will see in the ECG a slurred PR interval called as the delta wave. Sometimes the conduction is going reverse direction called as orthodromic AV tachycardia, that is antegrade. The information from that rather than going didactically. So they went to cardiac surgery. He went back to Kenya and posted this ECG, and those patients are having some palpitations. So if you look at here, you can see that the P wave here, P wave here, P wave, different morphologies are there. So this is called as a multifocal atrial tachycardia. If there is any postgraduates here, postgraduates. So what are the differential diagnosis for irregular pulse? It's a commonest question by our medicine professors. They used to ask. Number one, atrial fibrillation. Second, multifocal. If there is any postgraduates here, with variable postgraduates, these are the. So what are the differential diagnosis? Irregular. The mechanisms are the commonest question by our medicine professors. They used to ask. Number one, atrial fibrillation. Irritable followed by multifocal. If there is any postgraduates here, with variable postgraduates, these are the. So what are the differential diagnosis? Irregular. The multifocal atrial tachycardia. The P wave morphology should be more than 3. You can see here a different type of P wave, another type of P wave, and different type of P wave. So if you have different types of P wave with the QRS preceded by QRS is that, then you can call it as a multifocal atrial tachycardia. Again, multifocal tachycardias are benign and they don't need any treatment. Check the electrolytes and magnesium or any of this kind of history. Multifocal tachycardias in fetus may cause sometimes hydrops or cardiomegaly. Very rarely, we have seen only one case so for multifocal tachycardia with cardiomyopathy in a neonate. Otherwise, by and large, those are all asymptomatic. So this is a baby, a neonatologist was following for hydrops or cardiomegaly. Baby had very rarely, we have seen only one case so referred to multifocal tachycardia with cardiomyopathy. These are all neonate. Some of the otherwise, by and large, those are all asymptomatic. Period of time I did not. So this is a baby, a neonatologist was following educationally hydrops or cardiomegaly. Baby had very rarely, we have seen only one case referred to inverted tachycardia with cardiomyopathy. These are all neonate. Otherwise, AVF. Normally, the 2-3 AVF. So the PVF will be a baby. That means educationally, the focus is not coming from very rare somewhere in the AVM. Most probably cardiomyopathy. So this will be 3 AVF. So PVF will be a baby. That means the focus is not coming from very rare somewhere in the AVM. Most probably medication which we will discuss later. So you have to ask but so you essentially not rare. So you essentially some of not rare. Absolutely. Restoration of the sinus rhythm. So adenosine Dr. Aparna, anytime you can tell me to stop. I don't know the timer. So this is 30 weeks. No medication. And again 30 fetal Dr. Aparna, anytime you can tell me to stop. So this is 30 weeks. No medication. We saw Dr. Aparna, anytime this is the we saw Dr. Aparna, anytime this is the we saw Dr. Aparna, anytime this is actually improved very well, and followed by adenosine. Improved very well, present and followed by adenosine. Improved very well, beta blocker and followed by adenosine. Improved very well, beta blocker and followed by adenosine. Followed by followed by followed by followed by tremendously well. Refractory cases like this, here you can see a patient referred during antenatal period, which we could not manage with multiple medications. We had to do the delivery, and then you can see the tachycardia with there was high drops also, and given adenosine, but no improvement, drifting back here. Again, we gave DC version, no improvement because it's a atrial tachycardia which is not good. That's why it is not a fast tachycardia. Fast tachycardias are good because they get terminated very fast. Whereas the slow tachycardias anywhere between 180 to 200, they don't generally respond very well with DC version. Like to remember this point, usually they are atrial tachycardia. So this patient was having a ventricular dysfunction. We had to start amiodarone infusion, and the child had cardiac arrest, resuscitated, and again improved. You can see that the post improvement of maybe ventricular rhythm. This point, atrial tachycardia. So this patient was having sorry for that particular slide is not there. So child was started on amiodarone. Patient improved very well. So this particular patient with atrial flutter obviously referred but immediate medications did not work. Amiodarone started, did not work. Then again we had to intubate the baby and continued amiodarone and beta blocker over the period of time. So why I am telling all these case example, the algorithm of treatment starts with a stable patient beta blocker or adenosine if they come, if they are in remote stage where adenosine is not available, propanol and adenosine if they over the period of time. So why I am telling all these case example, the algorithm of treatment, circulatory failure or amiodarone in case of semi-elective case or semi-urgency case. So junctional tachycardias are rare in children, usually predominantly confined to postoperative jet. Postoperative algorithm of treatment, circulatory failure or amiodarone in case of tachycardias are due to postoperative intracardiac repair. They have different algorithms to manage the first cooling of the baby, reduce the inotropic support, then we straight away start amiodarone, not earlier medication. So that's a separate section probably. This is not the forum to discuss that. But however, I will show you one case. This is a 6-year-old child underwent a Jennings procedure for a deconstruction of great vagina, and you can see the P wave which is inverted here going on, having the tachycardia for a long time here, and this improved over the period of time with the beta blockers. So sending fetal tachycardias born LSCS or fetal tachycardias in near term cannot be managed intrauterine, should be delivered. They will have different set of problems: airway edema, chest wall edema, lung compliance is poor, pulmonary edema, ventricular dysfunction, requirement of the surfactant. All these are the combination of the problems which needs to be addressed. Sometimes we have to put the chest tube, we have to drain the ascites as well. Chest wall edema, lung compliance is poor, pulmonary edema, ventricular dysfunction, requirement of the surfactant. All these are the combination of the problems which needs to be addressed. Sometimes we have to put the chest tube, we have to drain the ascites as well. Chest wall edema, lung compliance is poor, pulmonary edema, ventricular dysfunction, requirement of the surfactant. So as I earlier told you that paraQRS tachycardia, you have to see the A to V ratio 1:1. If the interval is lesser than 70, AV-NRT prognosis is excellent with adenosine and beta blockers. And if the RP interval is more than 70, WPW beta blockers in grown-up children, you can do calcium channel blocker. Eventually, they will go for the electrical ablation treatment. AV-NRT is the refractory cases. You need a combination of treatment. If the atrioventricular ratio is more than 1:1, so you have atrial flutter, atrial rate beta blocker, or multiple atrial ventricular tachycardia. Predominantly medical follow-up, no medication in case of multifocal. The combination lesser than 1:1, generally ratio is more than amiodarone to have the conversion to sinusoid. Now refractory to adenosine beta blockers are very important. Children, we don't recommend calcium channel blockers. Negative chronotropic response, inotropic response. They actually develop cardiac arrest. That's why it's dangerous to give verapamil and diltiazem in less than 2 years especially. Refractory to adenosine beta blockers are very important. Children, we don't recommend calcium channel blockers. Negative chronotropic response, inotropic response. They actually develop cardiac arrest. That's why it's dangerous to give verapamil and diltiazem in less than 2 years especially. Refractory to adenosine beta blockers are very important. I will just skip off this. I'll show you 1 or 2 cases. So this is a 3 months, a very old case actually. You can see the wide QRS. The QRS axis is indeterminate, and you see everywhere it's wide. So it's did not respond to any medications. The physician told me, I saw as usual cardiologist comes. You expect, parents expect, and we also do the echocardiogram. So similarly here, the echo showed that there's an abdomen. See, everywhere it's wide. So it's did not respond to any medications. The physician called me. I saw a usual cardiologist comes. You expect parents expect, and we also do the echo. Similarly, yes, the echo showed that there's an abdomen. See, everywhere it's wide. So it's did not respond to any medications. The physician called me. I saw a usual cardiologist comes. You expect parents expect, and we also do the echo. Similarly, yes, the echo showed that there's an abdomen. See, everywhere it's wide. So it's did not respond to any medications. The physician called me. I saw a usual cardiologist comes. You expect parents expect, and we also do the echo. Similarly, yes, the echo showed that there's an abdomen. See, everywhere it's wide. The physician called me. I saw a cardiologist comes. You expect parents expect, and we also do the echo. Yes, the echo showed that there's an abdomen. See, everywhere it's wide. The physician called me. I saw a cardiologist comes. You expect parents expect, and we also do the echo. Yes, the echo showed that there's an abdomen. See, everywhere it's wide. The physician called me. I saw a cardiologist comes. You expect parents expect, and we also do the echo. Yes, the echo showed that there's an abdomen. See, everywhere it's wide. The physician called me. I saw a cardiologist comes. You expect parents expect, and we also do the echo. Yes, the echo showed that there's an abdomen. See, everywhere it's wide. The physician called me. I saw a cardiologist comes. You expect parents expect. Myoclonus, it's a stroke Adams attack. So we observed and we connected the monitor and we did the ECG, and you can see the ECG. It is a polymorphic VT, a tarsa disc polymorphic VT. So what are the commonest cause? Any postgraduates? Long QTC syndrome. Very good. This patient is having a long QTC syndrome. The QTC interval is quite significant, more than 500. You can know the Budget's formula, how to measure all these things, which is available. You can read. We did genetic test, which showed long QTC 3, and then we had to give a treatment called vaccination to this baby. Thank you very much for your kind attention. 500 I think that gives information what medication at what stage. I don't need to tell the conclusions and summary.
Thank you, sir, for that amazing and elaborate talk on approach to arrhythmias. So we would like to express our gratitude. Please.
What is your experience with post-surgical? Absolutely, very good question. And ivabradine is nowadays is coming. It's not a monotherapy, but a combination of medications. It works very well, especially post-operative jet. You can start ivabradine along with beta blocker, or amiodarone and ivabradine is useful. And also inappropriate tachycardia. If there is a tachycardia which is disproportionate, irrespective of whatever it is, sinus or whatever it is, even jet also, ivabradine is going to be useful. Even if there is a myocarditis, with overt heart failure is controlled completely, and only sinus tachycardia, which is persisting, ivabradine is going to be very useful in these particular scenarios.
So one more thing, sir, emerging role of ibutolite where sometimes flutter won't respond to that, sir.
Yeah, those are all medications which are tried ibutolite. Sotalol also has a good conversion rate. But in children, we most of the times extrapolate the data. So we can tell all those things, but at the pediatrician level, you are in ICU, which is comfortable, what is the medication which you have maximum experience. You try to play with those medications and combination, because side effects also sometimes are more dangerous. One of the case I still remember some 10 years back, by the time I reached, they gave IV dilcham injection to a 3-year-old child, cardiac arrest happened. We had to put a pacemaker, and it took a long time, stormy course, renal failure, all those things. So that's the reason medications are there, but you have to choose appropriate medication with the combinations, and physicians should have very comfort zone to treat the child with that kind of medication.
Thank you.
Sir, one small. For resistant arrhythmias, we have to go for amiodarone, right? Amiodarone is the last drug. If you do a radio frequency ablation for the children, RF field or cryo, how do you map it?
No, in case of tachycardia acutely, you manage with the medications, amiodarone, whatever it is. In case if it is not manageable with all these medications, then we have to take for the radiofrequency ablation, that's for sure. If it is a 3D mapping is available, NAVEX, in a complex arrhythmia, it is going to be useful so that you can do that. Whether it is a cryoablation or radiofrequency ablation, I think it's an electrophysiologist will decide what type of path and all. It's a beyond scope, our scope to discuss that part. We don't need to discuss because there are a lot of advancements happened in radiofrequency ablation. A standard radiofrequency ablation for AV-NRT, AV-RT is regularly being done and commonly safely can be done. In case of complex arrhythmias, ventricular tachycardias, or you have a pulmonary vein isolation, those are the things you need this kind of all this.
Thank you, sir.
Thank you, sir. We'll continue our talks. Our next important talk is by Dr. Anil Dharmapuram, sir, Senior Consultant Cardiothoracic Surgeon, on neonatal critical cardiac surgery, the evolution. And to chair this session, I would like to call upon Dr. Neonatologist and Dr. Chandrasekharam, sir, Senior Consultant Pediatrician and Neonatologist, onto the stage.
Alimeru ma'am is the Professor of Pediatrics at MJ Medical College, Warangal. She has great interest in neonatology and has been taking care of newborns in Nilofer for a long time. Very passionate neonatologist. Thank you, ma'am, for taking leave from MGM Warangal and attending the session today. We request you to take the chair on the dais. And Dr. Chandrasekhar, sir, I think, sir, yes. Sir is Professor of Pediatrics at Malla Reddy Medical College. Again, he's a MD postgraduate from AIMS and a very keen participant even today in all the conferences, CMEs that we do. So thank you, ma'am and sir, for chairing this session, and over to Anil, sir.
Thank you, Dr. Aparna, for this opportunity to talk here in this forum. I would just like to make a brief presentation on neonatal cardiac surgery. Some common lesions which we discuss. I don't want to take too much time on the slide. When you classify diseases in the heart, cyanotic and acyanotic, so I will focus on the acyanotic lesion, coagulation of aorta, and cyanotic lesions, transpiration and TAPVC. Today, just to tell everybody that in India, we're able to perform complete correction in complex lesions in neonates. Examples are coarctation of aorta, TGA that requires arterial switch operation, and TAPVC, the total pulmonary correction. And it is possible today to correct intracardiac defects like VSD associated with arch interruption or coarctation. We all should remember that outcomes today in India are equal to any advanced country in the West. And good corrections in neonatal age for these lesions, if they have two good sized ventricles, give normal life to the baby, and the babies grow normally like any other child and have a normal and have normal neurodevelopment. To achieve good outcomes in neonatal cardiac surgery, we need a good hospital infrastructure with advanced cath lab and a modern operation theater and efficient blood bank and a dedicated team. The most important is that, and predictable and promising postoperative skilled nursing. When I mention team, it's a complete team. So a cardiac surgery in neonate cannot be performed alone. It's a team effort. I should mention my colleagues here, my cardiology colleagues, Dr. Gautam and Sudeep, my surgical colleague Rajani, who is here, and an anesthesiology colleague Dr. Nagarajan, and a perfusionist, and intensive care, neonatal care. Dr. Aparna's team here, and Dr. Parag's team, Dr. Kalyan is here. They're all part of the team to execute a cardiac surgery in a complex cardiac surgery in the neonate. A modular theater looks like this to show you. It's the theater the environment, like it's a modular flow. That means there's no infection. There is always a continuous air which is clean and sterile. You can see the heart-lung machine here, and the perfusion is sitting there. And the heart-lung machine here, the perfusion is sitting there, and surgical and when you do an anesthesia technique, it's all done in a very sterile way, and it's because the open heart surgery, baby is subjected to heart-lung machine, and immunity is very low for a baby post-operative. So we have to be extremely careful in a theater to give the maximum aseptic technique for the procedure. You can see the heart-lung machine and hemotherm. This hemotherm is a machine to cool the baby's body temperature to hypothermia, to low levels of temperature. And you can see the heart-lung machine, which is roller heads, which run the pump. So when we talk of open heart surgery, this is called oxygenator, and the heart is completely stopped, and the heart-lung machine takes care of the heart and lung function during surgery. And we stop the heart. That is, we give what is called cardioplegia. This is a cardioplegia delivery system which is done at low temperature. So the heart is stopped with high potassium solution, and then the surgery is performed. So common emergencies in neonates, I will focus today on transpiration, switch operation with VSD or without VSD, TAPVC, coarctation of repair thoracotomy, and then interruption coarctation repair with VSD. We're using requiring complete repair. The first case scenario I would like to tell about a 20-day-old term neonate with cyanosis and rapid breathing. The pericardium is silent, no murmur, and the room air saturation is 60%. The diagnosis is TJ with intact septum. There's no VSD. So what do we do? Issues to be addressed are: what are the emergency measures to be taken? What is the role of intervention? Prostaglandin, and then if the patient presents later after 2 months, what is the plan? So management plan for a baby like this, the transpiration before 4 to 6 weeks of age, if symptomatic, early surgery has to be done even during first week of life. If it is delayed, surgery is delayed, then BAS, as we discussed in the forum before, septostomy can be performed, or a PGA prostaglandin can be used to tide over the crisis. If delay is more than 4 weeks, then the left ventricle will regress in transpiration. Then we cannot do a switch operation. Then we do atrial switch, that is called sending operation, or a trial of LV retraining with PA band and PDS stenting, which is very difficult. Surgical options in a baby like this is TJ with intact septum, 4 to 6 weeks of age, switch operation can be performed right away. If after 6 weeks, if the LV regresses, then we do what is called our atrial switch, because arterial switch is not possible. And if the TJ has got a VSD by 3 months of age, I mean, VSD can be performed along with switch operation even as early as 1 week of age, but beyond 3 months of age, there will be high mortality because of the risk associated with pulmonary hypertension. The current case is a switch operation. So this is a pictorial diagram of transpiration, a normal heart, and the transpiration where the LV gives us the pulmonary artery, and the pulmonary and aorta comes from the right ventricle. So in switch operation, what is to be done? We switch the arteries. It is very simple to say, but when we switch the arteries, we have to also move the tiny coronary arteries which take blood to the left ventricle. So this is the important part of the switch operation. When we move the coronary arteries, then we have to preserve myocardium, and the left ventricle function cannot be altered. So the complexity of the operation increases when the coronary artery presentation is not normal like this. See, with the left and the right are two origins. Sometimes the left they may be together called single coronary artery, or sometimes the circumflex may come along with the right coronary artery to make it more complex. So this complex routing in the translocation and switch operation is a part of the complex surgical management. I will show some examples of some slides of babies operated with due permission of families. This is a switch operation, 17-year-old neonate operated and extubated after surgery. And to take home message that when we do the operation in perfect time, in correct time, the baby will have normal life. This is the same baby, 6 months follow-up, and then they will go to school normally with like any other child, because they have normal ventricular function and they'll be a normal child. This is another example of a transpiration VSD with a small baby along with the 2.2 kg. So these babies require a lot of the postoperative care in NICU. When we in a ventilator, they require a lot of the non-invasive ventilation like this, CPAP or NIV. This is another example of a TGA neonate. You can see the baby follow-up, grown up very well, playing, and then having a normal life. Another example of a transpiration with intact septum, 8-day-old neonate, long time ago, many years ago, operated in our institution. Then 1 month follow-up, and then later on when she goes to school, you can see how normal she is. This is an example of a newborn baby, transpiration VSD, transported on day 3 of life from outstate with VSD and a single coronary artery. So this operation was very complex. So Dr. Aparna published this in the local newspaper that time about 2 years ago. This is another example of a transpiration and TAPVC in a 3-day-old baby. So in our experience, this combination of a transpiration with TAPVC is very rare. So in this, we did a combination of both switch operation and the TAPVC, and the baby did very well, and we published locally in the newspaper. So these babies, after follow-up, they do well, and it is very challenging. It is very satisfying for the surgical, for all of us to see the baby coming back to us with normal, growing normally. This is an example of a switch operation. So transpiration TGA has usually associated with VSD, but in sometimes coagulation is also associated. That makes the operation more complex. This is day 2 of life. Baby did well after surgery. So this is second case. I will tell about a 3-day-old neonate with a 2.7 kg, SATs are 88%, and with on ventilator, obstructive TAPVC is the diagnosis, infradiaphragmatic. So TAPVC, as all of you know, 3 types of TAPVC we have. So supracardiac is the way that pulmonary veins go to superior vena cava and right atrium. And then this is the vertical vein, which is now the normal left SVC location. So this is a common chamber. So what we have to do, we have to operate, when we do the operation, we have to anastomose this to the left atrium. And then this is a case of in this case, the veins are going down below below diaphragm into the liver. This is called infradiaphragmatic. This is less common than supracardiac. And the recent innovation of surgical technique of TAPVC, I mentioned in the earlier panel discussion, we do what is called sutureless technique, where we avoid taking bites on intima and only take adventitia. That is supposed to be prevent restenosis. Because in TAPVC repairs, when we do the repair of the veins to the left atrium, the anastomosis can get narrow sometimes. So to prevent, we have to be very careful in surgical technique. This is an example of the heart. You see the TAPVC the operative picture. The heart is completely stopped on pump, and then it's flipped to the right chest. and you can see the anastomosis of the left atrium to the common chamber. The chest, especially in TAPVCs, the kids are very sick post-op. In the post-operative period, sometimes we keep the chest open. That means we don't close the sternum. We close the skin and with a membrane, and then cover it with cell membrane and close the chest, because this is to give the heart and lungs more space to recover. And then close it later, and when the baby recovers better. So, and then after, you can see the same baby after extubation. So in the recent years, in our experience, chest closure is what very unusual. We primarily do primary chest closure. The babies recover very well and feed well with the nurses in ICU. Another example of a baby, a newborn baby, operated TAPVC on recovering on HFNC, and then you can see the baby post-op follow-up, how well the baby is. The baby is this is day 2 of baby of TAPVC. You can see the baby has got so many pumps there. The baby is just about 3 kilograms, 2.8, something like that. And and it's a very complex repair. They require a lot of care post-operatively with ventilation, inotropic support, and adequate and skillful nursing. And they recover well. And this is an example of the same baby, recover 1 year follow-up. This is an example of a preterm baby. This is the smallest weight we operate in our experience. This is in our KIMS hospital in Vizag. It's a preterm TAPVC, 1.3 kilogram, operated and did well, and post-operatively recovered very well. This is an example of another baby, which is very unusual to have a pre-op ECMO for a baby before surgery. Usually we have operate immediately, but ECMO has to be taken in this case, instituted in a very unusual situation in a peripheral hospital in Vizag. So, as I told you, resources can happen in TAPVC. We operate sometimes, our incidence is very less, but still we have to handle it. This is an example of a baby after operation, second time did well and they went home. Now, I want to focus on the third lesion called coarctation. This is coarctation of aorta in neonates, usually done by thoracotomy. You can see the incision on the left side of the chest, and then this is called thoracotomy, and then here you can see the lesion of coarctation of aorta, and the entire arch is hypoplastic and small. So what we do nowadays is what is called arch advancement. We place a clamp close to the innominate artery junction, innominate artery base, so that we move the descending aorta more efficiently towards the ascending aorta to prevent restenosis. You can see a postoperative picture of the same baby, and the follow-up. You can see how the coarctation is, the descending aorta is moved to the ascending aorta. It is entire arch is hypoplastic. And this is a follow-up CT angio of a baby for a academic purpose. And then we published this report in long ago in our unit in 2018. Early outcomes of our modification of our intersect repair of technique of aortic arch repair with arch aplasia in the APC Annals of Pediatric Cardiology. This slide shows a different form of coarctation. This is called interruption. You can see there is no connection between the aortic arch and the descending aorta. So when we repair, we do what is called selective regional perfusion of the brain. You can see the artery in the base. You can see the arterial cannula in the base of the innominate artery. So this is called, when we do the repair, we don't stop circulation to the brain. This is called regional perfusion, and this technique is to avoid total circulatory arrest during surgery. When we do this, what we do is you can see the arch hypoplasia in this infant, and a pictorial picture of the same baby in the intraoperatively, where how the pulmonary artery is so huge, aorta is small, and arch is smallish. And when we do the repair, we can see the cannulation of the innominate artery being done to achieve perfusion. And here, when we do arch repair is being done, when the brain is getting continuous, the brain is getting continuous cerebral flow at a particular temperature of about 22 degrees and at a flow of 40, so that there is no circulatory arrest to the brain. And this prevents long-term outcome. The baby will have normal life, and the brain out, the neurological complications of avoiding total circulatory arrest is very laudable. So this is another example of a neonatal VSD or she had done in infancy, about 1 week of life and 6 months follow-up. You can see how normally the babies recover. Overall experience. So we published this experience of regional perfusion technique long ago from a unit in 2015 in the Indian Journal. And I got a post award for this presentation long time ago in 2015 in the Asian Congress. So to summarize, our experience of the overall in our KIMS hospitals has been for complex operations. We have done quite a big number of them in the TA, PVC, TGA, and then combined arch and VSD. And recently in KIMS Kondapur, the COA in neonate that came out successfully after COA repair. And in Kondapur, recently we have been operating the neonates with the APVC, COA, transpiration switches, and combined repair and coagulation VSD. This is a recent public reports from our unit in KIMS Hospital. Thank you.
Amazing. Neonatal cardiac surgeries. Of all the neonatal cardiac surgeries, which is the more complex, more difficult to do?
No. As I told you, transpiration when you operate at a TGA, a switch operation on day 2 of life, it is it's very complex. At the same time, if you operate a TAPVC within the second day of life, immediately after birth, that is also equally complex because the veins are so fragile. And then recently, to prevent restenosis, we have been doing sutureless technique. It takes more time. So it is very difficult to handle the babies surgically in such a small weight and so early in life. As I told you, it's a team effort. It's not only surgery. Postoperative management is a very difficult job because these babies have infections that come up in the blood from the normal bacterial flora in the lung and the intestine that create a lot of problem for the intensive care to manage. That is a challenging part. Thank you.
And when you do an arterial switch, is there any coronary compromise at a later date in their life? No. Like when they go for extreme sports or?
We have long-term follow-up of our babies after up to close to 10 years who have got good ventricular function. So if the coronary arteries are, if you do a good coronary transfer at the time of operation, you should usually have no problem. On the other hand, to answer your question, the artery the pulmonary artery component will become narrow. So we have almost 5% of incidence of switch operations coming back for reoperation for the pulmonary artery segment, but very rare for coronary artery problem to have. It is known to happen, but in our experience, it's very less.
I did attend arterial switch on day 2 of life in 1992 when I was doing my residency at AIMS.
Oh, thank you.
Nair did it.
Okay.
Dr. Nair.
Okay.
Probably you are aware of him.
I trained there and a little bit later. So
Day 2, they did the surgery. We were the resident. I was the resident taking care of that.
Yeah.
And ICU cot.
It's a very challenging operation.
Very challenging.
Sir, I had few doubts. So what about the anticoagulations? How long do they continue? And
No, usually for switch operations, we give aspirin for about a month or so, not more than that. They don't require anticoagulation.
antiarrhythmics?
Antiarrhythmic, it depends because when they have a normal rhythm, they don't usually have rhythm problems. Sometimes in TAPVC, they can have some short-term rhythm issues, but they don't require any antiarrhythmics usually for this case.
Thank you. Anybody has any questions? Shall we? Yeah. Thank you, sir. Thank you so much. That was excellent, sir.
This time.
So your presentation now. Prashant. So now I invite Dr. Prashant to present his talk. Prashant is my dear friend and colleague. He's the lead department in Care Hospital, Banjara Hill. I know him from last 15-20 years. So he's an excellent pediatric cardio. Now he will deliver lecture on the update, pediatric heart failure. What is the update now?
This is slide runner. Okay, I can run with this. Thank you, Sudeep, Dr. Aparna and KIMS and IAPTCB, inviting me for this educational gathering. After such a, big talks by big people, I am going to present the pediatric heart failure recent updates. So as you know, the heart failure is a progressive clinical and pathological syndrome which is caused by cardiovascular and non-cardiovascular abnormalities, which results in symptoms due to the either poor perfusion or food retention accompanied by circulatory neurohormonal and molecular derangements. This circulatory neurohormonal and molecular derangement initially they will help to tide over the failure, but later they can be detrimental. As it is the pediatric heart failure is it's rare compared to the adult cardiac failure, but it causes significant morbidity and mortality. And unlike the adult heart failure, which is more of a ischemic and cardiomyopathy type, pediatric heart failure has a variable pathophysiological mechanisms and symptoms. The prevalence, it differs in developing countries versus the developed countries, but everywhere the most common cause of pediatric heart failure is a congenital heart defect. And with advancement in the technology, in the diagnosis and treatment, they have improved the outcome, but the challenges still remain. These are the causes of cardiac failure in the children. As you can see, the main predominantly CHD, and then the cardiomyopathy, either primary or secondary cardiomyopathy. Most common is post-viral myocarditis. This update is basically for the cardiomyopathy group, because CHD group, once you treat the CHD, the failure will improve. Most of these guidelines are derived from the adult studies. But we forget that kids are not adult, because we have a lot of various issues we have to deal with, because the pediatric causes for the pediatric heart failure are have a heterogeneous pathophysiology. They have developmental factors. The causes as per the age differs. They have difference in the genetic expressions. They have difference in the signaling pathways, and because of which there will be difference in the responses to the medication compared to the adults. But we don't have an option, because there are various challenges in conducting the pediatric drug trials, because we have insufficient numbers and there are a lot of dropouts. There are high event rates during the follow-ups. We don't have defined clinical outcomes, because every pediatric heart failure is different. Means the cause is different, the endpoints are different. So these guidelines, these updates are basically derived from the International Society for Heart and Lung Transplantation, which were published in July this year. So by then, we need to classify the heart failure, and there are different classifications. The first classification, which was suggested by ACC, AHA, these are the stages of heart failure. So you have stage A, B, C, D. A is those who for the heart disease. They don't have any symptoms. They don't have any biochemical markers which are suggestive of heart failure, but they are like, you have previous exposure to the cardiotoxic agent, family history of CHD, congenital corrected TGAs, where you expect that these kids can go for the failure. Then there is a stage 2 where you have no symptoms and signs of heart failure, but you have something on the investigations, like you have structural heart diseases, or you have presence of failing pressures like increased pro-BNP, you have invasive, you get increased filling pressures. The third group is the symptomatic, where the symptom appears, and the fourth group is where there will be advanced symptoms which will require frequent hospitalization and additional mode of treatment. The other classification which was suggested by Enroll, which is a functional classification of the heart failure, and which is modified for the kids by Ross, as everyone knows the class 1, 2, and 3, and 4. But for practical purposes, now the IS, International Society of Heart, use this classification, which is derived from the adult classification, is heart failure with reduced cardiac function, heart failure with preserved cardiac function, and heart failure with mildly reduced ejection fraction. So ejection fraction less than 40, 40 to 50, and more than 50, but with evidence of the failure. So these are the compensatory mechanism which happens when you have a heart failure, and basically the drug therapies which are directed for these compensatory mechanisms. So whenever you get a child of a heart failure, we need to assess, and the assessment remains the same. Like, you have to clinically evaluate the child, get a ECG, echo, X-ray, and then the further testing. So the additional test which has to be is advised by the ISH, International Society for Heart and Lung Transplant, is doing a PBNP and anti-PNP, which will help us to evaluate and monitor the patients with no heart failure to determine their severity, their disease progression, and their response to the therapy. And the additional investigations you can do depending upon the type of cardiomyopathy you will get, like, lactates, pyruvates, ammonia, mitochondrial disorders, and all. By the guidelines, they say that all the patients with cardiomyopathy should get the genetic evaluation. So what we suggest is depends upon what kind of cardiomyopathy you have. Means, like, any patient with a cardiomyopathy, they should get a comprehensive or targeted panel. But if you have a causative pathogenic or likely pathogenic in the index case, you can go for a specific gene testing. Exome sequencing is for the complex cardiomyopathy, where inconclusive comprehensive panel comes. The sequencing is advised for the multisystemic disorders where high lactate levels are there. Further, the 2D-ECO is the most economical and most available imaging modality which is available. But with advancement, because sometimes it doesn't give you proper idea, so you can go for a three-dimensional imaging, measurement of stream, and measurement of TDI to determine the failure. Also, the advanced cardiac imaging, like cardiac MRI with forward flow MRIs, which will help in determining the phenotypic movement of the cardiomyopathy, and as well size, function, and detecting the fibrosis, edema, and inflammation. Cardiopulmonary exercise testing is advised in those patients who are for the heart transplantations, Recently RCHI has started doing the cardiopulmonary exercising testing for kids. Those centers where you have the cardiopulmonary exercise testing test available, they can go for a 6-month test. The cardiac catheterization have a limited indications in the pediatric heart failure management unless you are not sure about the coronary, so you can do a coronary angiography. For the hemodynamic assessment, you can do a cath, or for an endomyocardial biopsy to determine the cause of the cardiomyopathy. So current treatment strategies are basically these are the drugs which are available, like ACE inhibitors, beta blockers, diuretics, and cardioglycosides. And if with this, you have ventricular assist device and ECMO which is available, and surgically, they can go for surgical correction or heart transplant. The last decade had seen a lot of interest in drugs which will act on the molecular level. So initially we had digoxin, vasodilators, ACE inhibitors, diuretics. Since last 2010, we have got then sodium sodium glycoside cyclase stimulators, cardiac myosin activators, and all these drugs are under studies in the adults, and their results have not come from the pediatrics. So the proposed mechanism for treating the heart failure with reduced ejection fraction is we have to target 5 pathways: the angiotensin 2, norepinephrine, aldosterone, neprilysin, and SGLT. So we have 4 drugs available, that is ARNI, beta blockers, MRAs, steroid receptor antagonist, and SGLT2 inhibitors, that is sodium glucose co-transporter inhibitor. And we have additional 3 drugs which will help in our management is ivabradine, hydrolazine, and vericiguat, that is a soluble glyconate cyclase stimulator. So when we use which drug? So if you have a child with fluid retention, the diuretics are the drug of choice. If you have a patient who is symptomatic with reduced cardiac function, digoxin can be used, but because of the narrow therapeutic range, the patient which receives the digoxin will have more side effects. Third one is the beta blockers, where beta blockers have been found to be effective in the adult studies, which will decrease the morbidity and mortality, but they haven't found it is useful in children. But still, we use a beta receptor antagonist when we control the acute heart failure. Basically, the ACE inhibitors are the drug of choice with child with a left ventricular systolic dysfunction. If there is a ACE inhibitor intolerance, we can use ARBs. And in the child with symptomatic symptomatic LV dysfunction, you can use an aldosterone antagonist like spironolactone. ARNIs can be used. They haven't found anything. ARNIs are better than ACE inhibitors, but still they are in the class 2A and evidence B indicators. The newer drugs, that is the ivabradine, which is a fun channel inhibitor, which will decrease the repolarization, phase 4 repolarization, which decreases the heart rate. As you know, as Dr. Nageshwara sir was telling, when the heart rate is low, the longevity is better. So the ivabradine decreases the heart rate in symptomatic heart failure, and which decreases the hospital stay, decreases the morbidity and mortality. Especially this was found in the SHIFT study. So the ivabradine is indicated in a stable heart failure for a heart rate reduction. The sodium glucose co-transporter inhibitors like dapagliflozin and empagliflozin, these drugs act in the distal tubules, which will decrease the sodium and glucose absorption, and which will finally lead to the decreased preload, decreased stress, decreased myocardial sodium content, decreased afterload, and thus they can improve the bioenergetics, and they can be helpful in the child with heart failure. So there is a study which was conducted in 33 diabetic patients, and they found that the BNP was decreased after 6 weeks. So they are indicated in a child with LV dysfunction. Third one is the new drug is soluble gluconylate cyclase stimulator, that is vericiguat, which basically increases the cyclic GMP, which will decrease the platelet aggregation and which will cause the platelet vasorelaxation, and which will help in improving the cardiac failure. So this is indicated in a worsening heart failure despite the optimized treatment with the beta blocker, ACE inhibitors, and diuretics. So these are the drugs which are drug dosages. You can go through it. Next one is for a patient who has refractory heart failure and which is there for the transplant. The Milrin infusion, daily infusion, can be used for a bridge to the heart transplantation, and it can cause symptomatic relief in the palliative settings where the heart transplantation is contraindicated. Next thing after using the diuretics, vasodilators, and in a child with a reduced heart failure, is whether we should do anticoagulation or not. So this update says we should not use anticoagulation for patients with a reduced heart function. Those who are with who has intracardiac thrombus, those who have uncontrolled AF, or those who have a history of thrombotic events, they should be on anticoagulated. Rest of the patients should not receive the anticoagulation. So the next group where you have heart failure with preserved LV function, especially when you have hypertrophic cardiomyopathy, or where the systolic function is normal, or you have restrictive cardiomyopathy. The drugs which are recommended are diuretics and SLGT2 inhibitors. Apart from that, the newer drugs which are coming, but they haven't been tested in children, is alpha myosin activators, histone deacetylase inhibitors, and elamipretide, which acts on the mitochondrial bioenergetics. The devices which have come, there is, the VAD is very big. So for kids, pediatric specific VADs are coming up. And usually the longest period the VAD can be effective is 6 weeks to 3 months. So there are longer duration VADs are getting invented. The cardiac resynchronization therapy, which is useful in adults, is being tried in child more than 25 kgs. Those who have arrhythmogenic heart, they can have internal cardioverter defibrillator. So these are the newer drugs which will act on different molecules or different levels. So there are something the and wearable devices are coming where the cardio where you implant a device in the left pulmonary artery to assess the hemodynamic data, and you can titrate your therapy according to that. And also there advances which are going in the wearable technology as well. Apart from this, these kids will pharmacological therapies like lifestyle support, where the physical activity should be encouraged in this child's serial exercise testing should be done, and lifestyle changes like physical activity and should be promoted. These kids are more of iron deficiency, and so the iron supplement should be given to these kids, and the family and the patient should. So going to the acute decompensated heart failure, where the diagnosis is based upon the again your examination and investigation finding. So basically, when you have acute decompensated failure, decide whether there is a congestion or there is a blood perfusion. So if congestion, the baby will have warm we can have the cold and dry extremities. So basically, if you see the severity of the failure, we run from the clockwise, means from warm dry to the cold dry. So when we start the treatment, the cold dry will convert into cold and wet, then they will convert to warm and wet, and then they can be converted to the normal. So this patient should be heart failure center, where continuous ECG monitoring should be there. There should be facilities for central catheterization and arterial catheterization. If possible, the pulmonary artery catheters can be kept for the hemodynamic assessment. So what is the best of treatment is to, when you have warm and wet shock, you start a diuretics. If you have with the diuretics, if they are not improving, then start inotropes. The mildenafil is the first drug of choice. If they are not responding to that, you start epinephrine. Vasodilators can be used like nitroprusside in absence of heart failure, in absence of hypotension, along with diuretics for a symptomatic relief. And if with all these drugs, the patient is not improved, which is a calcium channel sensitizer, can be used as an adjuvant to the mainstay of treatment. So these are the drugs what we use. So something about levosimendan. This causes inotropic by calcium sensitization to troponin C. They reduce afterload calcium channels. They can have cardioprotective effect because of opening of mitochondrial potassium channels in the cardiomyocyte. But they can lead to hypertension. So adequate volumes. So these are the adjuvant therapies. In case of acute decompensated heart failure, we should see whether they have adrenal insufficiency or not, they have thyroid dysfunction or not. We should treat that. If they have arrhythmias, we should treat arrhythmias. And if they are in distress, they will need ventilatory support or respiratory support. So in short, if you have a patient we should assess whether he has a hypotension, tachycardia, or respiratory, means the signs of congestion. If they are not there, EF is more, you can EF is more than 40%, you can start ACE inhibitors. If EF is less than 40%, you can start ACE inhibitors along with beta blockers. If the patient has symptoms of congestion, start loop diuretics. If there is an improvement 14 hours, you can go back to the stage A. If there is no improvement, you can go to the stage C, where you can start inotropic support and ventilation. And if there is a proper improvement, then within 4 to 7 days and go back to class 4, class 2B. And if there is, then this kind of kids may require the circulatory ventilatory support and may be candidate for the diuretics. With diuretics, they are not improving, start inotropes. If with inotropes they are not improving, you start vasodilatation, and last one is levosimendan. If the heart function improves, then how to wean off the support? First, withdraw the inotropes like epinephrine. Then withdraw you can start the ACE inhibitors. Then wean off the inodilators like milrinone. And then before you discharge them, you start beta blockers and or ivabradine. There are certain drugs which have come up in an acute setting, like synthetic natriuretic peptides, which will cause diuresis and which will improve and which it can cause diuresis and natriuresis, and which are found to be effective in the acute setting. The other drugs which are serelaxin, which is a recombinant human relaxin, which will cause a vasodilatory effect. These are all the IV medications which can be used in the acute setting. A very important drug is istaroxime, which is like digitalis analog, which has a positive inotropic as well as lusiotropic effect, which acts on the potassium sodium ATPase channel. And this drug is under study. So in a nutshell, if you see, you have increasing you have to see whether you have increasing symptomatic severity or and accordingly you can start the drugs. The first drug which is useful is the ACE inhibitors or ARNI. Then aldosterone antagonist, and then you can start beta blockers, ivabradine or diuretics. And if they are not improving, then you can go for the inotropic and inodilator supports. So with all these, there is an improved survival, but still, the 40% of these patients will need a heart transplant. So what is a future direction beyond this is the personalized medicine based on genetic profile. Then we should be able to develop some targeted therapies for specific cardiomyopathies, better mechanical support for pediatric use, and on clinical trials which will target the pathophysiological pathways. To conclude, the significant progress has been made, but still the mortality is high. Early diagnosis and innovation are key to improve the outcomes, and continued research and multidisciplinary care is essential. Thank you.
Thank you, Dr. Prashant sir, for that elaborate talk on heart failure in children. So any questions or comments from the audience? Anyone has any doubts, they can ask sir.
Just one question, simple. When heart failure patients, we are like, we discharge them and we continue them on some medication. Now we follow up, we see that the heart function is normalized. So what duration in your practice do you continue those drugs, or what is the way you paper them? Right.
It all depends upon the symptoms. If they are all symptomatic, I think I will wait till 1 year and then you will stop them.
Yeah.
But if you have certain myocardial problems, then I would still continue the ACE inhibitors for long duration of time.
Yeah. Even if the EF has returned to normal.
Yes.
Right. Yeah. Okay. Because
And that is what these
decompensate.
guidelines recommend. Even if you have improved EF more than 50%, you should continue ACE inhibitors or ARBs.
Right. Thank you.
Guidelines for the pediatric heart failure. You talked about extensively about SGLT. This is the experiment. I have attended several talks of the adult cardiac failure, where they talk about there is no role of GDMT for the pediatric heart failure. Is that right or not?
So most of these drugs have come from the adult studies.
Right.
Okay, and
Yes, dapagliflozin, all these things.
We are still reevaluating in the child heart failure. But it is not like they won't be effective, but we need a study to see what is the effect. See, similarly, if you see the milrinone in an acute heart failure, in the adult, it may not be effective because cyclic GMP levels are very low in the adult heart failures. But they are effective in pediatric where we have some cyclic GMP which is there in the cells. So that is why milrinone was found more effective in the pediatric population compared to the adult population. So similarly, we have to check whether that particular molecule where it is acting and what is its role in the adult as well as pediatric.
MRAs are definitely helpful, right?
Yes.
If you use SGLT2 inhibitors, the resistant heart failure like, do they develop hypoglycemia?
Whatever studies are
basically they were
anti-diabetic and anti-diabetic medications, but
now it's gone into the hands of cardiologists, right?
Yes, but even in non-diabetic patient, the hypoglycemia is not side effect of SGL2 inhibitors.
Okay. Thank you, sir.
The SGL2 inhibit. I'm Dr. Bhargavi, pediatric cardiologist. SGL2 inhibitors research purpose. Amrita Institute, they have a paper on that. They're still doing the thesis work. So we are still on that basis. Second thing is the hypoglycemia. Yes, sir. It's not approved for the pediatric heart failure. That's what it is going on. Studies are going on. And hypoglycemia in their study, in our national conference, when they have published, they had very few, like 2 or 3 had a hypoglycemia events of children, not more than that.
In 38 patients where they studied, I think hypoglycemia was not a significant side effect, but it improved the BNP levels, pro-BNP levels. So, it is class 2B indication. It is not class 1 indication till now.
Don't have approval.
Yes,
That is like,
but now the AHA means they have said more than 1 year. If you can use ACE inhibitor, you can use RNase.
yeah, it's better.
Yes.
Thank you, sir. We would like to present a small memento to Dr. Prashant Patil, sir. Sir, please on stage. For presenting the memento, I would like to call upon Dr. Razani, consultant pediatric cardiac surgeon. Thank you, sir. Our
So, I'll try to make the talk in like 10-15 minutes. I know it's getting late and everybody is tired.
So I'll give a little brief about what is Kawasaki disease and we will talk about the treatment part. So we all know Kawasaki disease is the medium-sized vasculitis and it's more common among 6 months to 5 years of age. And this is a more of a clinical diagnosis. There are no pathognomic laboratory tests for it. And it is becoming one of the commonest acquired heart disease also, as the use of antibiotics has increased and RHT incidents have come down. That Kawasaki disease incidence also is picking up. So the original description was by Tomisoko Kawasaki in 1961. He's a Japanese pediatrician. Followed by he has published in 1967 a case report of 50 cases. So this is 2017 AHA guidelines suggesting how to classify a Kawasaki disease. So it suggests that fever for at least 5 days should be there and presence of the 4 of the 5 criteria, including conjunctival injection, unilateral cervical lymphadenopathy, skin changes, either edema and erythema of hands and feet in the acute stages or periangal desquamation in the convalescent phase, or general skin lesions, either it can be a polymorphous rash and also mucosal changes. And this illness should not be explained by any other known diseases. So this is for you to identify, you have to observe the child and then you have to ask history whether the initially day 1, day 2 child had this feature and later now when you are seeing a child at day 7 of illness, it may not be there. So you have to keep asking the history and then look for all these signs. So it is the diagnosis based on the temporal sequence of these clinical features of and these findings may vary. So it can be there on day 1 and day 2 and sometimes it cannot be there when you see the child. And since there is no lab diagnosis, it is very difficult to diagnose until you keenly ask the history for it. So the updated guidelines have come in 2024. So in this guideline, there are few changes. You can diagnose the Kawasaki disease when they have more than 4 principal characters on the day 4 of illness also. Even an experienced clinician, you can diagnose with the day 3 of fever also when you have a high suspicion in this patient. So when this guideline says like they encourage early diagnosis because it leads to early treatment and then to prevent the coronary artery aneurysms. So these are one of the few important things that they have suggested in 2024 AHA guidelines. Coming to the typical findings of KD, so in the first picture, you can see oromucosal redness with a crackling of lips, then strawberry tongue, and then you can see the unilateral cervical lymphadenopathy. If you do an ultrasound, you can see a bunch of grave appearance in this cervical lymphadenopathy. Next is the conjunctival injection. You can see there is a perilimbal sparring. You can see the white around the limbus. That is like that area is not red. The rest of the part is red. That is also one of the classical feature. Generally, if you see in a viral conjunctivitis, the entire part will be red and they'll have lot of discharges. So these patients never have discharge and then they'll have a perilimbal sparring also. So rash, generally a maculopapular rash or any kind of rash, less likely a vesicular rash. So this is a picture that is showing edema and erythema of hands, many times misdiagnosed as HFMD. So when the child is having fever, along with the other features, you have to think of KD also in these patients. So on convalescent phase, you can see peeling. So it just starts in the periangle region. It can have like extensive peeling of soles and also in the palms. And these are the Bu's lines that you see in the 3rd to 4th week of the illness. Coming to infants, since it is a neonatology based conference, then we will focus few pathognomic features that we see in the Kawasaki patients who's presenting in infancy. So this perianal peeling is one of the classical features. BCG site reactivation, this is also one of the classical feature of Kawasaki disease that we see predominantly in the infantile age group. So this BCG site reactivation has been included in the criteria, in the Japanese classification criteria. However, it is not in the AHA criteria because in US they don't give BCG, but in Japanese they have included this as an important skin feature also. So in India we are still using BCG, so we have to look for this sign, BCG site reactivation. Coming to the laboratory investigation, so we see TLC being raised, thrombocytosis at the later period of time, and they can have elevated inflammatory markers like elevated ESR, CRP. They can have sterile pyuria and elevated pro-BNP. This is also one of the important things when you are suspecting KD patient, you send pro-BNP, so it can be elevated. So that also gives a point towards diagnosing the patient, and echocardiography in all of them. So many times we see the sterile pyuria and start treating the patient as like UTI, but without a culture and having some 10 to 15 pulses and having fever with some rash, you have to think of Kawasaki disease. So why KD in infant is very challenging, one for diagnose, because like they don't have all the features. Most of the times it will be an incomplete Kawasaki disease, and many times it can be atypical KD also. And they have high risk of complication, including coronary artery abnormalities and myocarditis. So KD in infant is a separate entity, and you have to diagnose early. So this is one of the case. So this patient at 6 weeks, child has received vaccination, following which child had some fever, papular rash, non-prudent conjunctival injection, and some oromucosal changes. The treating pediatrician thought it is not significant. Given some antibiotic, child improved. Child became afebrile, so the child was discharged. 20 days later, child has started to develop gangrene in the toe. Child has developed new onset rash. Child started to have skin peeling, and child came to our hospital. So, sorry. So you can see in the echo, so I have put the LMCA, LAD and LCX. You can see a huge giant aneurysm in the LCX and then 2 aneurysms in the LAD also. So this is the reason this child at 3 months having a KD, and it has been diagnosed late and ended up having a giant aneurysm involving all 3 coronaries. So this is the important that KD can be incomplete in infants, and then the risk of them having coronary artery abnormalities is like nearly 40 to 50%. When in otherwise we say like in KD generally it is 25% without treatment. So in AHA 2004 guidelines, they have mentioned like in patients of infants less than 6 months of age, if fever without any diagnosis for more than 7 days, you have to think of Kawasaki disease, start doing investigations and echocardiography based on it. So, and they have emphasized the importance of echocardiography in an infant for more than 7 days if they are having a fever. In 2017 AHA guidelines, they have mentioned if patient is having prolonged fever with irritability, or a prolonged fever with aseptic meningitis, prolonged fever with the culture negative shock, prolonged fever with the cervical adenopathy not responding to antibiotic therapy, or any other oromucosal redness with not responding to antibiotic therapy. So these are the times, these are the atypical presentations or like incomplete presentations of infantile KD, that in those conditions you have to KD in them and then treat in the way. So 2024 did not give much focus on infantile KD. They have the diagnosis or the criteria, they have kept the same. Only thing they have mentioned, like they have a high risk, so you have to give primary intensification in them. So in that the risk score, they have mentioned age less than 6 months, when they have initially coronary artery dilatation more than 2.5 Z scores. Male infants, so these are the high risk they have mentioned. So they have given a risk scoring system, SUN risk scoring system. So if the child satisfies that you have to give a intensification therapy, that is a treatment apart from IVIG that you have to give in them. So this, like I said before, CAS in infants is nearly 40 to 60% that we see. These are the few studies that I have quoted in which they have mentioned CAS are much more severe and common in infantile Kawasaki disease. So this is a nice paper published in, I think, end of 2024 by JNC groups, the one who's involving in AHA criteria and building up. So they have done a cluster analysis. In the subgroup analysis, they have mentioned that young subgroups, that is the infantile subgroup in which there is a high risk of coronary artery aneurysms. So there are multiple studies which shows like infantile age group is like a very high risk for coronary artery aneurysms. So coming to the potential risk factors of coronary artery aneurysms, age less than 1 year, male child, prolonged fever, that is like we have missed that train, like more than 7 days it's been there or more than 10 days. There is a delayed initiation of IVIG resistant or coronary artery Z score being more than 2.5 at baseline. So these are the few other studies in which they have given the criteria for coronary artery abnormalities. More or less, they all have said the same points. So these are the conditions you have to hit hard. So apart from IVIG, you have to add one more treatment for it. So the few points that I have added extra is like KD with macrophage activation syndrome, KD with shock. These are the few extra things that I have added in this presentation, in that slide. So our main aim in KD is like, normally we say like with the IVAG, the risk of coronary artery abnormalities have come down to 5%. But in a patient with infant, with the when you have an infantile KD, the risk already is like almost around 50 to 60%. So how much you have to come down and how much you have to treat it. So that is the main thing. So the treatment intensification, there are a lot of drug has been introduced in the KD treatment over the years. So initially started with aspirin and intravenous immunoglobulins. Later, there is RISE trials saying prednisolone has a role in coronary artery abnormalities, and then IVG resistant KD. Then KICA trial suggesting cyclosporin as a role, and there is a infliximab as primary intensification therapy, and then nowadays anakinra also has come into it. So yes, so with IVAG, generally in KD, from 25% risk of coronary artery abnormality, it can come to 5%. And when you add infliximab, cyclosporin and steroids, it can come to 1%. But in high risk infants, it may not come to 1% because we don't know exactly the percentage now, but it will definitely come down and it will definitely help. So these patients, you have to upfront treat along with an IVAG, you have to add an extra drug. So what are the extra drugs that you can give? So the extra drugs that we generally prefer is infliximab, dose on IVAG or anakinra. Second dose on IVAG is more useful when you have a myocarditis because IVAG helps more in myocarditis. When they have a coronary artery abnormalities, we tend to use the other drugs. So this is the AHA 2024 guidelines, which has given steroids, infliximab, etanercept. They have also included anakinra in case of refractory Kawasaki. This is the one who's having persistent fevers. So for the coming to the patient that I have already described. So for this patient, we have given IVAG, we have given infliximab at 10 milligram per kg, along with the cyclosporin, and we have pulsed the child. But this child persistent to have myocarditis, went into KD shock syndrome, had difficult treatment. So we have to give one more dose of IVAG also at the end. And then on top of it, we have given propranolol and statins. Since the child also had gangrene and had like a giant aneurysm, we have to give this child an anticoagulant therapy also. And during this stay, the child also required inotropic supports, and then we are able to bring out the child. So to summarize, KD in infants are generally severe, and then we need to intensify treatment in those patients. And then apart from them, there are few patients, few risk factors also I have mentioned that in which intensification of therapy is required. And KD, in infantile KD, the CA coronary artery incidence is much more higher, as high as like 40 to 50%. And the window of opportunity to intervene is very narrow. So you have to take a decision upfront and then treat upfront. Thank you.
So we got small.
Yes.
So you said the infancy, the KD can occur without systemic manifestations also.
Yes.
And the risk of aneurysm is very much increased in younger the infants. So it requires high index of suspicion on the part of the general case.
Yes, sir.
Because it fits into the spectrum of vasculitic disorders.
Yes.
He said in the case there is a gangrene also. So what recommendations you make for a general pediatrician to suspect KD in an infant who is most often an inarticulate patient who cannot verbalize the symptoms? To identify the red flags.
Yeah.
Yes.
So irritability is the one we see, which is very, very difficult to manage. So that is one of the things. So once we see irritability, we think of meningitis or UTI. So, but those patients will have culture negative meningitis only. It is generally aseptic meningitis. It will be a sterile pyuria. So irritability, apart from fever, if you have the other clinical signs, irritability is one of the important thing. So whenever the fever is not there, patient will be like much more stable. When fever is there, they'll have like much more irritability. So that is the main thing. Redness, oromucosal redness, you have to keep a watch. This edema and erythema of hands also you have to keep. In infants, this is also important clue and signs that we see. Every patient you have to check for BCG site reactivations. So we have from PJ, we have not published data about on pipeline. So we have found that KD with infants who's having BCG site reactivation, it is 9 times higher risk of coronary artery abnormalities. So that is also one of the things that you have to look. Some redness, crusting, any changes that they have noticed recently.
What is the ascribed reason for increased incidence of coronary aneurysms in infants?
So as such, they have reason why we don't know, sir, exactly, but they are one of the high risk groups.
But as all said, it is very interesting and very important to note also, because there can be overlooked easily.
Yes.
So, that's a very good presentation.
Thank you, sir.
Congratulations. And my question is, as a clinician, we see a lot of cases of atypical Kawasaki. Most of the time, all the guidelines, this one will not be there. So when you suspect atypical Kawasaki, how early you can send them for echocardiogram to rule out the coronary aneurysms?
So as from the place I have trained, when we suspect the moment, in a half an hour we do echocardiography. And even here in I think of we do not the entire structure. So we just need to look for coronary arteries and then the Z-score calculation, which
That's what. How early the coronary aneurysm starts? How early we can detect the coronary aneurysm?
So
after the fever.
Pathophysiology, they say like it happens in the second week, but we have seen patients who's having with the presentation with the dilatation also. And then the dilatation keeps on increasing at 5 days, 6 also we have seen.
So you have to follow up with.
Yes. So even like what my consultant, Professor Sujit Singh says, like if a patient is admitted with the Kawasaki disease, you do on the day of admission, that time when you are suspecting, and then daily you have to keep doing it because during the time they can have changes. So if there are changes from 2 Z-score, if it's going to 3 Z-score, that means the inflammations keep happening apart from the CRP, ESR or pro-BNP that you are following up. So you have to intensify that also. A child who is having 0 Z-score becoming a 2 Z-score, that is an increase. So that is also, it signifies that you have to give treatment. Consider that as an aneurysm. You don't need to wait for it more than 2.5 Z-score.
So in fact, there is increased need for 2D echo very often.
Yes.
Whenever we have got a fever child with who is more irritable.
Yes. Yeah, we need to not doing echo with just size of you have to calculate the Z-scores also. That is also a very important thing.
The lesions are the ones which
is
very significant, I think.
It's
so we see a lot of cases of perianal lesions.
As an insignificant, but many times this perianal region is a very important thing.
Right. Thank you.
Thank you so much.
Just a last question, Dr. Aparna. For calling the KD as resistant, when are we calling it? After first dose of IVIG?
36, the AHA definition says like 36 after.
After finishing the IVIG, the fever should not be there.
Yeah,
right?
fever should not be there.
In the criteria, like if we are saying for the coronaries, many times we see that the patient has become afebrile in our practice, but the coronary Z scores are now increasing.
So that means we don't call them as a resistant KD, we call them KD with coronary artery abnormalities, and then we can intensify the treatment for them.
Yeah, because we have to
Yeah, you have to
intensify
the treatment for them, but it is
definition wise it doesn't fit.
Yeah.
Right.
Labeling is a different labeling.
Yes. Thank you.
The pathogenesis in KD is basically inflammatory cytokines, right?
Yes.
So do you monitor these cytokines to predict is there any relation between, if you have a high cytokine rise, can you predict coronary aneurysm, CAS?
Yes, you are suggesting a good question. My thesis is on genetics and cytokine based only. So we have found that IL-1 is one of the high levels in patients who's having coronary artery abnormalities and who's had resistant KD. So that is how anakinra has come into the picture. Yeah. I'm not saying anakinra should be a first line in KD, but that's how anakinra has come into the picture of Kawasaki disease management in whom there are refractory KD or who's having very severe forms of KD. So that anakinra, like cytokines like IL-1 is IL-1, IL-1B, all those things are only mainly involved. Yes. We are not monitoring because cytokine analysis takes a lot of time and it's not easily available and cost restraints and everything. So we generally monitor CRP, ESR only, sir. CRP basically.
CRP. And what about this? Do you use any something to pick up to remove the cytokines so that you can save the child from going into CAS and all this?
No, sir, we plex, all those things that you are asking, right? So we still now, no, not really. Maybe in very rare cases, they would have used in 1 or 2
If it
seconds.
doesn't respond to IVIG, what is the next step?
So next step is like infliximab or cyclosporin.
That's it. Thank you.
Thank you.
IVIG, usually IVIG is given, but you suggested some other drugs.
Yeah, sir.
So what are the situations to seek the opinion of a pediatric rheumatologist?
You are suspecting a resistant KD or patients who's having aneurysms, is better to consult a pediatric rheumatologist because those patients will require infliximab, cyclosporin, steroids, and the long-term monitoring also.
After they develop aneurysm only.
After the, our patients who's having high risk, high like less than 1 year old male gender, or a patient who's having aneurysm Z-scores more than 2.5 Z-score at presentation, or you are suspecting KD shock syndrome, KD with macrophage activation syndrome in those patients.
Thank you.
Thanks.
Thank you, Dr. Aparna. I think we'll all will need definitely rheumatologist consultation whenever we have a case with KD. So to honor the faculty, I would like to call upon Dr. Nagaraj sir to give the mementos. First, sir, Dr. Ajay Bandaru sir, consultant pediatrician. I would like to ask Nagarajan sir to give the memento to sir. Next, I would like to request Dr. Muthuza Kamal sir to receive the certificate and memento from Dr. Nagarajan sir. I request Dr. G.V. Subramaniam sir to receive the memento and certificate from Nagarajan sir. Next, I would like to call upon Dr. Aparna to receive the certificate from Dr. Nagarajan sir. Next, we will move on to the panel discussion on common presentations of pediatric cardiac conditions and their management in the form of case-based discussions. So the panel is being Dr. Sudeep Verma sir. I would like to request Dr. Sudeep Verma sir and Dr. Nagarajan sir to come on to the dais. To moderate this session, I would like to call upon Dr. Kalyan Kunchapudi. He has done his PICU training from St. John's Medical College and Apollo Children's Hospital, Chennai. He has done his cardiac ICU and ECMO fellowship from Ghosh Hospital, UK. And he is interested in ECLS, EICU, acute liver failure and neurocritical tear. He is also a teacher of PICU fellowship program and ESOI ECMO course. I would like to ask the Dr. Kalyan to continue with the session.
Thank you. Okay, I would call upon and Anil sir. Anil sir. Thank you for the opportunity. We shall quickly go through. Oh. And, done. You. Okay. Okay.
Yeah, thank you for the opportunity. I would like to call my accepting for being a panel. So, what are the common presentations and how difficult it is to transport, and what are the things that we need to have for the transport? Preoperative stabilization of different cases, and what are the congenital heart disease that need special attention. So, what are the common presentations of infants and children with congenital heart disease to sleep, sir?
See, we already discussed in neonates, it's a three symptoms. Mostly they may be asymptomatic. They present with the failure, cyanosis. These are the three common symptoms. And apart from that, chest pain rarely in the child, syncope rarely in the child. Okay. So these are the common for early dyspnea, which is related to the failure for the dilated cardiomyopathy, palpitation to the arrhythmia. But the most common symptom, what usually comes with the cyanotic for the cyanotic heart disease, or sometimes dyspnea, which is the common symptom for cyanotic as well as acyanotic also. Third thing, for the failure, sometimes they come with a lot of recurrent RTI for the small babies, feeding difficulty. So it's a set of the symptoms are different, presentation are different for the neonate, infant and the children. Infant is more like a feeding, failure to thrive. In adult, it will be more like a dyspnea and chest pain or the syncope or the this one or cyanosis. But the neonate, the more common present in a severe form, more critical, or sometimes nothing will be there only when they go for some this vaccine, they found out some murmur and they referred to us. So these are also some of the most common symptom in ASD, PS for the simpler reasons.
Yeah. Yeah. So there are no set symptoms that they would present. They might come with a varied presentations based on the natural history of each of the disease. So most of the patients are transported first, stabilized, and then operated, because the more commonly more common subset are either the worsening physiology or associated infections, because the elective and asymptomatic presentations are more commonly a planned procedures. So the transports can be inter-hospital or intra-hospital transports. So inter-hospital is mainly it's a two-way transport, or rarely the patient is coming from the referral by themselves. It could be a road or an air transport. And we shall go through a case where it involved many things. So the case is 11-month-old, previously diagnosed mitral regurgitation with mitral stenosis and an ASD. Child had fever, cold, cough for 3 days, breathing difficulty for a day, and was admitted for the same. So echo is suggestive of severe MS with severe PAH and biventricular dysfunction. Child had respiratory failure initially on HFNC, worsened, was intubated, and the shock was being progressive from the time of intubation on high doses of epinephrine, norepinephrine, vasopressin. Also had hospital-acquired infection progressing to MODS. So at referral hospital, child is being on higher antibiotics. For MODS, the child is in AKI, coagulopathy, liver injury is being there, thrombocytopenia. Also had right side central lines and arterial line. So transport call came that child is not behaving well. Cardiologist was contacted, planned to retrieve to the ICU. The transport call came to PIC consultant and fellow. So what are the prerequisites and equipment you check on to transport such sick cardiac cases? Srividya.
First of all, prior to the transport, we need to be sure, we speak to the transport referral doctor consultant regarding the clinical condition, current status, and the management so far which was done in the referral hospital. And also, other thing is whether appropriate counseling is done about to the patient attendance Other foremost thing is, are we well equipped with the supporting system during transport and after the transport? Like be it the transporting equipment or the team. Like this child is into multiple organ dysfunction and AKI and all. So this child eventually might require and also sepsis require a dialysis, and we need to be doubly sure that whether we have a dialysis facility in our referral in our center, and also the cardiac team, cardiothoracic surgeon team, and during transport. So we need to keep a checklist of what are the things in the ambulance. Do we have an ambulance equipped with the ventilator, defibrillator, all the equipment, and also the emergency drugs and emergency kit. Apart from that, the pre-prepared inotropic support and all. And also after reaching the transport also, we need to make sure we give the supporting advice in the management plan after reaching the referral hospital. So we need to take an adequate detailed handover from regarding the case management, including the medications, and regarding when if the child is ventilated, what are the peak pressures, what are the ventilator settings there, and we before transport we need to connect to the our transport ventilator, whether it is to check for the stability, when was the last suction done, what is the NPO status, when was the last feed given, and also the inotropes, transition inotropes we need to prepare. And foremost thing is the high risk consent before starting from there, and after that doing a detailed counseling to the patient attendants. And before starting there, we need to inform our referral unit. We need to update the information regarding the patient.
Yeah, so basically we need to have all the stuff which just prepare for the worst, prepare the things, prepare the infusions prior rather than going and preparing in front of a sick patient. So go with all the things. This is our ambulance which is equipped with even to support the ECMO, and detailed handover, decent consent, and then having a good coordination. In interest of time, I'm skipping this video, which is going through all of the things. And this is one of the intra-hospital transport of ECMO for a CT head that we are doing. Right. Okay. So next, coming to the preoperative stabilization, this is the most important thing for a better outcome, especially when we are dealing with the kids with cardiac issues where the physiology is altered and upon which there are multiple things that are happening like sepsis. So what are the prerequisites for cardiac surgical fitness from an anesthesia point of view, especially in a kid who presented with cardiac problem along with multi-organ dysfunction? How can we classify these surgeries from a cardiac ICU standpoint? Dr. Nagarajan, sir.
Yeah. So if you look at the question of surgical fitness from the anesthesia point of view, I would say all patients are fit for anesthesia. I think now anesthesia we are safe enough to anesthetize all the patients. But the point to be answered is the surgery going to be beneficial? Is the surgery risk less than the benefit of not doing the surgery? At that particular point is what I think would be essential thing to be answered. As far as we want to classify these surgeries, the main thing which, and as far as the preoperative stabilization thing comes, it's always better to have patients who are hemodynamic with adequate hemodynamics before putting them on cardiopulmonary bypass. But yeah, there are going to be situations like a TAPVC or something wherein they are, or a severe Al-Kappa with severe dysfunction, wherein you might have to put them on cardiopulmonary bypass with some dysfunction and some metabolic disturbances. But otherwise, I think there are enough drugs or there are enough catheter interventions to stabilize all these patients before going on bypass and doing the surgery on them. As far as the surgery is concerned, And how the outcomes are classified, it will be based on the STAT risk score. This is the Society of Thoracic Surgeons and the European Society of Surgeons classification is there, which would classify all the heart diseases on 5 categories, and then the class 5 being the highest risk with almost a 16% mortality in them. So that's going to include the hypoplastic left heart or the neonatal Epstein, and class 1 or the ASD and the VSD. Even those ones have a risk of around 1.5%. The STAT 1 would be. The other way to look at it is, of course, whether you want to do an immediate surgery, a semi-urgent, or an elective surgery. And the risks are definitely much higher when you want to do an immediate or a semi-urgent surgery compared to a well-stabilized elective scheduled procedures.
Yeah. So basically, based on the scores and what is your outcome and how complicated the surgery is, that defines it. So this is sort of an easy way with some examples where you routinely schedule the case, routine scheduled cases like ASD, VSD, where you want infection-free PAC and you can wait. And there are certain urgent surgical cardiac cases where survival is not at all possible without surgery, like obstructed TAPVC, TGA, where you don't have any other room to sustain the life, rather than going into the theaters, especially when your medical management is failing. There are certain, similarly, we can say it like semi-urgent. We want to take them as soon as possible, but we have some time, like TAPVC, not completely obstructed, or medical management is amenable, or TGA, where we have a decent ASD, or where we have done balloon-atrial septostomy, where you can actually wait for a optimal ventilation, saturation, lactate clearance, and a good support for multi-organ dysfunction. So management is, I mean, the decision making, as I said, it can go through the similar tree, and where you need to stress more upon the preoperative stabilization is that semi-urgent cases where surgery is not possible with sickness, or the risk of surgery is the risk of continuing the medical management. So these are certain cardiac surgical prerequisites which we do in PICU before putting them into a bypass, where whether it's a balanced physiology, whether shock is controlled or not, there is an appropriate perfusion and minimal possible or physiological doses of inotropes, clearing the lactates and infection free. So this is an idealistic scenario of going through it. And what are the less invasive procedures, and what are the time buying procedures in cardiac congenital heart disease in critically ill children? Dr.
As we discussed in neonatal age, if the neonatal age is there, the hybrid procedures like IAS stenting, RVOT stenting, PDA stenting, balloon septostomy, as you grow little big, like some of the top where they come in 2 to 3 months, when they are not suitable or come in an emergency condition, then you can do the RVOT stenting, PDA stenting, or sometimes HLHs with a moderate of everything like coag balloon dilatation you can do, aortic balloon dilatation, aortic wall stenosis, balloon dilatation. So our aim in that part is just to stabilize, and if we get good result, it's okay. If we not get the good result, we need to stabilize and later to send for the surgery.
Yeah. So most of these procedures are actually time. We are buying the time rather than we are providing a bigger solution.
That's why I call it as palliative procedures.
Yeah.
Like PDA stenting, RVOT, that means it's just to tide over the crisis and few months or few days or few hours, so that we can able to do the surgery in a proper, in a best hemodynamic setting later with a good results.
Yeah. So this is one of the technique that is being followed, was followed in GOSH when preterm presents with a high risk.
HLHs in India, we are not doing much, we are not
HLHs.
giving good counseling because the outcome is very bad. Even after that, the best, nobody in the India, hardly 1 or 2 centers are doing surgery.
Yeah. So where we actually stent the PDA and we put in a
IAS
retroseptal stent and do a banding. So through the surgical, they are going to do banding, which is not a very much invasive compared to going on to a bypass and all. So, but like as sir said, HLHS per se go into a palliation route and requires multiple surgeries, and interstage mortality is very high. So most of the times in our settings, we do a sort of a negative counseling or give them a true picture. Most of them take the decision even before going to their first stage. So going to our transported case, child came to our unit, intubated and ventilated, and we set in a rate of 50s to get rid of CO2s, and there are a lot of secretions initially, and saturations we are achieving a decent one. Circulation on epinephrine, norepinephrine and vasopressin, child is febrile, and GCS wise and CNS wise child is doing okay. So to gist the problems that we have: sepsis, shock, multi-organ dysfunction, ARDS, and pressure sore in the occipital area. And physiology wise, it's a MS with huge LA dilatation, PAH, RARV dilatation. There is less small LV to say. There is congestive hepatopathy and low cardiac output state. At this point, like, the challenges are the child needs diuresis because of ARDS. But it could be counterproductive because already the LV is receiving a very less amount of volume. LV and diastolic volume is less. And hypotension is requiring a high inotrope, but if we keep high SVR, the LV is going to take a hit. So we need to balance it. And the investigations wise, cardiomegaly and bilateral lung field infiltrates are being present. With the current support, the lactates are holding on, and there is some acidosis. And this is the presentation platelets of 35,000. Slowly it is improving, and urea creatinine are slightly going up, and there is a coagulopathy as well. And if you see, the liver enzymes have also gone up. So cultures have shown, I think it's not clear, cultures have shown Candida and Spingomonas. Antibiotics are adjusted as per the antibiotic sensitivity. So over the next 3 days, what happened is, it's a culture positive sepsis. We have removed all the lines, put in a new lines. There is infection control happening. Shock is slightly better. Inotropes are reduced. We have introduced milrinone. Kidney injury is getting better. Antibiotics are adjusted. Thrombocytopenia is improving. Not received any transfusion after day 1. And physiology wise, we are on ventilation, diuresis. Liver injury is improving, and for nutrition, we have introduced aminoven. Right. So the question is for Anil sir. If we are proceeding for a cardiac surgery, and what are the interventions and what is the planning dilemma that was going on? This child is having a large ASD, predominantly mitral stenosis with some MR, and a small LV, or like LV that might not be adapted well for the lesion.
So this child had as you said, combination of a large ASD and a mitral valve stenosis. The LV is borderline. So we discussed a lot about our options. So because of the sick nature of the baby on ventilator with infection, low platelets, multi-organ system involved, surgical thing is going to be high risk. So we discussed whether there's a role for a balloon. So if you do a balloon, now there are 2 issues in this case: the ASD, the contribution of the ASD. Both are equally important. So whether we have to fix both together, or we thought whether we can just balloon the cardiologist can do just a balloon valvotomy at the mitral valve come out. Then that's a problem, because when we balloon the mitral valve, you can produce severe MR, and it can bleed into the lung, and the baby may die. So the other option is whether we should only address the ASD, partly close the ASD and come out, and leave the mitral valve, do partial repair and come out. And the other option is replacement of the mitral valve. In such a small kid, there are no repair options available, but there's no valve repair available at this age to put in the valve. So we discussed everything, and then we took a high risk consent and went for surgery.
So that was the disease. Basically, as he said, RA and RV is being dilated, and ASD is shunting. And so some amount of volume loss is happening from the ASD, and very less amount of volume that is coming because of the MS. So LV is like quite have not seen the full flows, and LV is small. So for the immediate surgery, so we are actually preparing for a marathon. So we are coming out of each of the steps. At this point, I'm able to maintain the cardiac output. There is no metabolic acidosis, good urine output. I'm able to maintain perfusion. So we are waiting for some of the organ injuries to settle, infection control, and child is showing improvement day by day. And once the child improved, we have gone in for the surgery. So this is a preoperative stabilization sort of a checklist that we have gone through. It's like then just rubbing on some of the special scenarios where preoperative stabilization slightly varies with each of the disease. So some cardiac issues need a tailored support. So and this needs to be started even in emergency room. So over to Sri Vidya. What are the few steps that where we change from the usual things on duct-dependent pulmonary circulation?
Usually duct-dependent pulmonary circulation occurs in the conditions like tricuspid atresia with pulmonary atresia, critical pulmonary valve stenosis, and conditions like TOF with pulmonary atresia, or pulmonary atresia with heterotaxis syndromes and all. So in these conditions, usually like we need a patency of the duct, and at the same time, like first, usually during the transition phase from the fetal circulation, initially they present with only symptoms like cyanosis and saturations around 85, 80 to 85 around. But as it progresses, they present with symptoms like respiratory distress and cyanosis worsens and all. At that time, like we need to keep the duct patent. We should start prostaglandins at the dose of like 5 to 10 nanogram per kg per minute to keep the duct patent. At the same time, we start with the smaller doses and gradually up the doses as per the requirement, keeping in view of its associated complications like apnea, hypertension and all. But make sure your saturations are maintained around 75 to 90, not more than that. But if we aim for a higher pulmonary blood flows, if there is a pulmonary flooding, your systemic circulation will be compromised. So this may end up with your organ perfusion and rising of the lactates and all. So aim for a balanced circulation. So for that, we can increase the systemic vascular resistance with a good ionotropy and pressors. But too much of pressors should not be there. So aim for a QP-QS ratio to maintain a balanced circulation, and consider oxygen as a drug and aim for permissive hypoxia, and also keeping your SVRs at a higher level, and pulmonary too much of pulmonary flooding should not be there. Otherwise, your diastolic pressures will be low, and this leads to poor coronary perfusion and all.
So basically balance the circulation, and if you increase the SVR, more blood goes into the lungs. If you reduce the SVR, more blood comes into the systemic circulation. So next is to Nagarajan sir, like just a few of the preparative steps what we do when we see a duct dependent systemic circulation where patency of duct is the main ideology.
So these are the patients who are going to be very sick and usually would present in shock, because once the PDA closes, the systemic perfusion gets affected. The LV EDP is going to go up, LA pressures are going to go up. And of course, the perfusion is not happening to the distal organs. So the organ perfusions are getting damaged. The kidney gets affected and everything is. So the aim is to keep the duct open. So again, you have a avoid oxygen, keep it lower FiO2 in these patients so that the PDA doesn't close. Prostin is definitely helpful in these patients. You would definitely start Prostin once the PDA opens. You do find the acidosis slowly settling down, the perfusion, distal perfusion getting better in these patients. The lactate would start decreasing. The one important thing which is there in compared to duct-dependent pulmonary circulation to duct-dependent systemic circulation is the question of should we feed the patients. In duct-dependent pulmonary circulation, you could feed the patients, But in a duct-dependent systemic circulation, it would be preferable not to feed these patients till we go or finish the surgery, because gut ischemia and then vomiting and then aspiration is a major issue which comes up. They would require some amount of inotropes to maintain the systemic pressures and appropriate volume. I think that would be the way to go about it.
Yes. So these are the cases like where we do like high risk feeding. Maybe like we might reach the full feeds by end of a week of surgery. So so this is roughly the same. Next is the most common topic for all the PGs, like cough with cyanotic spell. So how would you manage, and what are the principles of
There are
managing?
two things. RVOT is the obstructed, there is a VSD and there is a systemic. So there you have to maintain the relative resistance over both sides. So you need to increase the resistance on the systemic side so the more blood will go towards the pulmonary flow. So first of all, give oxygen. How it will help? It will increase the dissolved oxygen. Second thing, knee chest position. How it will help? It will increase the systemic vascular resistance and it will trap the lactate in the periphery so that the less acidosis will be there. Third, make the baby cool and calm, like give ketamine, give pain relief. Okay, then it will help. Third, increase the SVR. So all drugs like ketamine, if you are giving, that will be helpful. Or you give the phenylephrine, it will be helpful. And then most important, decrease the make like the end, like you can give the morphine or you can give the fentanyl, that will cool and calm the baby. So that will decrease the oxygen requirement. Apart from that, Inderal is the main drug. Why? Why we do non-specific? Suppose if you use the metoprolol, the beta 2 will be unattended. So it will cause the beta 2 reception vasodilatation. So that's why you need to use the non-specific beta blocker like propofol, which will decrease the heart rate also. Beta 1 as well as beta 2, both it will get antagonized. So that will be helpful. So apart from if not improve, give good bolus also, that will improve the flow. And then if not improved, then you do the RVOT, PDA stenting or the BT stent emergency.
Right.
Bicarb also we have to give to counteract the acidosis.
So what are the respiratory issues associated with complex cardiac lesions, Dr. Nagaran, sir?
Yeah, so this could be just the airway issues or the lung issues. I think we could classify them. The airway issues could be just because of the associated conditions the child could be having, most common being Down syndrome, wherein they would have a subglottic narrowing, large tongue, makes the intubation slightly more difficult. Or it could also be in patients with microdeletions also could have some amount of airway abnormalities. Airway abnormalities, I do have seen some unanticipated airway issues, which could also be in any of the pediatric patients, especially in mucopolysaccharidosis when they come. That's going to be an issue which comes in. So this would be patients who are syndromic and then coming for surgeries, or it could be patients who are having some sort of a slings or the rings around the trachea, which would make them difficult. So this could be a double aortic arch or the aberrant subclavian going around, which can again compress the trachea. And then when you intubate, you cannot go further. You go to a certain level and then probably you're not able to pass the tube beyond it. So these are the issues there. The airway issues could also be beyond this. That would be happening in patients who are having something like TOF with absent pulmonary valves, wherein the pulmonary vasculature actually compresses on the distal airways. So those are the other patients who do have a lot of problems which should be there. But especially TOF with absent pulmonary valve, it's a neonatal presentations who would have more of a respiratory problems. The later presentations, they're actually slightly better patients to handle.
Right. So what are the non-cardiac issues that need to be in consideration when we are running?
So there is simple infection you control. Anemia in our country, anemia is the most common. Most of the child shifted with so much of infection. Lines will be there for the long time, so that is get infected. So this is the first anemia you have to consider. First of all, infection. Second, nowadays with the respiratory, even with the CHD, the viral pneumonia are more common. RSV infection, parainfluenza are more common. So many of the patients come to us at that point. They have to treat that. You have to stabilize and then you have to take. So most common, these are the 2-3 nutritional issues. Okay, they are very failure to thrive. So you have to take care of the nutritional issues also. Immunodeficiency, as sir told, like in DGeorge, you have to do the irradiated blood. to prevent that graft versus. So these are the all anemia, nutritional issue, infection, syndromic, gut issues, failure to that all you have to consider before taking the.
So this is a data assessment which we used to use before conducting planning meetings of all the cardiac cases, like where we used to fill all these things and present before the planning meetings, and we used to have the final outcome of the planning meetings before going for the surgery. So child underwent surgery on day 10 of transport. In the preoperative stage, like finally we got 2 blood cultures that are being positive, being negative, and we came on to very low dose of adrenaline and milrinone. Mitral valve repair has been done, CPB of 3 hours, ventilated for almost 10 to around 15 days, and finally all lines out and on full feeds. So these are like gist of problems that that we need to look off for each of the diseases. You can take a picture. Not that all these complications do come for all the patients. These are the specific complications for each of the diseases where we need to look off specifically. And in the post-operative echo also, we all, as an intensivist, when we are taking care of these cases, we need to know what the cardiologists want to see and what we want that information. For each of the disease, we want certain area and certain numbers to be addressed. So whether those are taken care of or not, because that makes a sense of what we need to wean off and what are the things that we should not play at the immediate post-operative period. So overall, the summary is safe transport is key for the successful outcome. It may need extensive resource stabilization for most of the congenital heart diseases which presents in critical situations is the key. It is as good as like one mantra that we do before a major things that we do. So this is one of the myocarditis on who underwent VA ECMO and then going home, and that's one of the TAPVCs. Myocarditis one came on air ambulance. That's our team. Thank you.
You, Dr. Kalyan, for that wonderful panel discussion and all the senior consultants for their contribution. I request Dr. Aparna ma'am, our NICU HOD, to present the mementos and certificates to the faculty. I request Dr. Kalyan to come onto the stage and receive the memento. Now I request Dr. Anil Dharmapuram sir to receive the memento. Next, I request Dr. Nagarajan sir to come onto the stage and receive the memento. I request Dr. Sudeep Verma sir to come onto the stage and receive the memento. I request Dr. Srividya to come onto the stage and receive the memento. I request Dr. Chandrasekhar sir to come onto the stage and receive the memento and certificate from Aparna. Next, we have the session on chest X-rays in pediatric cardiac conditions by Dr. Sudeep Verma sir. For this talk, I would like to call upon Dr. K.V. Subbarao sir, Professor and HOD at ESI Hospital, Professor of Pediatrics at ESI Hospital. I would like to call upon Dr. Bhargavi, Pediatric Cardiologist at KIMS Hospital. At Rainbow Hospital. Sorry, Rainbow Hospital. KNR sir will come back, I think.
Dr. Rajesh, he left actually. Dr. Chakrapani sir.
Dr. Chakrapani sir, consultant pediatrician at Sangareddy.
So for want of time, we are actually skipping the focus sessions and also for lack of delegates. And so we will be winding up with this session. The case presentation by neonatology DNB was completed. We are also doing away with the pediatric case presentation because we are running very late. So this and the last session will be on PDA device closure, which Dr. Sudeep and Dr. Bhavani will take. We request the chairpersons to chair the last session also, in addition to this chest X-ray session.
See, good evening everyone. Thanks for staying till time. See, this is one of my very close to because when I thought X-ray is very important part of examination. So this is the first X-ray. Anyone, which is this X-ray? This come with the recurrent RTI. Any clue? See, there is a specific, you can see, there is a right lung is hypoplastic, there is a vein here. The typical of scimitar syndrome. Okay. So this is my book, which I authored 1 year back. It's freely available. And it consists of almost 2000 X-rays with almost 35 chapters. Okay. So this is one of the very interesting, how the X-ray, this comes with the saturation of 80%, no distress. And this is the X-ray, what you may think of. No distress, patient is quite comfortable coming. So somebody fever, symptoms, disturbance, there is no distress, nothing. But there is a large, very good. so this is like, you can see there is a vasculature seen here, there is a vessel and there is a large AVM. So this is like a pulmonary AVM, saturation is 80%. So the X-ray we did the device closer and the child improved. So this is one of the very important, which we all read, 23-year-old with the cyanotic CHD ankle joint tenderness. Why this X-ray taken and what is the purpose? See, what we call, what is the grade 4 clubbing in all our, we are teaching, we are reading, but we are not. Grade 4 clubbing is a hypertrophic osteoarthropathy. That means hypoxia is so prolonged, it involves the bone also. So that causes the periosteosis. So you can see here, see, this is an irregular periosteum and that is causing the tenderness. So hypertrophic osteodystrophy grade 4 clubbing is a clinical triad of clubbing, arthralgia and the ossifying periosteate that is caused. This is a very HO grade 4 clubbing. Okay. So these are, so if you see the X is not only thing, it's a part of the whole jungle. We should like a detective where we have to check every system. We have to take clue from clinical examination, history, X-ray, ECG, echo, everything. But that's what it depends on so much of the thing. That's why it's included in the minor category because there's a lot of technical things are involved into that. This is the problem in our country. This is the Indian leading diagnostic company, and they are saying advertising like that, seeing the X-ray upside down. So even they don't know how to read the X-ray, and they are leading. It's a leading diagnostic company. So that's how, okay, what we don't know, we cannot comment. So ignorance is a bliss until you hit the ground. That's why we need to check all the systems. We have to take the clue from that. So these are the questions for every CHD, whether it's a cyanotic, acyanotic, pulmonary artery flow, increase or decrease, originate in the left or right side, which is a dominant ventricle, pH present or not. So this is just to show how the cyanosis shock and CCF present with follow-up PVRI in various congenital heart disease. So just I'll go with the simple normal pulmonary vasculature, 3 vertical zone, inner, outer, middle. And this is the very important thing. How the 3 different vascularity looks like, because the X-ray, the main important thing is vascularity. Normal vascularity, gradual pattern from, you not see anything in peripheral little bit. In more white out, plethora, end and vessels is a over circulation. That means flow to the lungs are increased. Oligemia, more black, no vessels are seen in the periphery, that is oligemia. In the same way, there are 2 other important concept is equilibration. When the flow toward the lung increase, it will go all together. That means all lobes are equally involved. That's why there is equilibrium active congestion. Passive congestion is left side condition where the lung, where the blood is pulmonary venous congestion getting congested. So here what happened? Normally the lower vessels are more prominent, but when it goes the backside, it causes a spasm and the more flow go towards the upper zone. So that is known as a reverse Mustet sign or the antler sign, and that is consist of the left heart pathology. Okay, so this we have to see all correctness, clinical detail, and then we have to consider the interpret. This is important. See, this patient come to us as a dextrocardia. Refer to as dextrocardia, even though not palpate properly, but this just the rotated film. Within the 2 to 5 days we taken the film, it's a normal, and this is just the anemia, nothing else. So this just we know. Second thing, we should know the interpretation, anterior end of the rib. This is a well centralized, well inspirated film. But if you see, this also come to us as a cardiomegaly. But this is a very expiratory film taken in the only up to R4. That's why it's causing the cardiomegaly. That is spurious. The spurious cardiomegaly patient is absolutely normal. Otherwise, if you see in the, this is very important. With this, so many patients, so many of them, my PGs are asking, sir, it's a boot-shaped heart in the neonate. Why? So the boot-shaped heart in the neonate, because we are taking lordotic film. When we are, the child is like this, and they are putting, so that the way the wave, the X-ray radiation will go like from up to down. So that's why how to diagnose that thing. So that all the abdominal structure will become prominent and all the RV become apex will be prominent. So how to diagnose that? So lordotic film is like that. If you see the clavicles are above the ribs, that means it's a lordotic film. Once if the clavicle is overlapping the rib, that means it's a normal rib. So if you see that the lordotic film, the RV apex and the boot-shaped heart is a normal. So many of times the PG are asking, this is the boot-shaped heart in the neonate, why you are telling? So it's just a lordotic film, nothing else. You have to, it's considered to be the normal for that. So the other various things will not go. This is the pedicle. So once the pedicle, see, pedicle is consist of the vessels. So once it's the pedicle problem, this is the figure of 8. Either it may be thymus or a figure of 8, or it may be abnormal vessels or the tumor, or it's an abnormal aorta, or when it's a narrow, it's like a TGA. So these are the very important clue. Once you see the pedicle, you can able to see what kind of the, and sometimes in the road trauma accident, when the pedicle is wide, that means there is a hemorrhagic hemomediastinum. That is also one of the classical sign for the trauma when it's a in the to the chest. Okay, so this I won't go. So there are spaces. This we won't go. But this is very important. Any lateral X-ray, if you are taking a line from the trachea to the apex, if any heart comes behind that, that means that heart is enlarged. So this is very important clue in the lateral X-ray. Whenever it's used, the heart going behind the light from the trachea, that means that heart is enlarged. If you are not able to see, sometimes you get a decubitus to see the pneumothorax. Here, pneumothorax you are unable to identify, but once it is a decubitus, air will come up, and that shows the dilated bowel loops as well as the pneumothorax here. This is very important. How to see the other things also. This is one patient we did the BT shunt, but the patient go into shock and the hemoglobin drop from 12 to 5. Anything, any comment on this X-ray? You can see the soft tissue here and soft tissue here. Because it was a BT shunt done from the thoracotomy. There is a bleeder in the soft tissue. That is causing the very soft tissue edema. The BT shunt was flowing well. There is no pleural collection, but the soft tissue bleeder was there. So when we told sir that this looks like soft tissue, he opened, there's a large bleeder in the soft tissue in the skin, and we repaired, it becomes normal. So just with the simple X-ray, you can tell out, and with your clinical knowledge, you can tell out this is a soft tissue is thick on this side. That means there is some bleeder in the soft tissue that is causing the problem. Sorry for that. This I won't go. Now these people are asking me how to diagnose the apex. So this you can see the sagging apex with the obtuse angle is usually LV. Okay, and the once you see the same trachea to backward, if something the retroesternal angle is not retrocardiac angle and there is a LV in the upper LA and upper zone LV, that means the LA LV is enlarged. So whenever the decreased retroesternal space, LV is enlarged. In the same way, acute angle with the diaphragm border is the RV apex. And once you go in the lateral X-ray, you can see only the retroesternal is filled up, but the retrocardiac is normal. So that's how you diagnose in all those things. So now we go with the case scenarios. This is one of the very important. I realize Moguls are the elevation on the left heart. 1, 2, 3, 4, 5. 1 is belongs to aorta, 2 to the pulmonary artery, 3 to the heart, but the LV, 4 to the apex, and the 5th to the. If anything is beyond this coming into this elevation, that is abnormal. So you can see this is the all elevation. So you can see this is one very large. So this is the mass in the LA appendage, which is causing the left heart border abnormality. So just with there is a palpitation, very palpable pulse, and you see, and when we did the echo, we didn't find out anything. But when we did the CT, we found large LA aneurysm that is causing. So that's why you have to see. So now this is the general. So now we go with the specific left to right shunts. See, 4-year-old tricuspid shunt, there is a prominent LA, and these are the end-on vessels. So once you see the aorta bronchus ratio, whenever the artery bronchus is smaller and artery is big, that means this is the plethora. That is a sign of plethora, because normally aorta and bronchus both will be equal size. In the same way, hyperinflation is a sign of CCF in the large VSD, or any shunt is a in infancy. When you see the hyperinflation without anything, that means it's a sign of the CCF in an infants. And there's a large VSD pulmonary artery with the LV apex. And you can see how the XL, this is the patient come at 5 months and again at the 12 years. You can see the heart size reduced, plethora not seen, that means it evolved into the Eisenmenger. The same patient come to us after a 12-year and the development of the Eisenmenger. In the same way, ASD, you will see the RA. The same both large ASD, because ASD there is a clockwise rotation. So sometimes even with the large ASD, you will see the small heart, but is the moderate ASD, you will see the large heart. So once the RA-RV is dilated, it's more suggestive of ASD. LA-LV dilated, it's more suggestive of VSD. In the same way, the triangular heart, because of the LA and RA, it becomes straight. The triangular heart is the characteristic of the large ASD. So this is the triangular heart. It also found in the constrictive pericardium, but at that time the heart size will be normal. Here in ASD, heart size will be enlarged. So there is an ASD. You can see the huge RA. And that is because of the flutter and the MR associated with the ASD. Same ASD patient come at the 40 years, you can see. This is the PA, very prominent. There is no vessel seen in the periphery. So already pruning developed. So this is Eisenmenger, that means it becomes unoperable. So with that, sometimes the normal thing you can see. This is the normal X-ray in a neonate. You can see the bump. This is because the duct in a neonate will close at the PA and the aortic bump, which is a normal structure in a initial 2 to 3 days of the life, which automatically disappear by 7 to 10 days. So this is the atrial aneurysm, ductal aneurysm. But once there is an aorta is dilated, that means it's a PDA. So how to differentiate VSD and PDA? Both LL will be dilated. But once the aorta is dilated, it's a more suggestive of PDA rather than the VSD. So here is the aorta is dilated. This is another patient. You can see the clinically, this pruning is there, and there is a calcification in the PA, that is suggestive of Eisenmenger, and when you see the clinically, there is a differential cyanosis. So that is typical of the PDA Eisenmenger. Calcification is a sign of two. Either if it's a PDA is small, it's a sign of calcification is the sign of Eisenmenger PDA or dilated huge aneurysmal PDA. So here it turns out to be the Eisenmenger because the differential clubbing is there. So we'll come to the obstructive lesion. This is once you see any ejection systolic murmur, and you see the LPA is more dilated than RPA, that is typical of pulmonary stenosis because of the preferential jet going towards the LPA. So that is this is known as Chen sign, that is the severe pulmonary stenosis. In the same way, you can see RRV dilated. The same patient comes after 4 to 6 months. It developed the severe RV dysfunction, and then developed the huge RA, and then become the decreased vascularity. So you can see the X-ray can see you the hemodynamicity, how the lesions evolved over the period. And this is the aorta. You remember the pulmonary artery dilatation is not associated with the severity. So even in the mild aortic stenosis, aorta will be dilated, mild PS, MPA will be dilated. So that is not the correlation with the severity. PS, if the dilatation is there or oligema is there, that suggestive of severity. In the same way, aorta, when the pulmonary venous congestion is there or LV dilatation is there, that is suggestive of aortic stenosis. So here, these aorta is dilated in that is known as Schmoo sign for the aortic stenosis. In the same way, in the neonate, you can see there is a ground glass. What do you mean ground? It's a hazy. This is a typical ground glass of the critical aortic stenosis with severe LV dysfunction presented. So you can see the aortic stenosis can present without cardiomegaly, but with the more lung feature, and without cardiomegaly with the aortic dilatation. So all things in the same way. It's a stent in the coarctation. Aorta is usually associated with the coarctation. So this is showing the aorta. So whenever the aortic dilatation on X-ray, how you see aortic dilatation? Always on the right side. If you see this prominence, it's a aortic dilatation. So these are the TOF with dilated aortic stenosis, aneurysm, aorta to LV tunnel. So this is the one of the patient with the aorta to LV tunnel to and fro murmur causing a huge aortic dilatation on the X-ray. So once you see the clinically with that, you can easily make a diagnosis because the hugely dilated aorta more suggestive of aneurysm or aorta to LV tunnel. In the same way, this is, you can see, this is the 25-year-old with the rib notching. So rib notching can present in all three conditions: venous obstruction, aortic obstruction, as well as neurofibromatosis. Here, the aorta is dilated, you can see, and this is suggestive of the coarctation and the radiofemoral delay was there. So this is the typical three sign. If you see like that, left heart border, that is typical of the coarctation. So rib notching, three signs, these are typical of the coarctation. So now this we got with the cyanotic. Now cyanotic, if you remember this, any cyanotic with increased cardiac size, only 4 or 5 diagnoses are there. Tricuspid atresia, intact IVS, PS with right to left stent with dysfunction, Epstein's. The cardiac size will be normal. So whenever you see like that, so now we go, this is the VSD, you can see this is the typical of the boot-shaped heart. So what the reason for the boot-shaped heart? I asked so many times of the student, they weren't able to tell. What happened when the boot-shaped heart, the LV is underfilled, RV is more. So it will get uplifted and the septum become more horizontal. So what is the boot shape? Toe upturned, acute angle with the diaphragm, altered development of the LV and the horizontal IV is causing the boot shape because of the clockwise rotation. And in and up, there will be narrow pedicular and this pulmonary bay will be empty. So that causing the boot shape. So boot shape has because of the clockwise rotation, horizontal septum, uplift toe, and the narrow pedicle. That all causes the boot shaped heart, and that is a typical of the top. Sometimes pink top, half feature you will get of the top, but the vascularity is maintained. As compared to top, it will be less dilated. If you see very huge PA and to and fro murmur, so that is typical of the top absent pulmonary. This is the X-ray that shows the typical Mickey Mouse appearance on, and that is a typical of the absent pulmonary wall top. So if you see like this, again with that pulmonary atresia, this is what anybody can tell which syndrome is this. You can see there is a hemivertebrae, there is a rib abnormality, boot shaped dot, and the patchy vascularity means there are only collaterals are there. So that means there is no native pulmonary artery present, but it is all supplied by collateral. So that is typical of vectral, like the hemivertebra, and the top. So the top with the hemivertebrate is the vectral anomaly. So this is a boot shape. Okay. So pleonemia is the term. Pleo means different, differential, nemia means vascularity. So the other term we use, oligemia means decrease, pleonemia means one side vascularity is more, one side is less, or one side is more, one side is oligemia. That is the meaning of the pleonemia. So these are all the various vascularity pattern we'll see. So we'll not go with this. But whenever, just I'll tell you only one thing. Whenever there is an absent RPA, absent right heart border, you can see this is never normal. Either it related to the chest deformity, absent pericardium, or the RA is not there. So when I associate with the complex heart disease, right heart border absent is juxtaposed RA appendage which is associated with the complex heart disease. Chest pectus excavatum, it will compress the heart, so there won't be any right heart border. Or absent pericardium, there won't be any right heart border. So whenever you found out low right heart border is absent or not seen, that is never normal. It associated with either heart disease or with the bony abnormality or absent pericardium. So this I won't go. And this last, whenever it's not associated, like your heart is on left side but stomach on right side, that means it's not correlating with each other. That means always associated with the complex heart disease. So when the situs, you can see the liver is midline, liver is on the right side also, right side, left side also, and the heart is midline and oligemia. That means it's a heterotaxic complex heart disease. So situs solitus dextrocardia, normally situs are associated with levocardia. It's normal, but if other way, it's a complex heart disease. So simple diseases will be ruled out. In the same way, egg on end appearance, we can see the narrow pedicle. That is because of the anteroposterior greater. The absent thymus, anteroposterior greater arterial relation, hypertrophy causes the narrow pedicle. So this is the last, how to assess the arch, because this is, see, this is once you see the arch, there are two ways. Wherever the indentation on the trachea and the paravertebral, you can see one shadow. So this is the descending aorta and that is the arch. If you see these two things, you're able to know the sided. This is the left arch. You can see the indentation on the trachea is on the left side. Here is not clear. It is on the right side. So this is the right side arch. This is the left sided arch. So once you see right heart, these are the association you can able to predict the which are the common disease associated with that. I won't go with this. Again, this is a large heart. Once you large heart, which occupies almost 90% of the chest, there may be Epstein's or organic TR. These are the common or pericardial collection. Okay, this is known as wall-to-wall heart, 100% CTR ratio. The diagnosis neonatal Epstein's, tricuspidal abnormality, tumor, pericardial collection, or thymus. So these are. So this I won't go. This is a typical same. You can see there is a scimitar vein seen in this patient. Okay, this is 5-year-old, 70% saturation. Figure of 8 is a figure of 8 appears only after 6 months of age. It will not present in the neonatal age. This is also normal saturation. It looks like figure of 8, but this turned out to everything is normal. So it's just a thymus which is causing the appearance of the figure of 8. So this I would. So thymus out. Thymus can produce anything. Figure of 8, vessel, tumor. So thymus is a big masquerading which causes the. Once you see this sign is very important because thymus is not into the heart. So you will see the indentation side. So once you see the indentation side, you can easily tell out it's a thymus. It's not the some mass associated with the heart. So these are the various sail sign as well as the wave sign for the thymus. Okay, this I won't go. Now this is the last. See, when I told you there is absent peri. Right heart border is absent or present in both. Right heart border is absent. And you can see there is a Snoopy appearance. The LA appendage become very prominent and there is an area below the heart. So this is the typical appearance of absent pericardium. So once I told you, that's what I do. Whenever right heart border is absent, you have to think of other diagnoses like chest deformity, absent pericardium, or the complex heart disease. Here you can see that normally the ribs will be like curved. But once the ribs become straight like this and causing cardiomegaly and the right heart border is absent, this is typical of pectus excavatum. So these are all comes to us for the cardiomegaly and the cardiac evaluation. So all extra cardiac cause of cardiomegaly, obesity, pregnancy, straight back, pectus excavatum, portable film, expiratory film, thymus, these are the all cause of the cardiomegaly come to us. The last 4-year-old normal heart, you can see the lateral X-ray, there is no bone seen here. So this is the cleft which we repaired with the sternum, one rib we took and put over there. Okay. So what is this relation? What is the fluid status of this patient? See, what is this? What is the relation? This phantom vanishing. So this is known as a minor fissure edema. This is related to the increased fluid volume in the lung. So that means the lung is overloaded. So if you give the Lasix, it will go out. Or if you improve the heart function, that's why it called as a phantom tumor or the vanishing tumor. So this related to the increased pulmonary venous congestion. Sometimes this you can say right heart, right oligemia, left is normal. This is the absent RPA syndrome which causing the severe PH. So utility of allowed with the ICU, just you know this I don't know. See, if you know the periphery in ICU, you can see this child developed RD. We saw the ICD is out. So just with the X-ray, we know the cause of the RD and we adjusted the ICD and the patient improves. In the same way, you can see this last. See, this is one patient. This is very important. That's what I want to add. This one patient come to us for VSD, but there is a hyperinflated right upper zone. Why? So when we did the CT scan, we found out there is a separate entity known as azygous lobe. What is azygous lobe? Normally, azygous will drain into SVC, but sometimes it will take an abnormal course and drain into SVC. So that lobe will be separated from the upper end. This is present in 0.1% population. So that is associated with the hyperinflation, tumor, opacity, increased risk of infection. Same patient after surgery, you can see the right opacity persists. So it took at least 25 days for child to improve, because this is very less ventilated. So this is more chance of having tumor in the future. So azygous lobe is an important phenomena which is present in a normal population, but if you don't know, it can create a problem in that. So this I wouldn't go. Other thing, this child come with the ASD but having a hyperinflated right chest. So we thought why there is a hyperinflation. So we did the CT scan. We found out there is a middle lobe, lobar emphysema of the right middle lobe. So we did the surgery and the child improved. This is the feeding tube. You can see after that went into the bronchus. After the surgery, we checked the first X-ray and then we improved. The same, the external wire was there after 20 days. External wire alignment changed. That means the external got break. So external dehiscence after surgery causing the external wire misarrangement. Okay. So in general, these are, if you see the X-ray, you can see the overall clinical status you have to see. But this is the crux. If any having increased vascularity, no cardiomegaly, MP shadow seen, then ASD, VSD, TAPVC, right heart element, ASD, MP shadow not seen, it's a TGA, irrespective of cyanosis, acyanosis. In the same way, decreased vascularity, cardiac enlargement, Epstein's, organic, tricuspid atresia, LV apex will be tricuspid atresia. Normal vascularity, you have to rule out the obstructive lesion until it is go into the last stage. So with X-ray, what I can tell, although we use the car, but for our health, we need the cycles for everything. Even ECG, X-ray, clinical is still the most important part of examination of treating the patient. Okay. So thanks a lot and sorry for accident.
So, very nice presentation. Because of your this thing, the pace you have gone, I think some of the important points could not be appreciated. Actually, for any chest X-ray to be clear, centering is very important. Just for the information of where the students are here, that is the center of the source of the X-ray should pass through the center of the object and to the center of the plane. So that's very important. And next thing you have to take into consideration of the rotation, because it gives a false information unless it is properly taken. Next is exposure. That is optimal voltage of X-ray should be passed through. Otherwise, hypertonsillicency or more opacification. So these are the pitfalls in the taking of the this thing, chest X-ray. Again, a lot of information. That means we can diagnose some of the congenital disease based on the chest X-ray itself. And one thing you say you have presented on hyperinflation as a cause of aortic or something. No, I just
No, sir.
go back that.
Actually, there is a concept in infantile age. One of the presentation of CCF is hyperinflation. So once you see any VSD or any ASD or any PDA patient in an infant, any patient with a hyperinflated lung, so that is suggestive of CCF. That means the lesion is significant lesion. So hyperinflation is one of the presentation of CCF in an infant, and that reflects into X-ray as a hyperinflated air trapping.
Yeah, how that hyperinflation results in case of CH who express pulmonary edema.
So the concept they given, suppose once the PA are very overloaded, it will compress the nearby bronchus in the bronchopulmonary segment. So if the large shunt is there, there are two reasons. One, they will try to hyperinflate to overcome the large shunt. Second thing, there is a micro compression of the bronchus, trapping of the air in the lung. So that both will present as a hyperinflation. So this usually present in infants only, not in the adults. So that's why in any significant left to right shunt, when the hyperinflation you are seeing on the X-ray, that itself is suggesting that this lesion is significant, means large, moderate to large shunt is there. That is.
If it compresses what you say, the vessel, no, that hyperinflation because of compression of the bronchus, you mentioned.
No, sir. Actually, bronchopulmonary segment, there are three. In the last level of the lung, the pulmonary artery as well as the bronchus go side by side. So whenever any pulmonary artery get dilated, it will compress the nearby. That is known as the micro atelectasis, micro air trapping at the bronchopulmonary segment, last segment. So that will overall in the lung. That's why what we did, one large VSD we operate. This compression will go. The first day if you see X-ray, there will be totally white out. So we thought there increased pulmonary plethora is there, but that is not plethora. The hyperinflation comes down, that is present as a plethora after surgery. So that is the reason given ki bronchopulmonary segment, because of the edema, congestion and the pulmonary artery dilatation, it will compress the nearby bronchus and it causing the overall hyperinflation all over the lung.
Something like obstructive emphysema. Right.
Yes.
Sometimes even dilated left atrium that compresses the left bronchus, lower bronchus, and causes hyperinflation of the left lower. Yes, sir. Not like symmetrical, asymmetric.
Suppose the patient has got some left to right shunt which has caused a pulmonary congestion with a predisposition for respiratory infection. The baby can have hyperinflation because of bronchiolitis, and cardiac problem per se may not be the cause for hyperinflation. It may be a coincidental finding. Just I wanted to put, because what we come across in clinical practice is more often a case of bronchiolitis with some congenital heart. It could be there always. That will be.
Ideally, cardiomegaly, pulmonary edema, and abdominal, usually they go in favor of CHF.
Yes.
But that is the rarest cases where vessel compressing the bronchus causing obstructive emphysema with air trapping. So I think some of the cases it's in like that.
The left bronchus, the concept of left bronchus is hip arterial bronchus and right is hip arterial bronchus. So what is the concept given? The left bronchus go below the pulmonary artery and enter into the lung. So whenever any left to right shunt is there, LA will be enlarged from the down and the pulmonary artery will enlarge from the up, and that will compress the left bronchus. So left bronchus in all large left to right shunt are more prone for blockage because of the hip arterial nature of the bronchus first. Second thing, once the heart is on left side, when the heart dilated, the bronchus which is going below the heart, behind the heart, that also will get compressed. So the concept given ki the left-sided bronchus is more often dilated because of the hip arterial nature of the bronchus and the heart present on the left side which is dilated and which is causing compression on the bronchus. So these are the two reasons given why the left heart, why the left lung is more air trapped in large left to right dilated cardiomyopathy than the right side. These are the reasons given, sir.
Okay, nice presentations. And just one more thing for that. For a good X-ray also, one must see the interspace, the posterior ninth interspace and anterior sixth interspace. So that is ideal for interpretation. Thank you.
Yes, sir. Thank you, sir.
Thank all the chairpersons and the speaker. We are almost at the end of the CME. We just have one last session where we wanted to highlight about the neonatal PDA closure for preterm infants who are not responding to medical management using Piccolo, which is a relatively recent advancement in PDA management. So we all know that PDA responds to medications like cyclooxygenase inhibitors in preterm infants. But whenever we have failed PDA closure with medical management, earlier the only treatment used to be a PDA surgical ligation. Now our pediatric cardiologists are able to do device closure of PDA even in the smallest of small babies. And I'm sure Dr. Bhargavi also is managing such babies in her unit. And we wanted to share our experience with neonatal PDA device closure using this Piccolo device. And Dr. Sudeep will be sharing this very briefly along with Dr. Bhavani Deepthi, who is our consultant neonatologist at KIMS Gachibowli. So I request all the chairpersons to stay on to chair this last session, and we'll be winding up post this. Replace this one.
Slideshow. Slideshow.
Yeah. Good evening, everyone. Pediatrician at KIMS Gachibowli. I know I am standing in between you and the dinner probably. So I'll just do a quick rush through a very short presentation. So I'm not going to cover the 97 days of this baby, but just the 25 days of the baby till the baby required device closure. Okay. So this was a mitral 25 weeks, 5 days to a G2A1 mother who presented with discharge PV. She was, had a registry of PP 5 days. This mother was taken care of in the hospital by covering antinetal steroids with the antibiotics, and magnesium sulfate even was covered for this particular case. So in view of maternal fever spikes after 5 days of antibiotic course with fetal tachycardia, baby was taken up for emergency LSES. So this was a baby 680 grams, delivered by emergency LSES, who was relatively vigorous. However, he had severe RD, for which baby was intubated with surfactant. He was with relatively settings. He took 2 doses of surfactant in view of high requirement of MAPS and FiO2. The concern we had with this child was the presence of PDA starting from second day of life within 48 hours. The initial PDA was around 2.4 with chamber dilatation, with a continuous murmur, with a systolic murmur, and wide pulse pressure with hypotension. So we went to start with paracetamol in this particular case. We received almost 3 medical closures, 2 courses of paracetamol and 1 course of ibuprofen. After the failed medical management, device closure was planned. So in this particular case, apart from the 2 challenges of pulmonary overcirculation and systemic hypoperfusion, there was another challenge we had. The problem with financial resources, the device closure had to be postponed for around 5 to 7 days because the father wasn't ready, because it's a 25 weeks with a 600 grams baby. So after the initial medical management and the stage was set up, the team was informed, Sudeep sir was informed, and everyone was informed for piccolo device closure in that baby. Just 2 days before the procedure, management for the procedure, we went in disclosure. It was done on day 6, and he successfully extubated after 2 days after the procedure. Bronchopulmonary dysplasia, and he required oxygen for the of course, a course of steroid was given. Couldn't complete the regimen, was completely fine, and it was partly complicated by sepsis, also PPR and serraceous sepsis. However, he never landed a septic shock, and this is about him. Just a very brief short course why he required device closure. So another complication he had was which required just a few weeks before discharge. For now, his visual fine. He's around 2 months now. He's at 5 kgs. So far, so good. So over to the pediatric cardiologist now. So he happens to be the tiniest and first one to survive after the device closure in the country called PICO data. There were closures done even for also, but this one happens to be the tiniest to survive till date in the country. So thanks to Sudeep sir and the whole KIMS team. Of course, we are grateful. The name of the child is Izan.
Congratulations, Dr. Bhavani.
Thank you.
So my questions as a pediatric cardiology to neonatologist. So you are the persons to tell us when we have to do. We are like only plumbing. We will come and keep the device. Okay. So main things are the indication. So this case definitely, I also know this case.
Yes, yes.
Definitely.
Ma'am also helped me actually.
So it's definitely indicated. But should we go for the 2 courses of paracetamol, ibuprofen, then we have to take, here the challenge is weight. It is 600 grammer. So same case, if it is a 901 kg, having all the features of systemic hypoperfusion, pulmonary overcirculation, after the course of PCM twice. So what is your, I'm asking neonatology perspective, you want to go for the closure of the PDA, or you want to go and wait for some time, or go for the ibuprofen?
Ma'am, ibuprofen in certain cases, exactly in this particular case, he had cytopenia. Of course, he was maintaining 1 lakh. At that point, we weren't very comfortable with ibuprofen. And also he had signs of systemic hypertension like feed intolerance. In that particular 2 cases, prompted us to prefer paracetamol over ibuprofen or indomethacin. So even after 2 courses of paracetamol, then his platelet counts were stabilized. Then we went ahead to ibuprofen because even the father wasn't sure, should he continue? Should he really go ahead with such a big procedure? So at that bridging time is when we actually could give, and then also was relatively stable. However, keeping this particular case aside, in case after 2 courses, it's better to go ahead because probably the PDA would be flooding the lungs, and this child eventually landed in BPD. Of course, BPD or death is also a contributor to further morbidity or mortality. It would be it would be a necessity at that point to go ahead and do a device closure if the hemodynamic stability is relatively established.
Very nice as a neonatologist, I would say, to pediatric cardiologist. So you're telling after 2 courses. Because why I'm asking this one, the chance of bronchopulmonary dysplasia will be more if we are waiting. We have to wait for 4 weeks, 6 weeks, keeping the baby on ventilation. That is the reason I'm raising this point. Actually, after 2 courses, wait is better and everything clinically, means transport team, neonatology, cardiologist, everybody are thinking it's better to close the PDA.
Yes.
That is what I want to say.
Yes, yes. I agree with you. There's no delay. The 5 days or 1 week delay here is because yeah.
Till now we have done 26 piccolo devices. Our smallest is 680 grammer. So our experience, so initially there was so much resistance. I would say 4 years back there was so much resistance. We say piccolo is there, we will close. Everybody used to say we will wait another 2 weeks, 4 weeks, 6 weeks. But now after 2 courses of paracetamol or 1 course of ibuprofen, if their systemic hypoperfusion is there, over circulation, we are going ahead, and everybody from whole Hyderabad, I would say, neonatology team, everybody are in sync, and we are closing with the piccolo device. Here, the importance is when we are closing, we are able to extubate early. Our mean extubation time in the 26 cases is around 36 to 48 hours. We are extubating the child coming out of the oxygenation. And recently only I saw one of the baby. I have completely forgotten. He's now 4 years old. Father was coming and told, my baby is 900 grammer when you have done the device. So their growth is good, development is good, neurological, and bronchopulmonary dysplasia is very less. So that's what I want to say. And we don't have any pneumothorax issues will not be there. So these are the things. But every time it's a first is surgery only, gold standard. But the next is the piccolo device. But keeping all the complications involved, hypertension when we close with the surgery, with the device it will not be there. So that is
Maybe the size of the PDA matters.
PDA
Right? If it is too large, then there is no chance for the piccolo.
for surgery only, too large. That's all.
Thank you, Aparna ma'am and the whole team for giving this opportunity. Thank you, Dr. Bhavani. So we'll close the session with this, and I'm going to request Anil sir for giving away the last round of mementos to the chairpersons and the last speaker. So we'll start with Dr. Bhavani, neonatologist at KIMS, Gachibowli Ranch. Thank you, Bhavani, for sharing your experience with one of the smallest babies who has had PDA device closure. And thanks also to our chairpersons, Dr. Bhargavi, pediatric cardiologist, Rainbow Hospital. Dr. K.V. Subbarao, sir. Currently Professor of Pediatrics at ESA Medical College. And Dr. Chakrapani, sir,
who's a busy pediatrician at Sangareddy. I'd also like to thank the students who presented cases. Dr. Shruti, if you could come up to the stage and please take your memento also from Dr. Anil Dharma. And is Dr. Rakshita here? Thank you, Rakshita, for taking the case. Unfortunately, we could not discuss her case for want of time. So Dr. Shruti, she is DNB Neonatology with KIMS Cuddles team. And Dr. Rakshita, her DNB Pediatrics PG. Last but definitely not the least, I'm going to request Anil sir to give away the mementos to our team, starting from Dr. Arvinda, Dr. Nandiala Vishwanath, and Dr. Amit, who had to leave. Dr. Sindura is busy in the unit. So please come in, Arvinda and Vishwanath. Please give them a round of applause for all their efforts. Dr. Vishwanath. So now, before we wind up, let me request all those of us who are left to please come on to the stage for a group picture. And before we wind up, it's also my duty to thank all our team who helped us in organization, Dr. Sudhir, our medical director, Dr. Sudhakar, of course, the clinical team, Dr. Sudeep, who had to just run to see a patient. He helped us in designing the program. All the speakers who joined us today, the operations team, Dr. Rohini, marketing team, the IT, and cameramen. Sir, one group picture before we leave. So please join us on the stage for a picture. And thank you all, the last few of you who could stay on till the end. Please join us on the stage for a final group picture. Call your team. Shrikant. Kiran. Kitna are you ready? Kiran. Come on. Kiran, come on. Everyone from KIMS team, please can join us on stage. Bharat, Vinay.
Okay, I'll come sit you. Yeah, yes, 5 members mistaken.
Good meeting you. I always speak here.